intradiscal access. So for those of you, this is intradiscal regenerative therapy. What this really is intradiscal access. So I'm going to ask for a little bit of vicarious audience participation. So how many of you guys, by show of hands, are doing intradiscal work, discography, intradiscal injections, intradiscal hydrogel cells, anything like that? Show of hands. Okay, so I count.
One hand, in case you couldn't see.
Yeah, exactly, I count one hand.
Yes, sir.
So cells, gels, cross-linking nanotethers, oligonucleotide decoys, gene therapy, all of this stuff is going to be done through and into the disc via a transcameron approach. And you can take that transcameron approach and you can also do larger things. I mean, there are percutaneous fusions done through the transcameron approach. And this is also known as the discogram approach. So what I'm going to show you today is the approach for ViaDisc NP. ViaDisc NP has Medicare reimbursement in 2 out of the 7 MACs. And fortunately, my MAC, my local Novitas Medicare Administrative Contracting unit, is one of the ones that does reimburse. And for discogenic back pain, I consider this essential. So you think about patients that have discogenic back pain, they'll be primarily 25 to 45, or maybe even younger. I've had people that wait till their 18th birthday to enroll in one of our regenerative trials. And so the people, let's say age of 25 to 35 that have back pain, all of them essentially will be discogenic back pain. And really the only treatment for discogenic back pain, short of fusion, is something regenerative. So I'm going to show you today ViaDisc NP. And so we have a 20 gauge needle here. You can tell by the yellow color. I put a little slight bend in this, coincident with the bevel, just to be able to steer. The bevel goes this direction here. And so I made the bend coincident with the bevel that steers opposite the notch. So the notch is here, and it will steer opposite the notch. So we're going to go about, let's arc towards you, about 30 degrees there. And so we're just going to pick a level at random here, and we're going to do, go ahead and shoot. Okay. Picture. So it looks like we're going to go at the 3-4 level. Picture again. I'm going to start right here just in front of the superior articular process. And this is, we want to have the superior articular process of the level of interest where we're going to bisect anywhere from 1/3 to 1/2 of the vertebral body width above it. And so, shoot, please. And so we're going to aim just anterior to the superior articular process. And really what I like to do is we're going to come down and we're going to advance the needle, picture. And we're going to contact the SAPs, superior articular process, picture. And we're going to do so, and that gives us a depth measurement without having to go lateral, picture. And we're going to progressively come down, and I can feel the SAP right there, and we see where the needle position is. And then I'm going to, because I have put a bend in this needle, I'm going to back it up a few millimeters. I'm going to turn it 180 degrees. I'm going to advance it a little bit, shoot that. And you can see we're going around the superior articular process. And once we've gone around, I will turn the notch away from me again, bring the needle tip coming back toward us, picture. And at this point in time, we're going to go lateral and see where we are. So this is intradiscal access through Camden's triangle, named after Parviz Camden, who was an endoscopic surgeon and developed this for intradiscal approach for discectomy. So drop it down or table up. Yeah. Down a bit more. Okay. Good. Very nice. So we're a little bit off on the wig-wag picture. And so we'll see the needle coming into the disc. And we place it right in the center of the disc. So picture that. So that looks pretty good. We're a little bit off on the end plate, a level above. We have a little bit of scoliosis, but that is right in the center of the disc. Let's come back and take an AP shot very quickly. And while we're moving to take the AP to ensure we're in the middle of the disc, I'll demonstrate that this is Viadisc NP. And in this container, it won't be visible on camera, but in the container, we have micronized disc material. And this is disc material that's micronized, the white disc material down here, that's micronized to 100 microns. This has been reduced in size from 300 microns to make it more flowable. So what I'm going to do is I've taken 2 cc's of sterile normal saline, and I'm going to inject it into the container. The container has rotating gears on it, as you can see, and we'll take this and we'll just mix it. And we'll just mix this whole container. It's mixing the micronized disc material. Viadisc NP is micronized disc material. This is cadaver-based. It comes from the tissue bank, and so this is tested for everything in a tissue bank that is tested for, including all cadaver donor parts, bone, kidneys, heart, tested for all sorts of disease. And this is, I'm going to abbreviate this. Once you mix this for a minute, then I'm going to aspirate it back into the acrylic syringe. And it comes out with just slightly over 2 cc's of material. And this is exactly what it looks like. It looks cloudy, and this is micronized disc material mixed with normal saline. And this is an acrylic syringe to be able to deliver pressure to be able to put this in. So I'm going to disconnect this. Typically, we let this stand for about 5 minutes before we inject it, and it injects into something akin to a thin paste. But before we re-inject it, let's take an AP shot there and see where we are. So we're right smack dab in the middle of the disc, which is exactly where we want to be. So let's go lateral, please. Remember, the nucleus pulposus is present in the center third of the disc, and the inner annulus and the nucleus pulposus occupies about the inner 2/3 of the disc. So I want to take a shot here. Let's drop it down just a smidge. I want to take a pre and post. Drop it down just a little bit more, if you would. So I want to get the vertebral body, because whenever we inject this in, you get an expansion of the disc. So take this out. We'll inject the material, micronized disc material. I'm going to resuspend this, and then we'll inject it. And if you get a little plug, I'll clear it again with the stylet. Sometimes these micronized disc materials will give you a little plug in there. That's kind of the nature of injecting a semi-particulate or particulate in there. All right, let's shoot it again. So I think you could probably see the before and after the plumping up of the disc and the increasing of the disc height. And after this stylet goes back in, and this comes out. And that is it for the intradiscal access. This is going to be important for virtually everything we do with the disc. So we have products, regenerative products coming down the pike from Vivex. So Viadisc is going down the BLA pathway. This is Viadisc NP. This is, we're able to use this in 2 out of the 7 MACs, as I mentioned. We have Discgenics coming out with their Rebone Aputum cell. We have Mesoblast coming out with their Rexlemestrocel. They're in the phase 3B, the second phase 3 trial. We have Intralink that's going to go into testing for original, there's a first-in-man trial that's been completed. The next step is going to be a pivotal trial. So we have at least combination regenerative products. We're currently testing a hydrogel product called Hydrofill, and this is in the pivotal trial now, this ongoing in the U.S. So all of these products are something you're going to have to be able to do a transcameron approach, an intradiscal approach to be able to access the disc, to be able to deliver the material, whatever it is, whether it's a biologic or other biomaterial. And right now, let's just open it up for questions and comments.
Doug, that was great. This is Chad. We kind of highlighted at the beginning that not many fellows have experience with intradiscal access. Just curious, the fellows that go through your program, how many discographies would you say they graduate with, and how many intradiscal injections would you say they graduate with?
My current fellow, he'll probably do over 1,500 by the time he finishes.
Okay, so that's the standard. No, that's not the standard. That's the extreme. But the point is, there are certain things going on right now in medicine, especially pain medicine, that are hot and sexy. The intradisc space is beyond hot and sexy. If you go to Aspen this summer, if you go to other society meetings, you're going to see a lot of these things that Doug has brought to light today are going to be very hot on the injection list, because what we're trying to do is we're trying to find out, there's a whole bunch of different people around the country injecting amniotic products, other PRP products. There's guys in East Texas have their own little concoction. Everybody's trying to find that perfect soup, aren't they, Doug?
Yes.
That's going to not only correct either a disc herniation, like you related, the enzyme products are coming out that we're both aware of, and or cause height restoration and strength restoration to the disc. And so I think it's going to be critical, and it's not a complicated thing. Don't be worried about it at all. Just a few steps in getting access to the Camden's triangle, like he said. So make sure that you make that part of your training, because your groups you join, your orthopedic partners and your neurosurgery partners, they're going to be expecting you to be able to do a discogram, at least lumbar, possibly cervical, and they're probably going to be expecting you to be able to get access to a disc to deposit material. Would you agree with that, Doug?
Absolutely. You mentioned the chemonucleolytic. So we have Condoliase that will be approved sometime, hopefully this summer or fall, for use, and that's for use with lumbar disc herniations. And then ozone, starting a clinical trial this next year for ozone. So a lot of this stuff is coming down fast and furious. It's not only regenerative, it's not only biomaterials, it's not only hydrogels, all the rest of the Intralink is a cross-linking oligomer that polymerizes and links to the amine portion of the type 2 collagen. So this is like a facelift for a disc. So there's lots of things, and the only thing they have in common is be able to access the disc. And this is done, keep in mind that Camden developed this to be able to put a scope into the disc, and the fusions are done transcambon. It's called an OLLIF. And so this is, you can stick large things through there, 8, 10 millimeters even. So the intradiscal access with a 20 gauge needle, even an 18 gauge needle is really nothing.
Great, yeah. Keep your eyes out for Condoliase, like Doug talked about. I presented at the Pittsburgh Spine Summit last year. I was the only pain doctor in the entire place telling surgeons that these procedures will decrease the amount of surgeries you do. I was thrown off stage, kicked out, and not invited to dinner that night. But the other thing, the Interlink, that's huge. That's going to be, when that comes through at the FDA clearance, that's going to be a huge product for you to look at. Are there any, yeah?
When you access to this, you do anything extra, like antibiotics or anything to prevent ascites?
Excellent question. Yes, definitely. So the antibiotic cocktail that we use and that pretty much has been popularized for general use is 1 gram of Ancef or 2 based on weight, combined with 80 milligrams of gentamicin. If somebody's allergic to penicillin or some of the first two, and by the way, we use gent because it actually penetrates into the disc. If somebody's allergic to this, then we use clindamycin, 600 milligrams. If somebody's allergic to any of this, then we use 1 to 3 grams of vancomycin based on weight. IV, peri-procedure, every time. And parenthetically, you know, I just got back from ASIP, and we had questions on discitis, and it is, I think discitis is way, way overemphasized. You know, I can say that in the clinical trials I talked about, the materials I've talked about, there's been a grand total of one infection in the hundreds, if not over 1,000 intradiscal procedures. That was in a case where the practitioner did not use IV antibiotics. And I've got the Malcolm Gladwell's 10,000 hours of injecting discs. I've not seen one case. I've not knowingly had a single case of discitis. So I think this is incredibly overemphasized. This procedure is exceedingly safe.
Thanks, Doug. As a last thought on that, is there or is there not a kind of a pseudo discitis or pseudo infectious look after the injection of ViDisc?
That's a great question, Chad. As you know, Arnold Kaplan used to declare the cells MSCs, or medicinal signaling cells, or stem cells, whatever he wants to call them at the time. He used to say these were immunoprivileged, meaning you inject these cells into a foreign milieu and nothing happens. And then when he started to recognize that maybe something does happen, we'll call this instead of immunoprivileged, they'll be immunoevasive. And so they're more difficult. But sometimes whenever the immunology police catches up with the cells that are foreign, sometimes they'll try to employ the macrophages to take them away. And it will create a situation when injected into the disc that looks like discitis. There'll be lots of inflammatory changes from this immunologic response. There'll be in-plate erosions, and it will look just like a discitis, but the characteristics, instead of having a high SED rate, high CRP, they'll be normal or only very slightly elevated. So whenever we saw this, I couldn't really quite figure this out. It didn't really look like a disc. It looked like a discitis visually, anatomically, but the laboratory values had nothing. We biopsied it, cultured it. There was even a disc removed, and it was aseptic, no evidence at all of a bacterial or other infection. And so this immunologic flare is something that does happen. You have to be able to recognize, and the way that you recognize is once you put in a biomaterial, and this has happened with 6 or 7 different materials. It's not just one. It can happen with any type of material, fibrant sealant, OP1, GDRF5, different biomaterials. So it looks like a discitis, but the patient, it doesn't hurt as much, isn't nearly as sick as they are with the discitis, and the SED rate and C-reactive protein are normal or only slightly elevated.
That was amazing. I hope you guys got all that. I'm going to move one question in a second, but what I want to highlight there, and Doug, you may disagree or agree, but it is best if you work with a group of radiologists consistently to give them a heads up that this might be something they will see, because occasionally they will call it a discitis or a probable infected disc, and you may want, clinical follow-up, whatever. And so I like to work with the same radiology group, let them know that when I do, when I send somebody that's had an intradiscal procedure, if you see something you're really worried about, call it. If it looks like something subtle, maybe don't over-highlight it.
Absolutely. They also will call discitis in a very degenerated disc that has reactive fluid in it that has not been had a procedure on it at all. It's a very degenerated disc. So there is an overlap between discitis, severe disc degeneration, and certainly an overlap between whenever we start injecting fluids and having immunologic reactions and other things with the disc. So it's the same principle as the radiologist needing to mention modic changes, right, and not all of them do. In fact, a full third of them, we did a study on this, a full third of them don't mention modic changes at all. And the ones that do, even they're spotty when they do mention it, when they don't. So this is one of the things that you really have to have communication with your radiologist to make sure that they call modic changes, that not everything with increased signal on T2 in the disc is a discitis, and not every basivertebral nerve ablation are metastases lined up perfectly at the terminus of the BVN. So they don't need to be calling METs whenever it's really a BVN ablation zone.
Yeah, that's true. As pain doctors, we are not geared or excited about handling complications as much as some of our surgical colleagues may be, and they talk about them very openly. So I just want to not make you afraid of the changes you'll see radiographically after you do a ViDisc or interdiscal procedure. So thank you, Doug. I think we will take a quick question, and then we got to move on to the next topic. So There was a hand in the back.
Are there any radiologic changes, difference between a pseudo-discitis that you mentioned and versus a true discitis?
No, they look the same. So it's difficult. They're both immunologic reactions. So one is to try to rid the body of the bacteria. The other one is rid the body of whatever the foreign material that was injected. And again, it's not necessarily cellular material, because we've seen this with fibrin sealant, some of the other biologics that are acellular as well. So there's enough overlap so you cannot reliably tell the difference.
CBC, CRP, C-reactive protein, yes.
So how long after the procedure you will see the pseudodiscitis finding on imaging?
Could you repeat that question, Chad?
How long after the procedure will you see the findings of the pseudodiscitis on the imaging?
That's another component too. If you have a discitis, that will typically appear about 60 days afterwards, right? You have a delayed appearance. This happens sooner, within the first week or two. So that's the temporal relationship is another indicator that that this can happen. And we're talking literally, I've seen this, I think, 3 out of 1,000.
Yeah.
I mean, so this is pretty unusual.
Yep.
And but just know that everything that looks like discitis is not a discitis, especially when the inflammatory measurements, the CRP and SED rate are normal or only slightly elevated, and it happens more quickly. It happens a lot faster than a post-injection discitis.
Excellent point. Last question on this topic in the back.
Clinically, who's the ideal candidate?
Clinically, the ideal candidate, you mentioned earlier when you were talking about it, like the younger people, the 35 to 45 or 55 in that range, what would you say as far as ideal?
Yeah, so Chad, is the question, what do I say in terms of age range and Viadisc, or?
The presentation, clinical presentations for patients.
Pre-exam,
Yeah, with discogenic back pain?
Yeah.
Yeah, so everybody, essentially almost all young patients with back pain are discogenic, right? You're not going to have a 25-year-old with facet arthrosis causing back pain minus some preceding trauma of some kind. So all of these are going to be discogenic. And so for discogenic back pain, pain with bending forward, pain with axial loading plus a little bit of twisting, pain with sustained hip flexion, pelvic rock test, the two most sensitive physical examination signs. You know, I've heard patients say, well, you know, back pain is difficult. Well, if you look at work that Mike DePalma did, if you have pain with sitting and pain with positive sustained hip flexion test, if you have findings on the MRI that show a degenerated disc, you've got literally 94% positive predictive value that degenerated disc is one causing pain. So this is something that is not only recognizable, it's really reproducible. You can see patients, you know what to expect. A young person, difficulty sitting, riding in the car. I mean, it's anterior column pain, period. And then you use the MRI to figure out what it looks like. Are there modic changes? Are there not modic changes? And for discogenic pain is pain of the disc with degeneration not associated with modic changes. Vertebrogenic back pain, it has associated modic changes, but for treatment, you reserve, it's about 15% of patients that have treatment with modic changes, the pain with modic changes, that's treated with basivertebral nerve ablation. The Viadisc NP that I just demonstrated, doesn't matter whether patients have modic changes or not, it works about the same. So you can use it with or without any type of anterior column pain. Modified Fearman grades 3 through 7. 3 is just barely showing disc degeneration. Fearman grade goes to 8. 8 is completely collapsed, disc dust, and it can be used up to 7 that's not completely collapsed. So you have a wide span of patients that you can use this in.
Yeah, Doug doesn't know very much about this topic. We're going to move on to the next topic, guys. We can pull them aside in a minute, but I don't want to get too far behind.
Thanks, Jim.
The next topic is going to be PNS. I'll say that slower, PNS. The topic was given to me earlier this week, and so I want to just kind of throw out some thoughts. I didn't put together a slide deck, but I want to talk to you a little bit about the reasons for doing it, the efficacy of it, the safety, all those kind of things. So when it comes down to it, this is an FDA-cleared procedure that is a non-invasive or minimally invasive neuromodulation therapy that targets specific nerves. And so you can imagine that there's a lot of pain conditions out there that are tied to a specific nerve. So what kind of indications do we have? I think the number one indication in my practice is probably complex regional pain syndrome. We get a lot of those referrals for the wrist and hand, for the foot and ankle. home run. People that have had post-surgical changes like total knee arthroplasty, people like that. What about that stubborn hip pain that people cannot quite figure out exactly where it's coming from? It's kind of on the posterior hip, kind of over the iliac crest, maybe going the lateral hip a little bit. That cluneal nerve distribution, superior cluneal nerve distribution. Those are very good indications of this. And when you have a true cluneal neuropathy, nothing else I found works, except for maybe a block and it's temporary. What about patients that have problems with the headaches and the craniofacial problems? Those are also good indications. What about the tibial nerve, the sural nerve? Some of my best results are on people that have cubital tunnel syndrome. I have a guy coming up that I'm gonna do in a couple weeks that has bilateral cubital tunnel and he has peripheral neuropathy. So I'm gonna put a stimulator in his back to cover his back and legs. He unfortunately was in a coma as a result of a pancreatic necrosing pancreatitis, and now he's got peripheral neuropathy like at the wazoo. So I'm going to do peripheral stim here, spinal stim for the legs and feet. So those are good indications. What about patients that are not responding well to pain medications, right? We've talked about gabapentin, we talked about Lyrica, all these other medications. What do you do after that for peripheral neuropathy? There's a whole lot of people in my area who advertise in the newspaper a lot, which is the #1 sign that you should be careful about all these cures they have for neuropathy, which basically comes down to lasers and all those other things. And our patients have tried everything. And so by the time they get to us with peripheral neuropathy, they've already been gabapentin on Lyrica, probably narcotic. They've probably been to some chiropractor. No offense, chiropractors are good people, but sometimes they offer some things that may be a little out there. And so they've tried all these things, and they come to you and they're looking for another answer. And so I've had a really good success rate with those. There's some clinical outcome studies that show reduction in pain up to 70 to 80%, improvements in sleep, mobility, functional living, reduced reliance on opiates, just like with any kind of stimulator. And the nice thing is that the patients are very satisfied and they're kind of involved in their own care. So instead of reaching for that pill, in most instances, we have Nalu here, and there's other companies out there that have other devices that have to be applied to use the device, but it doesn't involve implanting a battery, which is nice. So when it comes to the safety of these placements, there are very few things you're going to do today or in your practices that are less difficult. I don't want to say easy because you're not supposed to say that, but less difficult because all you're really having to do a trial is place a lead along a nerve. So first step, decide what nerve you're trying to affect, right? If I want to affect the tibial nerve, I'm going to put in my code for a mononeuropathy of the tibial nerve, and I'm going to go and put a lead right along the tibial nerve to affect foot and ankle pain. If I'm trying to affect the ulnar nerve, I name that nerve. If it's the superior cluneal nerve for the lateral hip, I'm going to name that nerve. If it's the SI joint, the middle cluneal nerve does a good job of covering that. We'll get into SI joint later with fusions and everything, but there's not a lot you can do with SI long-term anymore, and so this is another option for that. There's minimal damage to the tissue. We're talking about little small tissue punctures for the trial, tinting of the skin, putting it along the nerve. These are done either with ultrasound guidance or fluoroscopy, depending on the person you're doing it with and their skill set. Real low complication rates. When it comes to spinal cord stimulators, I was talking to a patient today, and this may be the first I've ever heard of this, but they got an epidural hematoma when somebody was removing the leads. During the procedure, not anytime during the trial. They came to the office, they pulled the leads out, and they got an epidural hematoma, and they subsequently had to have an evacuation surgically, a big scar. I was like, holy cow. Made me think twice about how hard I pull those leads out, right? If it feels a little tension, you don't want to yank on it, you want to give it just a little, that's just a little Stevensism, but there's no chance if you're not putting anything in the spine of having an epidural hematoma. What's the #1 infectious problem with spinal cord stimulators we put in? It's the battery pocket infectious. Well, these don't have a battery pocket to speak of that degree to get infected. So we're not worried about getting, if we're not placing in the spine, we're not worried about getting CSF leaks, we're not worried about hematomas. Really the risk is very low. This has been covered by lots of different insurances. It's getting more and more approval. We're seeing that some of these are done for patients that can't get approval for a spinal cord stimulator. But when it comes in to the person who comes in and they say, my back, and then I hurt all the way down my legs, I'm going to probably put a spinal cord stimulator in there. But if they come in and say, man, below my knees, really just about halfway down my tibia, down to my foot, I have this paresthesia, I have this pain I can't deal with, that's a person I'm probably gonna talk about doing a peripheral stim on. So as you're thinking about how do you differentiate your practice from other pain docs, we talked about this last night, kind of the Alaska practice. One of the ways to differentiate your practice from other people, and I'm gonna talk about this a lot today, and I'm gonna talk about with hydrocision also, is do things that the other people in the area don't do, right? I showed you the radio frequency ablation. Everybody on my boulevard does that. Everybody does. And maybe I do hips, knees, and shoulders that they don't do, but everybody does the axial skeleton, but that's how I differentiate myself. Another thing you can use to differentiate yourself is to do the extremities with the stimulators. Another thing you can do to differentiate yourself is to do the tendon procedures we're gonna talk about later. So this has been a real good way for me to attract extremity patients from like podiatry cases that went bad. This has been a good way for me to attract the hand surgeons to refer me people on hand cases that went bad. CRPS, again, is a fantastic way to help patients out. Think about being a podiatrist or orthopedic surgeon who did a surgery exactly right. They did it step by step, exactly like they're supposed to, and the patient develops CRPS. They send that person to you, and because they are out of things to try, and you put a little lead in them, and they come back to that surgeon, they say, man, all it took was that referral to that pain doctor. They put a lead in, and my pain is gone. That is a great way for you to build practices in between other specialties. And what we're gonna talk about a lot today is how do you integrate, we spent time last night with a spine surgeon. Yes, they're people too. And so we can get along with each other, we can collaborate, work together. So I think this is another great way to get involved. There's some emerging other options. There's a lot going on in the urgency and incontinence world. I don't know, is Nalu diving into any of that at all? Not yet. I heard about a little dime-shaped thing that you can place into the extremity and get urinary continence help with. I haven't seen that personally yet. There's some thoughts about sleep apnea, asthma, stroke. There's different things they're looking into. There's two kinds of differentiating companies, though, I want to kind of put out there. One is Nalu and Curonics, which I'm going to define as direct electrical stimulation of a named nerve. In other words, like a long-term treatment. And then there's another company that I would mention called Sprint. And Sprint is a 60-day placement of the device, getting a temporary stimulation and getting longer-term stimulation thereafter. So when you have a patient that you want to do something for a peripheral stimulator approach, think about what your goals are. Are they long-term? Are they short-term? Do you want to go for maybe just, if you think you can just turn off that CRPS and they'll be fine, maybe the short-term option works. But if you have a patient that you think is going to need long-term care, I think going with one of the more direct approaches like the Nalu or the now named Curonics company is better. There's a whole bunch of products being developed by Medtronic, Boston Sci, Abbott, Nevro, Saluda, Biotronic. So there's going to be a lot of options, just like there's a lot of SI fusion options we're going to talk about. So your job is to figure out what is the one you feel is the best for your patients, what has the best reproducible results, what can you place accurately and effectively, and with the most minimal amount of complications. So we do have Nalu here to present their product. Each of these products does, like I said, have an external device that's involved that as a patient has to work with you to be able to get the stimulation they're looking for, but it's a lot less invasive to most people than putting a battery into their back. So something to keep in mind. They're basically, when it comes down to it, it's a frequency-based, current-based treatment to a painful area that is going to affect that specific nerve. And there's some people out there that are advocating and promoting doing like field stimulation, and that's not what I'm talking about here today. I'm talking about having a nerve, naming the nerve, and going and stimulating the nerve. And I will, with that, leave this for any questions you might have. I just wanted to do a quick overview of the peripheral nerve products. I do believe, just like the disc is hot, I believe peripheral nerve stimulators are getting very hot right now as well. And the reason is patients are asking for these. They're asking for a less invasive approach for their chronic pain that's not taking a pill or a patch. What do you want to say?
Just a comment about coding, because the coding just finished up. The CPT advisor just finished up last week. So it comes down to one part or two part. What Dr. Siebens was mentioning is the difference between Curonics, Nalu, and then SPR, Bioness, some of the other ones. That's a one-part system. And anytime you have a receiver or a battery, that's a two-part system. I say that because the codes are different for each.
right.
You can be used, these can be used similarly, but the one-part systems are temporary systems. They can be placed for a certain period of time and then removed. The two-parters are typically, these are general terms because there's more than just this. There's gastric stem and bladder stimulation, stuff that we don't really get into a lot, some. But the two-part systems are a different separate code. So and these are designed to be placed permanently.
So the code for the two parts are 64555, correct, Doug?
Yes.
And then what's the code for the one part?
So I don't know off the top of my head. I don't really use one part.
Okay, me either.
So,
Okay,
yeah.
so I guess we both use two parts. Any other questions from the audience? Yes.
So with this as well as the intradiscal therapy, I'm very excited about both. Real trouble getting it approved by insurers, obviously. So is some of this, just restricted to that Medicare population, Medicare A and B, or is it more for cash pay? How do you guys integrate this in your practice?
I think you kind of, there's a trick when a disruptive technology comes to the space. What you want to do is you want to get a lot of different requests for that code going to the insurance providers, going to the Medicare providers, depending on your communities you live in. And so we always recommend going through those. I will tell you in my area, like United Healthcare has been a no-go for me from the start, but Blue Cross has been pretty reliably going through. Medicare, of course, goes through. Cigna, Aetna, kind of hit and miss. But you may have to do some peer-to-peers for this. But I think you can easily take some of the terms I just told you and some of the recommendations to have talking points during those peer-to-peer calls. I think it's getting more and more accepted. For sure in Texas, it's getting more accepted by all the carriers other than United. What about Oklahoma?
Yeah, so just, pursuant to what you're talking about, intradiscal stuff. So these things get a category 3 code. I'm going to address this in a talk later. Then you get a category 1 code. This is Medicare, and it's usually adopted by all the 7 MACs, and they're independent, but they have some differences. They are each independent MACs. Then you start lobbying the commercials for payment. The commercial insurances, typically you'll start with some of the bigger ones, United Healthcare, the Blue Cross. And you can think of basivertebral nerve ablation as something. So the category 1 code was developed quite a while ago. It was reimbursed, and then sequentially, we start getting commercial reimbursements. Had a call last Tuesday with Blue Cross, Blue Shield, HCSC, which encompasses parts of Oklahoma, Texas, Illinois. It's a big carrier. So they're one of the 15% holdouts, and then you collect evidence and you use the evidence to your advantage to get them to pay for it. And here's an example of it. So basivertebral nerve ablation is at the end of this. And these other devices, intradiscal, augmentation, cellular therapy, that's at the very beginning of this. PNS is kind of in the middle. And so my closing pitch to Blue Cross is, as compared to fusion, which is the only viable option, basivertebral nerve ablation is 2.5 times better, it's 5 times cheaper, there's no incision, there's no downstream adjacent segment disease requiring additional surgery, there's little to no recovery, and there's no reason to do fusion before you would do this. And that's a pretty good pitch, I think. But we know that based on the data that we collected, and so we'll continue to collect the data from PNS, intradiscal substances, and we'll try to do the right thing and make the case. And if we do the right thing and it really is beneficial for the patient, the data will reflect that and the commercial coverage will follow.
I do think your cash pay idea, though, is something to keep in mind. Almost everything I do, I have a cash pay price for. And you might think to yourself, this is a lot of money, and I don't even want to throw it out there. But what I have found is the patients that are desperate or looking for something that they've not been offered before, they will find the money if it's something they want to try. I always try to put it through for them initially and do their peer-to-peer, but if I should lose, then we offer them a cash price. And you'd be surprised how many people, I mean, I had a guy do a stimulator the other day. I think he pulled his credit card out for his trial and then another credit card out for his perm, and it was a total of like 75 grand. And I don't know what the guy did for a living, but I know he flies back and forth to Mexico a lot with small planes. But the fact is, I don't need to know what he does. I just know that cash pay is an option.
Keep in mind, you can offer cash pay only if you're not in contract with that insurance to do that procedure. If you are, you have to honor your contract with the insurance. If they don't cover it, then cash pay is fine.
Bingo. That's a great point.
We did a cardiothoracic surgeon for myself, ablation,
Uh-huh.
the insurance would cover.
Yep,
So that's how I was seeing my ideas.
yep.
Then it's open for you to do that.
Did you have a question back there? Yeah.
Sam, personally, just like from your experience with it, like part of the algorithm, do you ever do a nerve block first? Or do you ever try the SPR first in the trial before jumping to like the novel? Or do you just sometimes say, hey,
That is a method some people do. I do a nerve block. I don't do an SPR first. But I think that most of us, like say it's a cluneal nerve I'm going to do, I first take a needle, walk it along the iliac crest and drag it back and do kind of a track anesthetizing. And if that makes a difference, then I put a trial lead in. So I typically want to give the patient the best outcomes they can have. And that reminds me, lateral femoral cutaneous nerve, we talked about this last night. That is a great indication for this. I've had really good results with that, whereas nothing else has been consistent. So keep that in mind. There's a lot of different nerves you can name throughout the body. That's a good one. Dr. Gandhi, are you getting close to ready in the OR? No, I can see you're not. So we can continue with questions for just a second here. Yes?
Do you find often that sometimes the nerve block doesn't necessarily predict success with the implant?
I mean, so
Comes back to
if I'm pretty dead set on it, I would probably still do a lead trial. In pain, we have gotten used to promoting, like you do medial branch blocks for doing ablation, right? And so the procedures that make us have the most sphincter factor are the procedures that have no precursor, right? The basivertebral nerve ablation that we'll talk about. There's no precursor procedure, so you kind of go, there's modic changes, there looks to be a problem with, the end plates, so let's go do that and hope it works. And so, but we feel more comfortable if we do a stem trial, the person has 95% improvement, their life changes for a week, and then we know a perm's probably gonna work for them. So I just am kind of the opinion that I always wanna try to give people a test drive before they buy the car. And, to your point, if they have a nerve block that maybe doesn't give them results we expect, but my suspicion is still strong, I'll go ahead and do a trial with the lead. Good point. Any other questions? Yes?
when you're doing like testing the procedure, are you really trying to cover the area? Or sometimes do you feel like you just don't get free coverage during the procedure and that's okay when you're testing?
When I'm doing a nerve block,
Or the actual like with spread deal, so what I've done is we try to test. Sometimes we get good coverage.
oh, you mean like intraoperatively? Yeah, I think that it's more, the reps can speak to this, but if you're a certain distance away from the nerve and it looks good radiographically, or especially if you have ultrasound, I don't worry so much about what they get intraoperatively. We ready over there? Great questions. We'll hold the other questions for now. Dr. Gandhi, if you want to take it from here, spinal cord stimulation.
Hey guys, kind of just a brief discussion before I demonstrate some of the trial and an implant for the spinal cord stimulation. So we have to think that the level of spinal cord stimulation has come, years and years and years. We started with single leads, single contacts, years and years ago, where we were doing one lead, one contact, treating really, one post-laminectomy syndrome. So in the last 10 years, even in the last 5 years, you've had an abundance of diagnoses now being treated. You've had different leads with different contacts coming out, different locations of placement, battery types. These are all sort of advances. As the technology develops and as new diagnoses are developing, you'll notice that companies are also changing the way they're sort of introducing these new technologies. So, we have a couple of different batteries here. Everything had started off with, high frequency and burst dosing, and now we're expanded to closed loop stimulation. We have fast programming from Boston Scientific. So you can see that all these various programming techniques are available because of the different type of patients that we have. The diagnosis has now been expanded for diabetic peripheral neuropathy. We're placing leads 9, 10, 11, a lot of dorsal root ganglion stimulation, which is also being done for CRPS. So these are different things to keep in mind, outside of just a spine patient. If you're an all-encompassing sort of pain management physician, you'll get, amputees, which is a big hot study right now with spinal cord stimulation and phantom limb pain. Again, CRPS for foot or, cervical implants for arm CRPS. And then you have your classics. You have your post-laminectomy syndrome. You have your persistent radiculopathy. Sometimes after some of these laminectomies and foraminotomies, you have scar tissue developing around peripheral nerves that we can't really do anything about, or your nerves, your motor nerves running down the legs, your sensory nerves. That's where spinal cord stimulation comes in. So you have to kind of pick which technique you want to adopt. You have to pick which technology works best, where you're seeing the best outcomes. We know that SES works, and all these little trademarks and little changes that are being made in spinal cord stimulation are all for the benefit of the patient. So you have to just kind of figure out what works best. Remote programming is another big topic that's coming out in spinal cord stimulation. The delivery, iPhone use, Samsung use, technology is guiding its way where we can monitor exactly what the patients were doing. Before, in the older technology, it's, you had a old school battery that patients would get stimulation, would have to come in person, get programmed every few months or every year, as the device was in the patient longer. Now they have, they have people in our clouds and, AI use that's, monitoring these patients. If there's a blip, or why did the patient turn the SES off? Is it impeding? Is there, a contact that's not working? Is the battery not working? All of these different questions that patients have are slowly being answered by all the companies, and as they come out with their technologies, including the battery types. The market is always who can create the smallest battery or who can create the most comfortable battery. So that's another sort of discussion there. So SES, just like peripheral nerve stimulation, is still a hot field, even though the technology has been around a long time. So these are just a couple of the batteries here. This is the Evoke battery here from Saluda. So they're very big on their closed loop programming. So once the leads are in, there's some devices where motion or flexion extension of the patient can cause an increase or decrease in stimulation. With the closed loop, you're getting these ECAP readings and the ability where the patient can maneuver without having, jolts or, I'm sure in a lot of your practices, you'll have patients that say, yeah, when I lay down, it zaps my whole body, or when I lean forward or cough, I get, stimulation as such. And all the companies are sort of driving away or trying to get the leads to work in a way where patients don't feel that. This is another battery from Boston Scientific. This is a rechargeable battery. This is the non-rechargeable battery. You can see the size difference. Again, size for a lot of patients, if they're living in Hawaii or places where they're out more, they're looking for batteries that are a little bit smaller. But some patients where they have shoulder issues or they have rotator cuff issues, they're not able to charge the batteries. So we place one of these sort of thick credit card is what I call it, or when I tell patients, this is the one that we implant. So there's an option, you have these options of batteries, but when we do the procedure and the technique of SES, that hasn't changed much, since it began. So I'll start, with the trial. I already kind of started a lead here, or a needle trajectory here. So generally speaking, we start a level and a half below is where our skin incision or our skin point is. So I've already kind of placed this one here, heading towards the epidural space there. So kind of guiding it there, picture. And so we're guiding it to the T12L1 space here. Picture. Picture. Just kind of making my way here. Picture. Okay, so we're going picture. And so we're looking for that purchase of the ligamentum flavum. Picture. Picture. So I'll bring this back to get a little bit more midline here. Picture. Picture. Okay. So we hit some os there. So we'll see if we're kind of getting into the space here. Seeing loss of resistance. So get lost there. And so again, along with the different battery types, you also have different leads here. So I kind of want to show you these wide space contacts here from the Saluda leads. So you can see how kind of wide space they are. And then in comparison, I'll show you the Boston Scientific trial leads here. So you can kind of see the difference there. A little bit more wider spaced, similar amount of contacts, but again, this is how these technologies are evolving to make sure that we get adequate coverage. We're able to trial these patients and make sure that they get good coverage of pain. Picture. 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 So we'll drive this there. Picture. So we're not quite in yet. Okay, picture.
Dr. Gandhi, while you're playing around with that, do you want to speak to, I can see the way the bevel is inserted and the way you're using it as a backboard to drive it the direction you want to. Would you speak to that real briefly for the fellows and the people here?
Yeah.
How you use that to your advantage?
Right, so when you look at this lead, I'm just gonna kind of pull the whole thing out. When you look at the needle here, if we can zoom in on that. Here we go. So when you look on this, the needle here, you can see a little hub here. So I'll go to a flat side, and you see how there's this part here, right there. So this is the flat side, which tells me that I'm cutting away or switching the bevel away. And then you come to this side, and you can see this little notch that the other side doesn't have. This is the directionality that I use. That's why I do so many rotations with the needle. This directionality or this little notch here will tell me which direction. If I'm curving left or right, I can turn the needle one way or the other. If I need to dive, if it's a larger patient and I need the needle to dive a little bit more, I'll face it downwards towards the front of the body. Or if I feel like the patient's a little bit thinner, then to stay more superficial and stay posterior, I'll turn the notch upwards. And so this helps quite a bit, especially in patients that have bone, small spaces, more bone spurs, et cetera. So that's why you'll see me kind of fidgeting with this as I'm doing the trial itself. Picture. Picture.
The only thing I would add to that is once you do get in the epidural space, if you are driving off to the right like he is, if your backstop is to the left, it's going to push it right. So you can make an adjustment and move the bevel so it will be more straight up. But what I wanted to encourage you there on, because I feel like sometimes we come kind of close to this, is make sure before you move your bevel, make sure you've backed your lead all the way out of the introducer. There's a theoretical possibility at that point of transecting the lead in the epidural space, and that would be something you might have to call a friend for. So just something to think about. And then you can't be my friend, right? That's right. We want to be friends.
Picture. Kind of getting this. Picture. We're just driving this lead in. Picture. Should be in there. Okay. So you want to stay as flat to the body as you can, just so your lead doesn't sort of migrate down. Okay, picture there. So you can see here, we're kind of driving the lead. We can go live here. So you can sometimes get some resistance here, so we'll turn the needles. Can we go lateral there? And picture.
Dr. Gandhi, what's your opinion about using the dummy that some of them have, if you can't get it to thread as far approximately as you want to, or cephalad as you want to go, using the dummy that's in the kit?
I mean, you can use it, but a lot of times I'm sort of just kind of finagling and trying to stay, with the actual leads. They have a guide wire too that you can use to carve out if there's some extra tissue there that you need. You go up with the C-arm. Picture. Picture. And you can follow me north there. Picture there. And let's go up. This one. Okay. Keep going. North, a little bit higher. Yeah. There you go. Okay, so now you can see this kind of going up towards the space there, and then we'll go back to AP.
That's a really good trick you just did there. I don't know if you guys picked up on that, but if you get stuck in the AP and you can't advance it, move to lateral, and then you can see exactly if you're going anterior or posterior in the space, and that'll help you direct it up.
And then you can
Good
go
move.
north there. So you can see we're kind of taking this weird trajectory, but picture. Yeah, so what we can do now is with this kind of steering wheel here, it doesn't require a whole lot of turning, just enough to go left and right. So we'll take a picture. So I'm just kind of doing one of these. If you start turning it and twisting it, it doesn't change the trajectory. You just basically need to go right to left. You can go back to there. Yep. You can go live. We'll try to turn these a little bit here. So occasionally these leads are a little bit finicky when they want to turn. They turn, and sometimes you have to take the trajectory and take a little bit longer to turn there. So this one's kind of going in the lateral gutter there. So I'll twist and kind of play with this. You can stop live there. Take a picture. So essentially, once we get the leads in place, our goal here is to get them next to each other. Picture again. A lot more resistance here. Picture. There you go. Picture. Going up. Now you can go live. And let's go north. That way. Okay, so we have one lead here. Obviously, there's some scoliosis here that we can correct for, but essentially, I wanted to really highlight, the leads here about the spacing between the contacts. So you can see, 16 contacts there. We would place a second lead right next to it. But essentially, what we're trying to do is how much pain does a person have in the back? How much pain does a person have down the legs? How much pain do they have down to the foot? And that's how you kind of play with the placement of these leads. If you feel like the patient is mostly axial back pain, you may place the trial leads at 6, 7, 8. If they feel like you have back and legs, you may do 7, 8, 9. If you're dealing with a peripheral neuropathy patient, you may just do 9, 10, 11, to be honest. So that's how you kind of gauge where you're placing the leads here. So once the lead is placed, you can kind of pull everything out. So what I'll do is I'll kind of switch things up here and kind of show you the other device as well and think about the implant side of things. Again, you have the battery here. And essentially, you're doing the same thing. I'm going to kind of try to use the incision we already have. You can go back south. Picture. Okay, so here, picture. So I'm just guiding this again to the epidural space. You can take your preference. I prefer T12L1 as an entry point for epidural entry. You can go in T1112, L12, but you sort of have a preference based on what you see on your film picture. So I'm just guiding this needle here into the epidural space picture. 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 There. Again, kind of playing with the needle, making sure that I'm getting the right direction. Yeah. So you can see that these implant leads here have 8 contacts. During the trial, you'll locate a CPS or central point of stimulation with the rep from the company, and they'll know exactly where the patient's getting the best relief. That's why these trials are 5 to 7 days, or some people do a little bit longer or shorter. But by that time, you'll know, hey, the best stimulation and best pain relief the patient received was at, let's say, contact 7 during the trial. So you'll stagger and make sure you have those contacts covered by using this lead. So you don't need as many, you don't need the 16 contacts when you actually implant, because you'll be a lot more specific in terms of where you want the stimulation picture. Let's go live. This one just wants to go forward. So again, I can turn the needle and try to get this to go the other way because it has a preference to go to the right. I'll hit live again. It's getting the same sort of bone spur there on that side. So what we can do is redirect here. So what I'll do is I'll go in from the other side if there's some resistance here. Picture. Picture. Picture again. Picture. Picture. Oh. So again, this is just, finessing the needle technique, making sure you know you're lost there. And then you can drive this. Again, staying flat towards the body. You can see my angle here. It's not up and down. It's more about 30 degrees, but even the flatter you are, the better it works out here. Live. So we're going up this way. Okay. Yeah, so there's a scoliosis in this patient. That's why it looks almost like it's in the gutter. But say we kind of want to stay here. We can essentially pull out the stylet, which I did there, and then kind of also pull out the needle. There. And so when we're implanting, you have, these different anchors here. So you can put these anchors onto the lead. They click on. And this is all stuff that you can kind of work with in the lab. It's a little bit harder to see video-wise and get a tactile feel. But essentially, this here will actually sit in the pocket. You can fixate it down, click it, suture it down. And then essentially what we end up doing, again, I'm gonna skip this step and leave it for the lab, but you have this device here, which is a tunneler. So what you do is you kind of bring this here, and you've created a battery pocket here too. So there will be a battery pocket for the device right here. So another incision goes across this way. And what will end up happening is this tunneler will get through to the battery pocket. You'll thread the lead through, and then you'll plug the battery in, make sure you get all green from the rep. And then, you basically close the sutures or close the incisions with either Stratafix, Dermabond, staples, all of the above, a couple of the above. And then essentially you're done. The patients can be programmed pretty quick right off the table. So they'll have incisional pain, which you kind of give them a heads up about. But in terms of their sciatic or radicular symptoms, they may have relief right away. So that's generally speaking. Again, we want to make sure that you guys get some hands-on in terms of how to do the battery pocket, making sure that you dig enough. These batteries can recharge about 1 centimeter away from the skin. So you don't need to be, if you have a non-rechargeable battery, then you can bury it as far deep as you need to. But if you have someone where they are going to recharge and the lifespan of the battery is a little bit longer for the rechargeable battery, then you want to keep it at least no more than 1 centimeter deep from the skin so that you have access for them to charge the battery. And I'll leave it at that for questions.
Thank you, Dr. Gandhi. Any questions from the audience? Okay, so there's a billion options out there, Dr. Gandhi, with lots of different companies and stuff. How does somebody who has never been involved in this start to select what's the best device for their patients, or do they use a specific device for a specific patient type, or is it better to do the same one on every patient, or how would you answer that?
So essentially, what I kind of chose, there's a couple different mentalities to this. Is one, from the physician standpoint, you want one that can steer the best. You want to make sure this, every company has good data behind them on what they're good for. But essentially, you want to I use kind of like if you have a thin patient, do you pick a company that has a smaller battery? Do you have a patient, or from the physician standpoint, does one steer, and this is where you learn these things at these different courses, is do you feel like one steers better going up and down the spinal canal? Are you able to turn the device a little bit better? To be honest, it really depends. If you kind of try, if you're first getting into spinal cord stimulation and you're trying these different devices, you'll find out what works best in terms of your technique, and then your patients are the ones that are giving you the feedback. You may do 5 Saluda trials, you may do 5 Biotronic trials, you may do 5 Boston trials and say, okay, patient feedback wise, who has gotten the most relief or the best relief, and which did I feel technique wise was the easiest to drive or easiest to utilize or do the procedure with. And that's how you'll come up with a game plan. And then you may narrow your choices to 1 or 2 companies that you use routinely.
Good. Any other questions? Can you give us an example of one CRPS patient you've treated with this and just how it worked for them?
Yeah, so there's a patient where the patient had because I work at a big orthopedic group, so I had foot surgery, had hardware placed, developed CRPS of the foot. So we essentially you could do lateral stim, you could do conventional stim, but essentially we placed the leads down at 9, 10, 11, and we're able to get coverage all the way down to the foot. Now, you have people that'll do lateral stimulation. You have people who do specific DRG for L5 and S1 to get the foot. These are all techniques that kind of come with the territory. But even just conventional stimulation, dorsal column stimulation at those lower levels, patient had great relief. Obviously we know if there's an offending factor for CRPS, like a hardware or a pin, you take it out, they'll get better most of the time. But these are patients who actually require or need the pin or the hardware placed, and they're dealing with pain continuously. A new population that's sort of coming into the practice are cerebral palsy patients as well. They're younger, but there are a lot of those cases as well where there's a lot of foot lower extremity symptoms where SES is kind of being used or trying to be used for it.
What's the youngest patient you've done an implant on?
So I had a 28-year-old gunshot victim right through the peripheral, not the femoral nerve, sort of the peroneal nerve down by the ankle.
Yep.
And so he was getting onto high doses of, opiates, methadone, and then we ended up implanting him conventionally, and he did really well.
Good.
So I don't put an age as obviously if someone's really young, you want to try everything else beforehand, but if they've done everything and there's really no end in sight to the pain, then you kind of use this. especially if they have no spinal conditions or anything like that.
Good, Gavin, same question.
This is kind of a more broad question. I had a patient a long time ago who he had traumatic fracture at L1, and he had cauda equina syndrome, and he had arachnoiditis and scarring all around. He was not someone, he was a workers' comp patient, so we weren't able to get the stim approved. But have you guys ever seen cauda equina and how that's best treated? Looking through the literature, I didn't really see that stim is typically done for those patients.
Let's give that question to Doug.
So you can try modulation, but the real treatment for arachnoiditis is pumps. I mean, that overwhelmingly. So arachnoiditis comes from various things. It can be post-surgical, it can be traumatic, and I'm talking about cauda equina inflammation, not cauda equina syndrome, which is compression of the cauda equina. It's amazing that a little bit of intrathecal pain medication, opioid, just almost gets rid of the arachnoiditis immediately. So anything that you can try stimulation, but you'd always do a trial first. And if the trial is successful, okay. But if the trial is unsuccessful, which in my experience it is about half the time, then you could go on to intrathecal drug delivery, pumps.
Good indication. Okay, good. I think we're at a point where we're gonna take a break. Corey, does that sound good? Okay, everybody has about a 10-minute break, so fill up on drinks and food and bathrooms. Thank you, buddy. Thanks for having me. Thank you. That's what we're going to do together, man. I'm not doing corner walk.
Yeah, that's good. Open shoulder and the posterolateral approach to the face. And then I'll do the lateral.
I knew I wanted to go into medicine, but I didn't really know which path I wanted to take or like what would suit me the most.
It's been an extremely informative experience. We were able to see human anatomy firsthand.
The cadaver was really cool. Didn't feel the way I thought it would feel, didn't smell the way I thought it would smell.
It was cool being able to first see all of these anatomical things on the augmented reality headset and then go in and be able to see them on like an actual human being.
And to know that like that was all going on inside me was interesting.
I really loved hearing from all of the different physicians. All of them had something different and new for me to take away.
If you learn how to suture, you just get exposed to so much more that you wouldn't have if you didn't do the program.
It's a really hands-on experience and there's tons of guidance. It was really informative, concise for how much information there was.
High school students, college students, anybody who thinks they're on the brink of choosing whether they want to do medicine or not.
This is for sure the course for you.
Good morning, I'm Jens Chapman. I'm here at the beautiful Seattle Science Foundation facilities. Today I'm thrilled to announce to you a new program that we have that's called the Seattle Science Foundation VIP Platinum Experience. This exclusive package is designed to take your participation to the next level. It includes your course registration, 2 nights hotel stay at a nice local facility, ground transportation to and from course activities. Furthermore, as a Platinum Experience participant, you'll gain unprecedented access to a world-class faculty and take part in exciting networking opportunities. You'll join us at the faculty dinner, a unique chance to connect in an intimate setting and even assist in a live surgical cadaver demonstration during the course. To top it off, we'll feature in our SSF YouTube.org videos and our social media channels and showcase your expertise and commitment to advancing medical education. So don't just attend an SSF course, immerse yourself in the full experience. Elevate your journey directly by signing up for the SSF VIP Platinum Experience today. I look forward to seeing you at a future faculty dinner here at SSF.
Hello, I'm Dr. Sakib Hassan, and I'm at the Seattle Science Foundation for the 3rd annual SSF Endoscopic Spine Surgery Symposium. This is the first multi-institutional didactic symposium in the United States that focuses exclusively on endoscopic spine surgery. This course is a comprehensive instructional series that delves into the intricacies of endoscopic spine surgery. Through advanced didactic lectures and cadaveric demonstrations, our all-star faculty will expose attendees to the cutting edge, the latest techniques and technology. We'll cover the indications, optimal surgical corridors, and operative pearls, as well as the benchmarks and functional outcomes following full endoscopic spine surgeries. You'll then get to put what you learned into practice in the state-of-the-art SSF BioSkills lab with unprecedented hands-on learning. Due to the very hands-on nature of this course, spots are extremely limited, so please sign up today. We look forward to seeing you in Seattle on July 25th and 26th.
Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation. We thank you for your interest over the past years in the regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on offering free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future. If you want to have CME credits, please do it through the all-access pass. So coming 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
I knew I wanted to go into medicine, but I
Sounders are
didn't
playing the
really know
timbers.
which path I wanted to take or like what would suit me the most.
It's been an extremely informative experience. We were able to see human anatomy firsthand.
The cadaver was really cool. It didn't feel the way I thought it would feel. It didn't smell the way I thought it would smell.
It was cool being able to first see all of these anatomical things on the augmented reality headset and then go in and be able to see them on like an actual human being.
And to know that like that was all going on inside me was interesting.
I really loved hearing from all of the different physicians. All of them had something different and new for me to take away.
If you learn how to suture, you just get exposed to so much more that you wouldn't have if you didn't do the program.
It's a really hands-on experience and there's tons of guidance. It was really informative, concise for how much information there was.
High school students, college students, anybody who thinks they're on the brink of choosing whether they want to do medicine or not.
This is for sure the course for you.
Good morning, I'm Jens Chapman. I'm here at the beautiful Seattle Science Foundation facilities. Today I'm thrilled to announce to you a new program that we have. It's called the Seattle Science Foundation VIP Platinum Experience. This exclusive package is designed to take your participation to the next level. It includes your course registration, 2 nights hotel stay at a nice local facility, ground transportation to and from course activities. Furthermore, as a Platinum Experience participant, you'll gain unprecedented access to a world-class faculty and take part in exciting networking opportunities. You'll join us at the faculty dinner, a unique chance to connect in an intimate setting and even assist in a live surgical cadaver demonstration during the course. To top it off, we'll feature in our ssfyoutube.org videos and our social media channels and showcase your expertise and commitment to advancing medical education. So don't just attend an SSF course, immerse yourself in the full experience. Elevate your journey directly by signing up for the SSF VIP Platinum Experience today. I look forward to seeing you at a future faculty dinner here at SSF.
I didn't see the stem one. Yeah. Yeah. Honestly, it's just as helpful to see something not work. To see it work. Like, this is probably going to happen to you at some point. You're going to have to adjust. It's never just going to go perfect. I know, I saw you really pushing. I'm like, it's getting close. think this Mediviz stuff is gonna be pretty slick. I was looking at what they have back there. Oh, that's great.
Ultimate universe. Living within the spine.
It's all around us.
It's all around me.
Yeah, I mean, all of the research is going into surgery. I don't think no one's really, which makes sense.
Well, for example, we had a minimally invasive robotic, the one that we had last year. We have a robot at Cherry Hill campus and Issaquah campus, so robotic surgeries. But the kit for it's like $5,000. Why am I doing for this?
I know.
Yeah, sign me up for a one-level typo. Yeah, not
Hello,
really
I'm
cost
Dr.
effective.
Sakib Hassan, and I'm at the Seattle
Eventually
Science
it's gonna be cheaper.
Foundation for the 3rd Annual SSF Endoscopic Spine Surgery Symposium. This is the first multi-institutional didactic symposium in the United States that focuses exclusively on endoscopic spine surgery. This course is a comprehensive instructional series that delves into the intricacies of endoscopic spine surgery. Through advanced didactic lectures and cadaveric demonstrations, our all-star faculty will expose attendees to the cutting edge, the latest techniques and technology. We'll cover the indications, optimal surgical corridors, and operative pearls, as well as the benchmarks and functional outcomes following full endoscopic spine surgeries. You'll then get to put what you learned into practice in the state-of-the-art SSF BioSkills Lab with unprecedented hands-on learning. Due to the very hands-on nature of this course, spots are extremely limited, so please sign up today. We look forward to seeing you in Seattle on July 25th and 26th.
Hi, I'm Jens Chapman, and welcome to the Seattle Science Foundation.
Was it really?
We thank you for your interest over the past years in the regular programming, and we will continue to look forward to a great new 2025 program series. As always, we pride ourselves on free and widely available high-quality content, and I'm, as a spine surgeon, always very intrigued in learning from this. In 2025, to support our mission, we'll have to charge for CME credits, and this is doable through an all-access pass. This all-access pass will be differentiated for residents and fellows and for attending level or faculty surgeons. So please join us in the future if you want to have CME credits. Please do it through the all-access pass. So coming in 2025, please keep tuning in. Free content, high quality, always available. But please use the all-access pass if you need to claim CME credits. Thank you so much.
It's good. Yeah. So that's patiently.
Yeah.
But
it works. You know, it's like there's a 10-hour-long podcast on the Neuralink, and it's like 1 hour long, 1 hour per chief neurosurgeon, and they're engineers and stuff, and they're talking about what this will be used for. But essentially, they were saying like you'll be able to control anything digitally with your thoughts, and they'll train to
that's
it.
gonna be awesome.
And I'm like,
Connected to your CMI.
no, and I mean like you'll be able to just control it by.
I don't want to know what's your thoughts for this. I'll go through reality.
Exactly.
But it's like you might have,
It's gonna be dark.
you might have like a. Well, put the probe down. All right, I'm ready to just do my talk and relax. I asked Corey, I was like, should I give my talk like this? And she was like, you can if you want. And I was like, this is obviously a joke. You can if you want.
I knew I wanted to go into medicine, but I didn't really know
Ready to
which
start back
path I
up?
wanted to take or like what would suit me the
So far, so
most.
good?
It's been an extremely informative experience. We were able to see human anatomy firsthand.
The cadaver was really cool. It didn't feel the way I thought it would feel. It didn't smell the way I thought it would smell.
It was cool being able to first see all of these anatomical things on the augmented reality headset and then go in and be able to see them on like an actual human being.
We're never get out of here, we keep going like this, right?
That was all going on inside me. It was
The sponsors, we gotta give the sponsors a little bit of love.
Right, yeah.
We've given them plenty of love. Yeah, let's go.
Hello.
Okay, there we go.
Where are we
We can do it, right?
I think Doug's ready.
But yeah, yep, we are ready.
All right, let's everyone kind of come back in here. We'll get started. Doug's ready.
Dr. Gandhi, act like you're rooting for the Mets, man. Speak a little louder.
I think I've lost my voice in the last, what, 20 years rooting for the Mets? All right.
Okay, guys, are we ready?
We ready? All right. Doug, it's all yours. SI joint fusion.
SI joint fusion, okay. We're going to accomplish the lateral and posterolateral approaches. Dr. Dave will be covering the posterior approach in the next section. And so this is for patients that have SI joint pain, SI joint dysfunction, which is not defined by imaging, it's defined by the presence of SI pain. And usually these patients, 70% of these patients will be patients that have had an SI, had a lumbosacral junction fusion, L5 to S1 or long segment fusion across to S1, or pelvic instability. Those will be the lion's share of people. These will undergo an injection test, having at least 75% relief of their SI joint pain. And then the other criteria is they have to have 3 out of 6 physical examination tests positive for SI pain, pelvic thrust, pelvic compression, sacral thrust, Gainsland's test, Faber's test, thigh thrust test. And it's also nice to have tenderness along the sacral sulcus or a positive Fortin's finger test. And so they've done all this, they've gone through, they have SI joint dysfunction there with you. And so we're going to start out with a lateral approach. And so this is the demonstration of the angle of the sacrum. So I'm going to put this right here, and let's take a picture of that. Okay, so picture again. Good. That's the angle of the sacrum. So I'd like to point out that the angle of the sacrum is superior on the cadaver is this. Superior on the SI joint is this, right? So projecting like that. So inferior on the cadaver is this way. Inferior on the SI joint and the sacrum is this way. So we have to normalize it. So therefore I put marks on here to be able to, can you move toward me and give me a little bit of room here? We put marks on here to be able to find exactly where we are. And so we will start out by putting an implant in S1. So picture this. Good. Picture. So I'm going to go, picture, in the mid-body of S1, picture. And we're going to make an incision right about there. This will be our starting point. And so we always start with rigid access. These are Steinman pins, have some give to them, but I really prefer to start out with rigid access. Okay. All right, picture here. Picture here. So we will find, picture here, the mid-body of S1, picture, and the vestigial disc marks the foramen picture. That's exactly where we need to be. We'll start off, and this has rigid access, and we'll go in, picture like this. Picture. I can hear, I'm right at the SI joint. We hear the tone of the hammer taps change, and you can, I'm sure you can hear that. That way we know we're right at the SI joint and we're relatively going in straight. So let's come back around. And first I'd like to come back around and do the pelvic inlet view, which is looking from the feet up toward the head. The II is looking superior. So we'll come out, tilt the II caudal. And this will be a pelvic inlet view. This is very helpful to look at the anteroposterior portion and to make sure that if you're going to miss on this, you miss high and inside. It's like a brushback pitch from Nolan Ryan. That's what hurts you. And this is right in the center. If you can pull that a little bit towards you, I want to give you an idea about what a good pelvic inlet view is. The anterior rim of the pelvis is very crisp, and the sacrum is kind of a bow tie shape with the sacral ala being the lateral portions of the bow tie, the sacral body being the center knot. So that's right in the middle, and we have a crisp anterior border. That's where the lumbosacral junction will run. So we'll go from there to the pelvic outlet view, and we're going to place the implant on the pelvic outlet view. So we're right in the middle. We're not too far anterior, we're not too far posterior. As you can see, you have a nice swath of territory, a large amount of territory that you have to go through. And remember, the vestigial disc was the marker of the S1 neural foramina and the S1 nerve root coming out. So we're right halfway between the top part of the sacrum and the S1 neural foramen. So picture, we crossed into the sacral ala. I'm going to take this and put the Steinman pin through this. This is an 8-gauge non-tapered jam sheeting needle picture. And this is about the depth that we'll put the screw at about the 11 o'clock position relative to the S1 neural foramina. So I'm going to take our rigid access out. And keep in mind, this is a bony corridor. We're not too far anteriorly. We're not violating anything in the pelvis, including the lumbosacral trunk. We're not too far posteriorly, getting into the spinal canal. We have that wide swath of territory that we're going through that is the S1 bone corridor. So I can actually come out on the other side and not hurt anything. Picture, and I'm going to back up the Steinman pin a bit. Picture, there we go. That's about a 55 right there. I'm looking on the proximal portion of this. This has numbers, and the end of the Steinman pin registers the number of the size of the implant I need to place. So that's dilator 1. This is dilator 2. These have soft tissue threads. It's designed to be turned in like this through the soft tissue, these large threads. So it's a righty-tighty in through the soft tissue using a clockwise turn. And then I'm going to place the extender pin, and this is a reverse thread. So if we use power, it doesn't unthread it. And then the working channel, this is the working channel. It has a Francine end that goes up against the bone, and this goes over the first 2 dilators. And so this will go over the whole apparatus here and all the way down to bone. We're going to take the other 2, dilator 1, dilator 2 out. And this is very similar to most things. This is a dilation process. So once we get it here, we're going to put our drill, which is 9 millimeters, in preparation for our 11.5 millimeter implant. And this drill will go in over the end of this. So 9.5 millimeter drill in preparation for our 11.5 millimeter screw. And then we'll go, this is a ratcheted device. So all the way to the end, and give me an x-ray, please. So we see the drill coming in, and just like most of the time, even when the body is osteoporotic, the SI joints, especially in the scenario picture, of SI joint dysfunction can be very sclerotic and very hard, and that's good for fusion. So we will cross the SI joint. You can see the drill crossing over. picture, the SI joint, and into the sacroiliac. I can feel it give there, so I know I'm in. Let's take a confirmatory picture for demonstration picture. And then we'll take the drill out, leaving the Steinman pin in. And then I'm going to place the implant. And the implant is this. It's 11.5 millimeters in diameter. This particular implant is 55 millimeters in length. And it has features itself, it's self-tapping. It's rifled on the inside so it doesn't push the pin forward. It's 3D printed. It's roughened titanium alloy. The differential pitch allows for lagging features of the screw. The oval windows allow for through growth in addition to the on growth from this roughened surface. And this roughened surface has a surface of the nodules here that are about the same distance apart as the cancellous bone. So we'll place this. We'll place it over the Steinman pin picture. And we will start placing it across the ilium, across the joint picture. Still have a nice bite. I can feel it going across picture. Nice. And we'll put it all the way to the desired endpoint picture. Picture. And just a smidge more picture. Good, all the way to the end point. Now, if you could arc about 15 degrees toward you, we're going to look down the ilium and make sure that the back end aligns with the posterior portion of the ilium. And this is something to be able to make sure that you have it flush. You don't want to countersink it. You don't want to leave it proud. And so you can see the line that is right at the posterior margin of the screw. I'm going to advance it just a little bit. Picture that. So that is flush with the posterior margin of the ilium. And keep in mind, you don't have to worry about the distal throw. We measured the size of the implant, so we know exactly how long that implant is, and it should fit perfectly. And it is in this case, but let's say you missize this and you need to go a little farther. There's a bone corridor there that you know you're not going to hit anything. It's all the way through, and we have it perfectly lined up. So I'm going to disconnect here. I want to come back to that AP outlet view. Just arc back toward me. Everything comes out. Disassemble this. This is a long Steinman pin. This is the inserter. This is a working channel. And we'll come back and we'll take final views of the outlet and the inlet. Very nice. Let's take an inlet view if we could. Very nice. And we'll skip the lateral view just for the purpose of brevity. I'm going to go ahead and we will show you the posterolateral approach. And this is something that is, so let's come back to the outlet view. And then we'll look at it, both of these implants on the lateral view. And I've kind of arbitrarily selected a shorter implant for the posterolateral view to try to get around the lateral implant that's existing already in there. So we'll start out again with the Steinman pin. I've made marks along the picture here, along the top of the S1, kind of mid portion between the S1 foramen, and then another mark picture along the border of the SI joint. I'm going to start right at that point, the intersection of those. So we're going to start out here, and this is more dorsal picture. Picture that. All right, so this is more dorsal, and it's out of the way of the gluteal muscles. This starts more dorsal. It starts just lateral to the PSIS and inferior to it. So you do have a built-in landmark that's pretty good. Picture that. Picture that. Okay, good. And let's go to the inlet view. So you start off in the inlet view, outlet view, go to the inlet view, and we'll make sure and have our orientation. So this is roughly aligned with the end plate of S1, the superior end plate of S1. And we'll get our medial lateral throw here, our angulation for our medial lateral throw, which looks, pretty darn good. I'm going to going to angle it about like that. Picture. And we're coming down, angling right across the joint. Picture that. Good. So I'm going to place Steinman pin and have the same sequence. So Steinman pin goes in. Picture that. Good. Let's go back to the outlet, please. So we'll take the jam sheety windshield wiper that thing out, pin and pull, don't lose access. We have dilator 1 down to bone, and the bone here is a lot closer to the skin surface than it is on the lateral view because you don't have any gluteal muscles you're going through. Dilator 2, right? And see, we can see the orientation here. This is the S1 posterolateral screw. And then dilator 2, then working channel. I'm going to make my incision just a little bit bigger. All right. And I'm going to make sure, and Doc, you can always use the working channel and hammer on the proximal neck of the working channel. That's designed to do that, just to make sure you're flush with bone. Okay, have these in. I'm going to put my extender on, and I'm going to try to skip the drilling portion of this, just for sake of brevity, since we've seen that before, that 9.5 millimeter drill. Let's remove dilator 2, remove dilator 1, keeping in mind you still have to pin the Steinman pin so it doesn't come back on you. And again, I've arbitrarily selected somewhat of a abbreviated size of a screw. This is 45, so this is 11.5 by 45. Smaller screw because we might have a little bit of dueling implants going on in there. So this goes on like this, and this is made by Genesis. Genesis has a dedicated posterolateral implant system that you can use with a nitinol K-wire. That's a very nice addition. So, picture. All right, so you can see this getting ready to cross the SI joint. And again, we'll try this without. Picture that. Good. Starting to go across the joint, and let's go back to the inlet view, if you can, please. Go back to the inlet view. We want to make sure the pin is not migrating on us. So there is lumbosacral trunk that runs along the anterior portion of the sacral ala that we need to make sure and not target. So that's a little bit more lateral than our distal tip of the screw. And it's right along the anterior margin, which we are really not aiming at. But sometimes in some pelvies, you'll have a posterolateral screw that aims toward the trunk. You just need to make sure not have that pin advance on the picture, and not have the screw be too long, which is just a technical error because we'll have measured the size of this picture. And so let's arc 15 degrees toward you. I'm going to stop, short of that. You can see why I sized this, because this would run into the other laterally placed implant. But otherwise, we'd have a longer screw. Picture. What you want to have is a situation like this, and this is a contralateral pelvic inlet view. This is a really nice view. So we're right at the posterior margin of the ilium. Ideally, we'd want the screw to come to the end of the Steinman pin, and it's, I've stopped short because of the obstruction, but that's where the appropriately sized screw. So in this case, a 55, perhaps a 60 millimeter screw would be appropriate, but that's the posterolateral technique, and you can see here how the proximal and distal threaded parts of that screw are bridging the SI joint, and the non-threaded portion lies over the SI joint. So lateral based, posterolateral access, and this is using the Genesis system. Genesis has a separate system for a posterolateral approach with a more conical screw, but it, just for the sake of brevity and because we have this system available to us today, this can also be used posterolaterally. So this is two good techniques, and they're almost interchangeable. I know I do primarily lateral-based fusions. There are many people that like the posterolateral approach because you spare the gluteal muscles, but either one is just fine. So with that, let's open it up to questions.
So I'll ask one. How many diagnostic either procedures or injections are you doing before jumping into the fusion?
So most of the, let's take like the NAS guidelines, for example. So they'll recommend one diagnostic and one therapeutic before you do an implant, before you go on to the fusion. So typically I'll do one, and that's how, one looking for 75% relief. I'll only do two if insurance requires it. There's some Medicare MACs that require 2 injections. NAS criteria for meeting criteria for SI joint fusion requires a diagnostic and a therapeutic. So oftentimes you'll find yourself doing 2 regardless. I mean, my typical approach and what I think is ideal is I'll do 1 injection that's diagnostic and therapeutic, mix triamcinolone, for example, and with bupivacaine. They get 75% more pain relief, then yes, they pass the minimum barrier necessary to move forward. If the injection lasts 4 to 6 months or more, I'll repeat it, doing 2, maybe 3 injections a year. If it lasts less than that, ideally, I think we should go on to SI joint radiofrequency rhizotomy, but that was not stopped being paid for by Medicare about 2 to 3 years ago. And so that's a difficult challenge, because the majority of these that I see with SI joint dysfunction will be Medicare patients. If they do, the insurance does pay for SI joint RF, then we'll go ahead and do that. And then when they fail that, we'll go ahead and go on to SI fusion. Typically, SI joint RF, depending on what you use, will last a year, plus or minus 6 months. But you can go into fusion if it becomes, pain goes away, it comes back, goes away, it comes back. You can go ahead and go into fusion. And non-surgical management, or so-called conservative care, is just not very effective for SI joint dysfunction pain.
Is this primarily a technique for people who are post-sacral fusion, or also like just SI joint dysfunction, no history of previous
Can
So
you
he's
repeat
asking if this is primarily done on patients who are post-lumbosacral fusion or just de novo SI joint dysfunction?
Yeah, no, there's got to be a reason. So somebody comes in and they haven't had surgery, they're male, they're younger, and they have SI joint pain. That doesn't happen, really. I mean, of course it does, but that's very, very unusual. So the 3 scenarios is somebody with a lumbosacral junction fusion or long segment fusion across 5-1, female with postpartum pelvic instability, and believe me, this can be chronic. I've seen women in their 80s that have had this for 40 years plus and unrecognized. And then the other category is seropositive and seronegative spinal arthropathies, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, something like it. And this is, they have to have a reason to have SI joint pain. And typically for the seronegative spinal arthropathies, I do not recommend an SI fusion because the natural course of this, think ankylosing spondylitis, it's going to go ahead and fuse anyway. Psoriatic arthritis, same. Reiter's, same. Intrahepatic arthropathy, there's a bunch of them. But I tend not to go ahead and fuse in that scenario, just wait to see what they'll happen. Treat them with DMARD if necessary, don't if it's not necessary, and then wait for the joint to fuse.
Questions? Yep.
Is there any preference whether do it lateral or the posterior approach?
There's a little bit of biomechanical benefit to going lateral as compared with posterolateral, but the biomechanical papers, to be really frank with everyone here, is based on a single posterolateral implant as compared with either a posterior implant, a very vigorous one that we're about ready to see that Dr. David is going to demonstrate, or 3 lateral implants. And so that biomechanical data may or may not be true. I never just put 1 implant, I always use 3 implants laterally or 3 implants posterolaterally. Most practitioners just do 2 implants posterolaterally, but most of the data, the level 1 data that we have is all lateral implants. So we just completed trials using the Genesis. It's a prospective multi-center clinical follow-up trial, registry type trial measuring PROs, and really good pain and functional improvements. Every single practitioner that participated in this was interventional pain or interventional radiology. The other trial we just finished is called the Stacy trial by SI bone using laterally placed torque screws. And so most of the data that we have is based on the lateral approach. I think the posterolateral approach is good. I think it is supported by the data that we have. I think also the lateral approach is good and supported by the data that we have. But it's just, I prefer the lateral just based on more biomechanical and clinical outcomes data.
Have you ever used the SI bone Intra-X or heard of that? Any thoughts on it?
Have you heard of or used the SI bone Intraflex?
Say again?
The SI bone Intra-X.
Oh, Intra-X, yeah. So Intra-X, you have Intra and then Intra-X. Intra-X is the smaller device. So you put on, so can you take a shot for me again? So this is the contralateral pelvic inlet view. And I've taken the lateral, posterolateral implant out. You can see at the very bottom of that is the SI joint. And the SI joint, if we were to go a little bit, can you arc about 5 degrees toward me? The posterior-inferior portion of that is more antero-posteriorly oriented than so you start to sharpen that up. And as you sharpen that joint up, the Intra-X is placed right on the pelvic inlet view. It's placed right into the joint on the pelvic inlet view. And you see the more medial part, that's the part of the joint that's more posterior toward us. The more ventral part starts to become more oblique as it goes ventrally. And this one is more antero-posteriorly as it is the dorsal part. So by using this is exactly the approach that you would use. 5 degrees off midline, and the Intra-X are little small implants, but a couple of implants in there. They're made out of cortical bone, and it goes right into the joint. I think that's ideal for very low demand, maybe elderly patient, maybe an in-office procedure is really ideal for that.
All right, so we'll pivot. We'll do the posterior approach with Dr. David now.
Oh, yeah, no problem.
Dr. Gandhi, while we're waiting for them to start, would you comment on dysmorphic sacral anatomy and what you see sometimes when you put up a AP or a lateral sacrum based on sacralization, based on all the different abnormalities out there.
Yeah.
What are your tips for getting the best pictures you can?
Yeah, I mean, so even when we do these SI joint injections and techniques, we run into, we'll hit posterior, anterior margins don't line up. Some people want to line them up and do the injections that way. Sometimes all you get is the inferior portion of the joint. That's where you're going to start, the injections, and you may get an arthrogram or you won't. So a lot of these cases, including the SI joint, that initial positioning, you may even need lateral views, right? Take a lateral view, see if you have a, L5-S1 fusion already there. You may have a transitional vertebrae from transverse process at L5 fusing with your ilium, for example. So you have these different views. You may even have to count from T12 down and see, is it L5, is it at L6, is it SI? And you really want to make sure once your margins are there, if you don't have a CLO or contralateral oblique, you may need to be right dead on with AP, especially in females and men as well. So when we do these techniques where we have to target and watch out for the foramen as well. So you have all these various SI joints that, staying on bone, again, for everything we do is, bone is home. But once you're doing the technique, we have to kind of see and make sure that we're in S1, is this S2? So laterals become a lot more important than just, straight on. And there's more and more, as we're going, as you're seeing more and more patients, you're going to see a lot of these transitionals. And, I've had cases where a person comes in with an SI joint fusion and it was done at, L5 instead. So it happens. And if it's just some physicians are a little bit faster and, they don't count.
We'll do CT scan, SI joints, and pelvis recommended for all of these, just for surgical planning.
I mean, not necessarily. I mean, most of them you can get away with floor if you have concerns about if they have like a seronegative, or if you feel like there could be some issues, again, transitional, then you'll get a CT. But it's all kind of provider preference.
You bring up some good points. So
Yeah.
in order to get approval, if we're playing the game of how to get approvals, you need to, and I was gonna say this later in my talks, but I'll just go ahead and it seems appropriate now. We talked about an injection, intra-articular injection with contrast enhancement that is therapeutic and one that's diagnostic. Usually they want one of each. They usually want to have an X-ray, plain X-ray of the ipsilateral hip to make sure there's not a profound amount of osteoarthritis. They want to have an MRI of the SI joint to prove that there is no insufficiency fracture, no space occupying lesions, nothing that's causing compression of the SI joint that could be another source of pain. They also want you to rule out spinal stenosis upstream. So you have a lumbar MRI and comment on, we've ruled out, this doesn't seem like spinal stenosis with claudication picture. You gotta, their verbiage needs to say, we've already thought about this, their stenosis and they've had injection or that's already been treated or whatever. But if you have all that together, you don't have to have a CT. You can get a CT for surgical planning if you want to. But if you have all that together and you submit it as one fell swoop, you have a lot better chance than if you put part of it through and then they ask for another this or you didn't tell this. You also want to include if they've been smoking in the last 3 months. You also want to include if they're diabetic or other things that make them a poor surgical candidate for a fusion device. But in terms of surgical planning, the other thing I was going to mention, I was kind of thinking when Dr. Gandhi was talking, if you're looking at your sacrum and it looks like S1 is the size of Texas, look again, because what you're probably looking at is a fused, transverse process against the ilium. And it will just confuse you where you are. So that's why the lateral approach is so important, because if you have a lateral and you're hugging that alar line, like I'm going to show you in a few minutes, if you're hugging that alar line and you get to your AP and your inlet and your outlets and you're nowhere near the alar line, you've got to start thinking about, okay, where am I in space? And I've seen a lot of dysmorphic pelvises, so just be aware they're out there. Did you want to comment on dysmorphic pelvises, Doug?
So there's an article written.
Doug knows all the articles. I know all the anecdotal. Go ahead.
Article written in the widely read Skeletal Radiology journal that categorized pelvic anatomy, and that the conclusion of that was that after observing all the pelvic anatomy, only 20% was conventional. They said 80% was variant. And then they made actually a good observation, a good comment that said, given the fact that most of it's variant, it's probably a variation of normal anatomy is what we're seeing. Transitional lumbosacral anatomy is 15%, so it's more common. It's as common in the US as blue eyes. So it's really common, and the variations of anatomy happen in almost everybody. Yes, SI joint and the sacrum and the shape of that, those two things are not a fingerprint, but it's close. So just be aware, L1 is not S1. They're very different.
And nobody would ever question you if you decide to get a CT for surgical planning. I mean, it's a certain amount of like 250 rads of like doing 250 x-rays on them as far as radiation wise. But if you have to do that to feel clear as far as going into the pre-op planning, please do it. I love the fact that you're bringing that up, because you're not just showing up in the OR, not having positioned the patient, not having looked at your pre-op films. You want to know long before what you're looking at. That's a A+ move.
So I'm gonna be go a little bit stronger on that. I'd say it's mandatory to get a pelvic CT beforehand. If you're not getting a pelvic CT, and I'm looking over your cases, I could tell that you don't know enough to be knowing that you should be getting a CT. Because pelvic anatomy, sacropelvic anatomy is hard. To be able to do that, to be able to extrapolate what you're seeing on CT to fluoro is kind of an art. And what we're teaching you is technique stopping short of the foramen so you don't go too far. And if you can't be in the middle of that big bow tie, then you probably not be doing any epidural injections either. So I'm confident you could do that, but the sacropelvic anatomy is so variable that you really need to get a CT scan beforehand.
So I was just telling them before you walked in that a lot of the insurance are requiring SI joint MRI. Would you recommend getting a CT instead, because that shows you your pre-op anatomy better?
So the only reason you get an MRI is to make sure there's not something else, right?
Yeah.
Make sure you don't have SI joint erosions for seronegatives. Make sure there's not a chordoma there, a tumor, and make sure there's not a fracture, sacral insufficiency fracture. That's what the MRI is for. CT is for anatomy. And if you can only have one, get an MRI of the pelvis instead of an MRI of the sacrum. Okay.
Yeah, and then also like picking up on types of patients we mentioned, lumbosacral fusion. Now, if you add a hip replacement to that, you're almost guaranteed that that person has SI joint pain if you're in between both, right? So another one to look at. They're ready.
Okay, you guys ready for me?
Yep, we're ready.
All right, so yeah, as Doug eloquently demonstrated the posterolateral and lateral approach, we'll be going over the posterior approach here. So we have the C-arm in a inlet view, but also oblique, contralateral oblique. We're gonna be going after the right sacroiliac joint. So inlet view with some oblique tilt towards me, and therefore a contralateral oblique view. So you want to show this picture of the C-arm there. We make an incision along the joint line there, but we're trying to make sure we're getting a good lengthwise incision that is at least the diameter or length of the actual working cannula that we're using. And this is the working cannula that we'll be using later on, okay? But we start off with the needle dilator, and this is it here. And that's used to enter within the joint. But first of all, you'll use a needle spinal needle to anesthetize a tract all the way down and get into the joint line. But this here is the needle dilator, okay? And it does release the handle, so picture here. So we're actually in the inferior portion of the joint there. It should slide in quite readily, and if you're having to force it, it should be more with taps rather than malleting heavily with the actual, erase it a little more. Thanks so much. Good there. Picture there. Do you have any, there we go. And picture there. Oh. It's going to be off the camera view there. Picture there. And raise up a little higher and push it out that way a little more. Other way. Yeah. Thank you. Okay. And just go a little south. Picture there. Just trying to get the joint space back into view here. Picture here. And here. 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 Taps there. Picture there. I'm barely even in yet. So. Picture there. I see it coming to medial there. I'm just entering the joint, just trying to get within the joint itself. Picture there. Picture. There. And there. There. Picture there. Picture. Okay. Now we're going to lateral from there. Let's see. So for the posterior approach, you're trying to get a more inferior approach of the sacrum. We are targeting in between the S1 and S2 segment, and we want to make sure we're not going beyond the anterior sacral line. So let's have a look on the lateral view to best describe that and see what we're going to be targeting, and also the actual angulation of which we're going to approach that area. And picture there. Put it up for me, and bring it up higher for me, please. Great. So this approach, you're kind of trying to avoid the PSIS. Picture there. Picture there. And you can see clearly the anterior sacral line. Picture there. This is quite easily tapping within the joint itself. We're aiming for that in between S1 and S2, and of course, not going beyond that anterior sacral line to keep ourselves safe. Picture there. 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 Excellent. Right. Okay. We'll go back to original view. Awesome. Oh. Push this way a little bit. Yeah, there you go. Lower a little bit, down a little bit lower. But next, we'll be using the joint dilator, which will be putting over top the joint needle. And picture there. Let's go oblique towards you a little bit. A little more oblique. And caudal tilt. And a picture there. Let's go a little bit more. Back that out. Let's go oblique towards me further. Picture there. A little more oblique. Picture there. So a little, I have to get a little too medial there. And back that out. Picture there. Picture there. That's trying to let it engaged. Picture. Picture there. Picture there. Let's check that lateral once more. Lateral, thanks. Picture when you're ready. Right. So I'll provide some. Provide a little bit of a medial distraction to making sure it follows and doesn't go medially. As a, you can tell if you're trying to pull it towards the sacrum. Picture there. Picture there. Picture there. Great. Let's go back to that original view. Thanks. As we, but as she's getting back to the original view, so yeah, we're going to use a needle joint dilator, sorry, to go over top of the needle dilator, the joint needle, and I'll be going over top here shortly to get within the joint itself. Just getting the picture lined up here. And a little, yeah, a little more oblique towards me. That actually looks like it. Yeah, let's have a look. Picture there. And back towards you again, live. Good, excellent. So beginning that over top. Using the utility tool. It does fit in one fashion, one orientation to fit over top of that. And this picture there. Picture there. And let's go to the outlet view. Let's go cranial tilt. Picture there. That's good. Okay. And go oblique towards you. Yeah. Picture there, live. Okay. Let's go back to the inlet view now. Just 1 second. Original view. Let's have a picture there. Okay. So you can see the bottom tine of that dilator is within the joint. We're going to try and make sure that the top tine is within the joint itself as well. Let's go cranial tilt live. Good there. Not fully engaged yet, so I'll bring that down further. Picture there. And come back to original view. I can get that down further and check again. Okay, picture there. Picture there. That's getting within the joint line. Picture there. Picture there. Picture there. Let's check the cranial tilt for me, please. Let's check the top tine. Picture there. Okay, good. And then let's go back to a lateral view now. And picture when you're ready. Trying to come over top. Okay. Back to the original view. I want to get a better view of the tines, but back to the original view when you're ready. But you advance that, once you confirm that you get the superior tine and the inferior tine within joint space, we then change over to get the working cannula over top. Okay. And just cranial tilt, that's when I get a little bit other view there, picture there. Okay. And a little bit, yeah, it's coming along nicely. Caudal tilt back to the inlet view, but oblique. Picture there. Okay. And let's go back to lateral. Let's confirm our endpoint there. And we'll start changing over to the working cannula. If you look at the working cannula itself, it has a ilium side, a longer ilium side, as well as a sacral side. Okay. And again, that depth-wise, see the lateral view. So we advance that a little bit more. Picture there. Picture there. Picture there. You may see that I am going a little bit beyond that anterior sacral line. It's still within the articular surface of the sacroiliac joints, so still quite a safe area, okay? So we'll change over to the working cannula. Again, putting on the ilium side and the sacral side, orienting that over top. And now we're using the utility tool, but more in a perpendicular manner. Come back to original view. Thank you. So you can see now using the utility tool over top and tapping that down. Getting that to engage. Need a little bit more room, please. And push that way a little bit. Get the same view. Oh. Picture there. Picture when you're ready. Picture there, please. Okay. And go cranial tilt. As we get deeper and deeper, I think we're going to be in line with the joint dilator there. Picture there. Yeah, I think we're going to be okay. And let's go to lateral. Okay. Picture there. Okay. And let's go back to that original view before I fully engage it into the end point there. And can we go a little more? Yeah, so picture there. Okay, and go cranial tilt. Picture there. So probably put a little distraction. We'll come over top of it, probably a little bit of a counterclockwise rotation to even get that away from the ilium on the top tine there a little bit. Picture there. And let's go back to the lateral just to confirm we're not going too deep there. Picture there. Just advance that a little bit more. Picture there. Picture there. Picture there. Okay. So now we're going to take up the needle dilator and joint dilator. And we're going to actually, I'll get a view right down the barrel of the working cannula. So right down this view. Use a slap hammer to get that joint dilator out. And here you really want to make sure that you see a good, nice joint space within the working cannula there. Picture there first. Let's have a look. So let's go, yeah. And let's go cranial tilt live. And oblique towards me. A little more, a little more. A little more. And back towards you. And let's go cranial tilt. Yeah. Keep going. So getting a little bit into the sacrum on the medial side there. It's up there. Oblique towards me a little bit. Back towards you, slowly. Back towards me. Oblique towards me a little bit. Good there. Stop there. Okay. So confirming that, I'll get the barrel view. Now we were looking at actually drilling it out and to help decorticate the actual area. Back to the original view, or and let's go lateral, yeah, sorry. And you're just gonna, using the lateral view, get the depth of how far you're gonna be drilling it out, decorticating it. Picture there, 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 there. Picture there, 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 there. Picture. Great. Pull straight out. Outside hole as well. Picture there. There. And there. Straight out. And in the middle, drill hole there. Picture. There. And pull straight out. All right. Taking that drill frame out. Now we're going to the box chisel to help further decorticate it. Picture there. Tapping that in, picture there. 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 Okay. Definitely gonna need the slap hammer to help me out. Take that out. And now we're using the rasp, which mimics the size of the implant we're going to be using. And picture there. 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 Great. Slap hammer to take out the rasp. And so using the titanium implant here, it's actually fixed onto the inserter. The black handle side goes towards the feet, mainly because in case it needs to be removed, we know which orientation it actually is in to have it removed. Once it's fully deployed, there'll be two anchors, an anchor on either side, which will deploy, which one will be into the sacrum, one will be into the ilium. So we'll see how those go in a second here, but yeah. And it's also packed with bone matrix to help facilitate fusion. Picture there. There. Picture there. 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 Excellent. Okay, now we're going to actually deploy the anchors. I'm going to screw that in, and then it's all fully screwed in. Now we actually hammer that down to deploy the actual anchors. Now we'll check to make sure the anchors are fully deployed. Back to original view. Yep, picture there. You see the anchor on the sacral side is deployed. Let's go oblique towards you. Oblique towards you. Live, yeah. And you can see parts of there on the ilium side there. Picture, keep going. Yeah, there we go. We see the other anchor on the ilium side there. Excellent. Let's go back and do a lateral view. And we're going to be take out the middle screw driver. And so we're basically going to be fixing those anchors in place and locking them in place by going to the side screw area. It locks in place. Now to actually release the actual implant, we are unscrewing the top bolt and gently moving it back. Picture there. You can see it's deployed. You pull that out. And now we can actually remove the working cannula. And let's get an AP, original view of the actual implant. Excellent. All right. Good. All right. And maybe it's cranial tilt. Some other views for the audience to have a look. Good there. Picture there. Okay. With the outlet view and back to original view. Thank you, Kristen. Excellent. All right. Any further questions or concerns?
Good.
I can't hear someone talking.
No, I said there's no questions.
Okay. Doug, anything else to add in particular?
So there's a question of safety. All of these are pretty safe. Posterior approach is typically how most of the interventional pain physicians do it. So just kind of be aware of that. It's dealer's choice. All of these work about the same in terms of biomechanical stability, rates of fusion, et cetera. So most best summary of this is Pete Wong's most recent meta-analysis, systematic review, goes over all three techniques. So if you want any extra reading on your board, just let me know and I'll send you that article. Well done.
Great.
All right. I'm Gavin Nixon. I'm an interventional physiatrist. Just started practice up in Anchorage, Alaska. We're going to be switching gears a little bit, talking about augmented reality. in spine care and some updates what's going on in that world. Some of the formatting is off. So the purpose of this talk is just to provide an overview on the available augmented reality technology and how it can be applied to spine care, and to go over use cases and future work. So the rise of complex outpatient minimally invasive spine surgeries necessitates new imaging modalities that are safe for us, safe for the patient, that are going to reduce radiation exposure for the patient and the operator, effective to allow for more precise navigation and placement of needles or hardware. And they must confer an advantage over traditional fluoroscopic approaches, and they can't really slow down workflow or be overly burdensome to user. So this technology is really going to be helping us visualize the anatomy in a totally different way, where we're not just looking at things in 2 dimensions and reconstructing in our mind anymore, although that will remain a skill that we'll have to use. But I think more and more we're going to have our procedures pre-planned as things go on into the future. Just a brief comment on radiation safety. We don't really get a lot of, no one really talks about this when you go through your training, but there's a certain dose amount that you get through the whole body. It's about 50 millisieverts is what's recommended for whole body over the course of a year. With protection, you usually are far below, but it's kind of important just to see like how much radiation are we typically getting. This study kind of looked at the radiation exposure when you're doing a kyphoplasty, depending on how many levels you did. This is a pretty small sample size, but it's 5.7 minutes, plus or minus 2 minutes for a single level, add 3.9s for a 2-level, and 2.9 for a 3-level kyphoplasty. So they were looking to see how much radiation are you getting with an unprotected dosimeter. Looking at the eye, the shallow exposure to the skin, and the hand exposure. And the conclusion was you'd have to do about 300 cases a year, and that would put you over the recommended radiation exposure for your hand and for your eye. So that's a lot of cases to do, but just to give you kind of an idea of how much radiation that you're getting exposed with a procedure that a lot of people are doing. So augmented reality, what is it? It's a virtual superposition of computer-generated information onto a surface viewed through a specialized headset or heads-up display. This superimposes the anatomical structures onto the live view of patient anatomy through a specialized headset or microscope. It's also called in situ holographic projection. This technology works by using pre-obtained images from a CT scan or MRI. It reconstructs them into 3 dimensions, and you superimpose them onto a patient using skin tags or different surface markers onto the body. This can be done basically to help you navigate where you're going to be in space and do planned trajectories. So this is kind of an older paper from the European Spine Journal in 2020, but you can kind of see what this might look like if you're looking through the headset and with a planned trajectory for here, which I think with this paper was a facet injection. So we'll kind of get through into where all this is heading. The history of augmented reality, the first heads-up display microscope was in 1986. They did a percutaneous vertebroplasty with a heads-up display in 2013. They did the first minimally invasive cervical foraminotomy in 2018, and then a TLIF in 2020. Now we're moving, a lot of the research is looking at pedicle screw placement for spine surgeons. So the pace of research is really picking up, specifically around spine surgery, pedicle screw placement, brain tumor navigation, and percutaneous vertebroplasty has also been looked at. The real applications overall for us are mainly around the navigation, a component, but also this is being deployed for a lot of physician training. I don't know if you guys have heard of Med Ed Combine, which is an interventional pain program. They do a lot of training virtually through augmented reality as well. So you can kind of walk through the workflow of a procedure, first off looking at it with a headset on. So it's being developed. This is kind of a new way to look at the anatomy and learn anatomy as well. Specifically with the use of spine, like I mentioned, this is going to be projecting an anatomically correct hologram combined with a planned trajectory for guided navigation. This is just a clip where you can see where the trajectory is planning. You'll be looking down at the patient, and a heads-up display will be in front that shows the slices of your images, which you'll be able to pan through, and we'll be able to do some of this in lab as well. The applications for kyphoplasty, this is a study that was done at a hospital in China. It was a 3-level kyphoplasty where they essentially just did the pre-procedural planning, where they had their trajectories planned before going into the case. They used the Microsoft HoloLens And during the case of the procedure, they were confirming with the C-arm, but this was kind of the first proof of concept of how can we do these procedures with visualizing the anatomy overlaid on the patient while we're doing the procedure. This was a case control study of the European Spine Journal in 2020. There was a total of 18 patients undergoing vertebroplasty with this ARCAS, which is Augmented Reality Computer Assisted Spine Surgery System. Really, the conclusions of this paper showed that it was a feasible system for percutaneous vertebroplasty. It provided a more precise bone entry with reduced operative time and unnecessary radiation exposure, which kind of meets the criteria of what we're looking for when bringing on a new technology. This was a study briefly that looked at sacroplasty. This was more of a proof of concept. In this study, there was really no significant difference in the radiation dose or the time, so it didn't provide too much of an advantage when they looked at this kind of smaller study. This is a group out of South Korea that has really been kind of leading the way for less of the trocar placement, more for needle placement. This is the first study done clinically for lumbar epidurals. This is probably what we'll start to see more and more of in the conventional procedure suite, where we have these visual tracking tools that these are constantly looking at basically QR codes that are going to be attached to the trocars or the needles that we're using. And then this is the reference marker that helps track where the patient is in time to the heads-up display. So these patients in this study were all scanned with these markers on the back. Then they were put on the table. The physicians then planned their trajectory on the CT scan. The CT scan was reconstructed, so you can see where exactly the trajectory would be. This picture is not my favorite, but it just goes to show that once the patient's on the table, there has to be a large QR code that is able to reference track with your headset that's always looking at this code. And every tool that you're using has some sort of tracking device that helps you know where you are in space, as well as where the skin markers are, so everything's superimposed onto the patient. This is a picture from one of the previous studies they had done on a phantom cadaver when they were doing the proof of concept that you could actually drive a needle under augmented reality and achieve correct needle placement with much less need for consistent fluoroscopy. So the results of this study was the first randomized controlled trial reporting clinical application for augmented reality navigation for an interventional procedure other than surgery. Really, the takeaway here is the T1 time was the time to get your needle in your correct trajectory. T2 time was the duration until the procedure was complete. In the AR navigation group, all of the times were much faster than the control group using conventional fluoroscopy, and the number of pictures that had to be taken during the procedure was significantly lower than your traditional fluoroscopy as well. So this was an interesting one. This is an interesting one because if you can really just have the whole procedure planned before you do it, it minimizes the need to constantly be taking pictures. If you have very complicated anatomy, then you already kind of know where you're supposed to go. The major players in the space, there's a lot of companies. There's basically a new company coming on the scene. The one that we're going to see in lab today is Mediviz that just got FDA approval in April of this year. They use the Microsoft HoloLens, and they use sort of this visual tracking equipment here. Some of the others FDA approved for spine navigation is the Augmented heads-up display here. And then there's a local company, Proprio. They are also working in this space as well. The kind of distinction between some of these is that as we integrate AI into the imaging, it's going to be able to start helping the pre-procedural planning. There'll probably be a point in time where it will just start to know what exactly we want to do before we even need to do it. And you'll be putting on a display and the trajectory will already be planned. So it's very interesting technology. Most of this is being pushed through spine surgery. I don't really see that this is happening a lot in the interventional space. This group in South Korea seems to be kind of leading the way in terms of what we can do with a needle. It's a little bit tricky because a needle can bend through skin and you're always going to have to confirm with fluoro, but it just means like, can we take maybe 50% less pictures, 75% less pictures, and achieve these procedures in a faster, safer way using some of this technology that's coming aboard. So it's kind of open for research for anyone. You can reach out to these companies and see what can be done. But that is all I have for you guys. Any questions?
So when I first, one of the ortho surgeons in my facility, once I started doing kyphoplasty, I did like 50 last year. He's like, you should look into O-arm to see if there's, a navigation assisted.
Sure.
That you can use over the course of your career. It's a ton of fun.
Mm-hmm.
And so, meeting with my surgical services director, she was basically like, sorry, these procedures don't pay enough to justify you using the O-arm.
Yeah.
And so that's the I think the big hang up. And so I know that in some academic centers, they do actually use O-arm and navigation for vertebral augmentation. But for me, that was what I went through that learning journey and discovered that. So I wonder if they can get the costs down.
Yeah.
Because I think we're talking about O-arm, right, for mapping, and then using this overlaying, just like the thing for spine surgery. Those, putting in pedicle screws pays pretty good.
Sure.
So there's
Yeah.
more margin than with my little.
I mean, kind of where I see this going is that patients will probably start to be scanned with reference trackers on them at baseline. And then, if you have a procedure suite, I don't know what the cost of this is, but it's going to require tracking, these tracking cameras over the patient. It may be one, it may be two, but this at some point is probably going to become somewhat standard of care. The cost is going to have to come down. This may be something that really is pushed more in the academic space, maybe not, I'm not sure. But if this makes our job easier and safer, then it'll probably be adopted, within the next 5 to 10 years more.
Thanks for the shout out to the Med Combine. I started that. That was kind of a fun little
yeah.
journey we went on with Jafrida. The other use of this, besides pre-op planning, that I think is applicable, especially when COVID and other issues happen, is education can go on, right? That's why we started the Med Combine, was so that when you couldn't go to society meetings, you could still have a scenario much like today, and people could watch online. And so we used our augmented teaching that way. But so it's great for if you're a residency director and you have multiple sites or something, and you want to see what you could be at your office and see what the fellows are doing and stuff like that. So I think there's a lot of educational benefits. In the pain management space, the margins are really narrow. Kyphoplasty, I mean, every time I do one, the surgery center director comes to me and says, now you do realize that we're making like $150 for you to take a really high risk. I'm like, yep, we're doing it anyway. And so the margins are low, and the procedures we do, there's only certain things I think we would do that would really add up to the benefit of the pre-op time.
Sure.
Because you're saving imaging time, but are you saving time
overall
in its entirety? I
Sure.
think you're adding time by having to do more pre-op.
Sure.
So somebody tell me if I'm wrong.
Yeah, I mean, that'll be the question is, will you save time during the procedure if you've done 5 minutes of trajectory planning or not? I guess people will have to figure that out for themselves. But I always found for myself, if I look at a case and I think this is going to go really easy, that's always the one that never goes the way you want it to. So you just never know until you get in there. But
That was an interesting presentation, though.
any other questions? All right.
Yeah. We'll put that together. I've never been put that together.
I mean, the O-arm, I think, is super expensive.
So, are we on the Basivertebral mode now?
Yeah.
All right. So we're going to be moving on to basivertebral nerve ablation, anterior column procedure. Semi-new, not really new. Really good procedure, treating, really don't have anything like it out there. But, we're taking the disc space as well as the vertebral column and the vertebral bodies as one unit and just calling it discovertebrogenic pain. But we can split them up, and, there's obviously a lot of intradiscal procedures as well as, kyphoplasty to treat fractures. So this is a procedure where we're taking a tried and true technology of radiofrequency ablation and putting it in a different location. And great study, great data, level 1 data out there. So, if I know they have a robust training program to actually start doing it. But it's definitely worth it, and you'll see a lot of patients in that 35 to 55-year-old range that you do epidurals on or you treat, their symptoms, but they clearly have vertebrogenic pain over facetogenic pain. So definitely a really, really good tool for your toolbox.
Vertebral nerve ablation. This is ICD-10 code 54.51. And this is a new ICD-10 code. This is for patients that have axial low back pain, that have modic type 1 or 2 degenerative end plate changes. Chronic by definition, meaning back pain of 6 months or more, and those that have failed non-surgical or conservative care. And so these patients are identified. This is on label for L3 to S1. It's on label for L3 to S1, off label for other lumbar levels. And it is targeting the terminus of the basivertebral nerve, which is halfway between the superior and inferior end plate. And it's at the 40-yard line from back to front. So it's just 50% or less from the anterior to the posterior portion. So this is supported by a couple level 1 trials, Intercept, and the SMART trial. It's got, last time I counted, 38 pieces of evidence, including multiple clinical trials. It's got non-industry sponsored trials. It's got prospective single-arm control trials, multi-center site. So this is really, the amalgam of evidence follows kind of along fairly clean and narrow lines, meaning that most of the results you get are pretty predictable and fairly consistent. So what I usually tell the patients is, like, for axial low back pain, yes, you have modic changes. So the statistics are this: you've got a 75% responder rate. If you're a responder, your average pain reduction is 75%, and it appears to be permanent or durable. So that's kind of a summary statement of the amalgam of the evidence. So let's show you the basivertebral nerve ablation. This is done, and Phil's going to help me here. This is a model. It's a very nice model, in fact. We're going to do L4, contralateral to where I am, picture there. And that's about the right start point, about a half vertebral body width out. And I'm going to come down and hold it with my hands because this isn't real fluoro picture. I'm going to go up a little bit, picture. And that's a pretty good start point, picture. And I'll get a better bite. Picture that. Good. All right, let's go lateral. And we'll take the stylet out and we'll put the nitinol curved stylet in. We'll get the appropriate arrow indicator, so we'll go medial on this. This is kind of a rock up and in one motion. To get this fairly stiff piece of nitinol, so it takes a couple times to get the gist of this picture. And so we're going to take the J-shaped stylet and we're going to angle this thing toward midline. I'm going to start over. I'm a little bit high there. And I want to get this perfect. So we want to get it halfway between superior and inferior end plates. And we're going to get this just posterior to the 50-yard line. All right, picture that. A good start. I'm going to advance a little bit. All right, picture that. Okay. All right. Picture. All right, better. Picture. Picture. I'm going to angle up a bit. Picture. Picture. So that's kind of what we want. We're about, if you were to go from distal to proximal, ventral to dorsal, and we're divide this, we're probably about 30%. The terminus of the BVN, the top of the trunk, happens at about halfway from front to back. So if we're going to target anything, we need to be at least at that halfway point or farther back, at the top of the trunk of the terminus, the top of the trunk of the tree, or back toward the base. And so we'll take a look on AP to see where we are, and there we are. If I'm going to pull the stylet out, and we'll have the probe that goes in, and picture that. And I'm going to advance it just a little bit farther, picture that. And I'm going to put that small dot, this is a bipolar probe. It has a very radiopaque distal electrode. The proximal one is not so radiopaque, and that small dot between the two is where you center things. So I'm going to roll the peak sheath back, take another shot, and it looks like I'm right directly in the midline. So I'm going to take this and I'm going to secure it, the probe wire, to make sure. Oh, okay, sorry. Picture that again. So yeah, the simulator doesn't allow me to do this, but to make room for the image intensifier, the eye to go back and forth, we take this and we pin it right here. It has a little notch so you can put the wire in to keep it out of the way of eye, and the notch is here. You can see that, but we'll leave it right there for the simulation, and that's it. And so this is, if you're on target, it's a 15-minute burn time at 85 degrees C. The impedance is about between 200 and 300. If you're right on target, you can get away with a 7-minute burn, and same parameters, 85 degrees C for 7 minutes. So this is basivertebral nerve ablation. It allows us to take care of people with axial back pain with motor changes. You can either select the patients based on MRI only, or you can do discography. I do anesthetic discography on everybody. Let's say we're targeting this level is L4. Let's say they have 3, 4, 4, 5 disease. I'll go in and inject those with a little bit of contrast. I'll anesthetize them, see if the pain goes away, make sure they have motor changes. If the pain goes mostly away or completely away, same as an SI joint fusion, then they're candidates. But you do not have to use discography. You can just do this off of anterior column, axial low back pain, and MRI only. You can use that as a patient selector. As I mentioned, I mean, based on the data we talked about, the anterior column pain, identifying combination of clinical characteristics and visual characteristics on the MRI, you can nail down this in terms of patient selection very well. So that is basivertebral nerve ablation.
Questions? Yeah.
Do we have data to compare the 7-minute burn and the 15-minute burn?
No, no data yet. So that brings up a good point. I mean, personally, I don't mind doing a 7-minute burn, somebody else doing it. I'm not doing 7-minute burns yet, and for the rationale that there's no data behind it. And you know, when a 25% non-responder rate and you don't get a response, I mean, is it because you have a 25% non-responder rate, or is it because you didn't go with a 15-minute burn? But there is data saying that in between 6 and 7 minutes, that's all you need, as long as you're on target, to adequately ablate that nerve. And I was part of that formative work, and I believe it. I just don't believe it enough to use it clinically without clinical data.
Yep.
That's a really good question, by the way.
Are you guys doing this mostly in the OR, or can this be done in the office with like IV sedation?
So no office, it can be done in the ASC or the OR in the HOPD, a hospital. I typically do most of my cases in the hospital. I practice out of a physician-owned hospital, so that's very easy for me. This can easily be done in an ASC. I think this is best done with deep sedation. In my experience, moderate sedation isn't quite enough to have the patient hold still. The cases tend to be longer, so it's difficult to do moderate anesthesia or MAC for that period of time. So for those reasons, I typically use either deep sedation and, you know, sometimes general anesthesia, but that's not common.
In the back there.
So do you perform the ablation of just those vertebral bodies with changes, or yes, do you do two vertebral bodies?
Yeah, so the question is, do you just do the levels with the modic changes, or do you go a level above and below? But
So
yeah.
So almost always, I go above and below, and almost always the modic changes are above and below. If the modic changes are not above and below, they typically aren't modic changes. Typically things like the Schmorl's node or a trans in-plate disc herniation. But there are single level modic changes. And if you have modic changes that are exclusively present, let's say at L4, as compared with the level above at L3, there is data. Luigi Manfrey did a study using SPECT CT, identifying the modic changes that were active or had increased uptake on SPECT CT, treating that level only. In this example I'm giving, it would be L4 only, and not treating L3. And the results, the outcome, were identical to treating both levels. So if you have additional information that allows you to be able to treat one level, that's perfectly fine. Otherwise, just go with the level above and the level below. And remember that modic changes, one of the cardinal signs of modic changes is that it's above and below of the disc that's affected.
And so the other indication is active Schmorl's nodes. So that goes into that single level vertebral body level if you're not just dealing with discogenic pain. So that is an on-label indication.
Yeah.
Yep.
If you're doing intradiscal injections to plan for this, if you're planning for like 3 vertebral bodies, are you doing the two intradiscal injections, and what is your local anesthetic choice?
If you're doing intradiscal injections for this and there's 2 levels, do you inject both, or do you plan on doing one and then come back for the other?
If there's 2 levels that are involved, I do both discs, and then I'll do all 4 vertebrae. So level above, level below for each disc.
Insurance is dicey because Medicare now wants 2 levels unless you have enough data to support doing more than 2 levels, so global period. So you end up doing, if you have an L3, 4, 4, 5, you'll kind of pick based on exam, do 4, 5, come back and do L3.
Does the intradiscal injection help with justification?
No. All right.
All right, you guys. Thanks.
So I'm going to jump into, as soon as he pops out of there, into the intrathecal drug delivery.
Okay, we're going to switch gears and go from targeted interventional techniques to this is a pain blocking device. This is intrathecal pain pumps. Okay, show of hands. How many people do intrathecal pumps? 1, 2. Okay. Why not? Why is that the case? It's been around for a long time, and I'm going to show you things that you need to be thinking about. And if you're not doing one of the 6 things I'm going to mention, you're missing out in terms of intrathecal pumps. So we'll talk a little bit about the inverse pyramid of stomatos. We'll talk about targeted drug delivery. And we'll talk about how to incorporate this into your practice. And then I'd like to spend some time on the economics, which is, of course, next to oxygen, one of the most important things that we do and we have. So typically, this concept, the inverse pyramid of stomatos, has been around. This was published in 2005. And most of the interventional techniques in the top of the pyramid, which is inverted, of course, the neuroablation and everything else will be short of corrective surgery. But what we're trying to do is we're trying to incorporate most of the interventional techniques into the corrective surgery and then incorporate some of the pain blocking devices before you'd ever do chronic systemic narcotics. So my position is that you would never start out with, in terms of pain management, with narcotics first. These are not designed to be used chronically, except for pump, and they don't do very well in terms of pain control over the course of time. So targeted interventional therapies to target the pain generator, to target the area where the patient hurts. This is always starting early, and you can do so with a combination of injections, radiofrequency ablation. Some of the corrective surgeries that we've shown you today include interspinous fusion, interspinous spacers, SI joint fusion, basivertebral nerve ablation, and there's a bunch more. So the corrective surgeries are now, we can encompass those. And then after we failed, we can try things like neuromodulation, peripheral nerve stimulation, and then past that, or maybe even before that in some situations, some circumstances, is targeted drug delivery. And so you start off at the top, you click down, becoming a little bit more invasive, a little bit more definitive for the most part, until you stop at the combination of the least invasive thing that helps your patient. And this is the philosophy, this is the ethos by which I do my practice. So let's switch to something that's really easy, like cancer pain. And so this isn't unusual. 2 out of this whole group do intrathecal pumps. I think that's a travesty. I think that's a crime. I think it's way underpenetrated, because if you were to take, I'm going to switch to blame my own specialty for a while. So Dr. Clerk and I are radiologists, and we deal a lot with cancer pain. Some of our specialty do only cancer pain, interventional oncologic procedures. And there's about 1.5 million people that have cancer every year. About a third of these will have severe pain, and about a third of those will have a life expectancy greater than 3 months. But this, by definition, means they're a good patient for a pain pump. And as we know, pursuant to what I mentioned earlier, opioids and the overprescribing of these things, I don't think we ever had justification for doing that. I'm sorry, but it was never appropriate. I remember back in the early 2000s, opioid-induced hyperalgesia was a thing. Anytime you poke somebody with your finger, they would say, ow, when you're about ready to do a procedure, and you knew that they'd been on chronic narcotics. You can identify them, you can know, and you're making their pain worse, right? Opioids are not designed to be used chronically. You develop a tremendous tolerance, and you create a situation that makes them unfixable when paradoxically trying to help them with their pain. And this has resulted in lots of opioid deaths. And the thing about opioid deaths now is that prescription opioid deaths are way down. The non-prescription or illicit opioid deaths are way up. But that originally was triggered and fostered by the prescription of opioids. And you could do it a bunch of different ways. You can give opioids a shot, transmuscular. You could do it transdermal with a patch. You could do it with a pill. You can do it IV. All of these are systemic opioid. The non-systemic opioid, or the targeted drug delivery, is intrathecal. Just like we have a blood-brain barrier, we have a barrier between the CSF and what's extrathecal. We put it in the CSF. We put it right by the pain, the dorsal columns and the rest of the neural network, the pain receptors that lie and are bathed by the CSF. And this is why it's called targeted drug delivery, because it targets the intrathecal space. And so intrathecal space, it turns out the pain reduction and pain treatment, and these are based on 3 level 1 trials, T.J. Smith, Peter Stotts, Lisa Stearns, and this is much better pain reduction, much less toxicity in terms not only of toxicity of side effects, but toxicity in general, and the survival. We know that in interventional oncology, if you take care of the patient's pain, you make them more comfortable, you automatically increase their survival. And we know from targeted drug delivery, this is much safer than systemic narcotics. This is about 1 to 100 in narcotic non-naive patients. So if you have somebody that's on 100 milligrams of 100 milligrams of morphine orally, it's about the same as 1 milligram of intrathecal morphine. And narcotic naive patients, it's about a 1 to 300 ratio. So this is utilization data. So pumps are expensive. I got that. Not as expensive as stimulators. In fact, they're about half the price of stimulators. And it turns out that treating patients for their pain based on whatever you do for pain, and it's primarily medication-based, that the crossover point is about 7 months, just shy of 8 months. And so the medication curve continues to go up. The pump stays static for 7 years, and you change out the battery, pop the hood and change the battery every 7 years, and this stays stable. And this is measured, this is good work by the late, great Lisa Stearns that measured this at all points, from the ER to outpatient to inpatient, all points of healthcare service delivery. And so to focus again on my radiology colleagues, this is, so you can do the diagnosis, you can do the biopsy of the tumor, you could put a chemo port in when you biopsy to be a malignant lesion, you could do ablations, you could do TACE, Y90, other embolizations, but you leave out the best thing in the world to take care of the patient's pain is a pump. And this is by far the best thing that we do for cancer. Just confining it to cancer is one of the 6 things that we really know that it's excellent for. So this involves just pocket creation. We do this with a bunch of different devices, including spinal cord stimulators. And we tunnel from the catheter placement, we tunnel it to the pocket, connect it, and then we refill, electronic analysis, reprogramming, and maintain that pump over the course of the next 7 years. So I want you to look at this list. Do you ever see patients that have severe spasticity? I think some of you guys do, some of you guys don't. Do you ever see patients with cancer pain? You ever see patients that have non-surgical pain? Think of the 80-year-old female primarily with degenerative scoliosis. Do you ever see those patients? You ever see patients with multi-site pain, neck and low back pain, neck, mid-back, low back pain, peripheral neuropathy? Ever see patients with arachnoiditis? I don't see them very often, but I see 1 or 2 a year. And the only common thing is the arachnoiditis has been missed. These are very apparently difficult to diagnose. People don't look at the cauda equina and see the clumping of the nerve roots. I think we do, don't we, Dr. Clerk? And it seems to be, maybe it's just the train, he's an interventional neuroradiologist, loves the cauda equina, and is able to pick up arachnoiditis. And I think other people can. Once again, patients that are unable, that are on high-dose oral opioids that are unable to reduce this. So does anybody see these patients? Yes. If you don't, they see you, and they see you every day or almost every day. These are not uncommon scenarios, especially the multi-site pain, degenerative scoliosis. This is a PSR registry data. This is comparing pumps and stimulators. Bottom line for the PSR registry, about at the end of life for a stimulator, about 60% of the patients want to have their stimulator battery replaced or some portion of their system to make it work again. Out of 831 pumps, only 4 patients elected not to have them replaced. Out of the 4, 1 had no pain, 1 had an infection at the site and couldn't have it replaced. So you have 2 patients. That's a replacement rate of 99.6% of people wanted to have their pump replaced. That's the best example that I know of about how effective this therapy is. And in clinical practice, this is exactly my experience. So why do we have the cognitive dissonance of some clinical conditions that are very common, and we have very few people putting pumps in? Well, I think it's a combination of things. This cognitive dissonance can really be explained by historical factors. So we've had past misuse of pumps and orals. So right when pumps came out, people thought we do intrathecal, and we combine that with oral, and that seemed to be better for pain control. Let me tell you a little story. We had a guy that was back in the day, this was 2017, he came in on 1,200 milligram equivalents of oral morphine a day. That's just insanity, by the way. But nevertheless, he wanted to come in for a pump trial. And I told him, this is very unlikely to work for you. Very unlikely. He was insisted. So using the 1-to-100 ratio, I usually give 1 milligram of intrathecal morphine or equivalent for every 100 milligrams taken by mouth. So that would have translated into 12 milligrams of intrathecal morphine. And I asked my fellow, well, what do you think? What should we do? He said, well, we're not going to give him 12. And I said, absolutely not. I mean, why? That's insanity for him to be on that much. We don't want to double down on the insanity by giving 12 milligrams of intrathecal. So I settled on 8. Do you know how I settled on 8? Maybe like this, 8 seems okay. So I gave him a bolus dose of 8 milligrams of intrathecal morphine, enough to kill this entire row right here. So what do you think happened to him? He stopped breathing. No, he didn't stop breathing. He did fine. And was pain-free for 2 hours. On hour 3, the pain started to come back. Hour 4, he was angry and checked out AMA. So this is an example about if you give somebody systemic narcotics, where is that digested? Where is it metabolized? It's metabolized in your liver, primarily by the cytochrome P450 enzyme. It turns out this is an amazing enzyme. I mean, there's nothing you can do almost to overcome it. This guy was taking orally enough oral opioids to, to supply this whole room for pain control post-op every day. So he had smooth endoplasmic reticulum from here to the sun and back. I mean, his cytochrome P450 was, running like a sub 2-hour marathon. And so there's no amount of this. And if you mix orals with pump, the pump can't overcome it. It doesn't have time. You put it intrathecally, it doesn't get systemic. It's metabolized systemically, but it's metabolized also by the liver. It will eventually become systemic, and it will be metabolized by the liver, and it will go away. And if you give somebody this amount of any type of systemic narcotic, you will short circuit the effectiveness of the pump by increasing the metabolism that will make it inevitably ineffective. So don't do that. Tradition. I've heard numerous of my colleagues say, don't do pumps, I don't like pumps. Anybody that says that is exactly the same person as saying, don't do kyphoplasty. It doesn't work. Magic, miracles, and kyphoplasty, not necessarily in that order. It's not one of the best things we do. It's the best thing that's done in terms of immediate pain relief, right? And so anybody that says it doesn't work doesn't do it. And I can bank on that. Anybody that says they don't like pumps doesn't do it to any significant degree, doesn't do it to, or has no knowledge about how to do it. So they say you're married to the patient. That's another trope that's just repeated over time. And I could tell the person that says these words doesn't do pump and they're listening to somebody else. What does that mean? Back to, I have acute sciatica. Would you see him? What if he needed 2 or 3 injections? Would you see him? What if you needed to do something else? Maybe perk discectomy? Yeah. Whoa, we don't want to be married to that patient. Hold on. So what does that mean? I mean, I see people that I've been in practice a couple of decades, and I see people routinely over and over again. I see also patients I haven't seen for a while. I mean, I don't know what that means, and I don't like the term. This means that the generation of people who don't do pumps are telling the next generation of people don't do pumps based on 0 experience. And you talk about the opposite is if you see people who do a lot of pumps, they love them. So you can always tell the experienced people because they like it. Pumps are complicated or complex. I've heard both terms. These are not synonyms. Complicated and complex are not the same thing, right? Complex are things that are complicated, but you can, as long as you know the rules, you can kind of work through it. Complicated are things that are unpredictable, right? Complex is a jet engine. Complex is our tax law. My wife is complicated. So there's a difference between these two. We have some people that put in pumps and some people that manage pumps. We do both. And I think the separation of the people who put them in versus the people who manage them, sometimes, problems are delayed to get fixed. Sometimes, it's the person managing your pump. That's why the pump's not working for you. It's the person that installed it. You need a catheter and rotor study. Something's wrong with it. So I think bringing these two together, manage them and install, troubleshoot, electronic analysis, reprogramming, catheter and rotor studies, do it all. Put these things together. And one of the things that's really interesting, it's not worth my time. I've heard this a lot. It's not worth my time. So this is CPT code list. Turns out that we're reimbursed for everything that we do, including the patient visit and every other factor of the pump placement and management that I just mentioned. everything that we do. And here are the numbers of reimbursement. You have year one, which includes the placement, and you have years 2 through 7 that include refills, electronic analysis and reprogramming, catheter and rotary studies. So for every patient, it's worth $2,587. And it took time to add all this up. These are accurate figures, and this is from my area. I'm in the same Medicare carrier as Chad Stevens. We're Novitas. And does anybody know what this is? We have anybody here with an MBA? Should have known. Present value of future cash flow. This is something they teach you in MBA school, and here's the way it's calculated. So if we have the present value, what's valuable now in terms of future cash flow, let's say we'll eliminate year one, and we'll just go to year two. Year two, you remember what year 2 was? You remember what the value per year of year 2 to year 7 was? $2,587, okay? So let's say you start off managing pump or 2, let's say, Gavin's up in Alaska and he's got, 20 pumps, and pretty soon after 3 or 4 years, he goes to a couple of hundred pumps. And so if we were to take this, the value of the $2,587 all the way out through the rest of the lifespan of that pump, using this formula, it would give you $15,000 per patient. Using a couple of hundred patients, this is your present value of future cash flow. So is that worth your time? The answer should be yes. If not, then you're playing in a different league than I think all the rest of us. But that is definitely worth your time. So we've reviewed all these, how to incorporate targeted drug delivery, the principle of the inverse pyramid, clicking down, starting with the least invasive thing, and ending up with the combination of the least invasive thing that helps patients. I can think of 6 categories, and these are categories that are mine. They're my original thoughts. I've also written a book about this, and they're in the book. And it's incorporated these. If you're not doing pumps, you're not adequately taking care of each one of these 6 categories. And then the strengths, the economic situation. So targeted drug delivery is just a natural extension of both benign care and both oncologic care, and very much a natural extension for certain subspecialties. It's highly effective, very sustainable, and very profitable. And I think this is absolutely essential to anybody who wants to be a pain practitioner, to take care of, be an interventional pain, be a minimally invasive treater. This is absolutely essential if you're going to be someone that takes care of the cross-sectional spectrum of these patients. Thank you very much. So let's, oh, okay. Does she know? She doesn't know. Okay. Does she want to come in here? Okay.
She's actually on the rooms.
Yeah. All right. So right now we are on time-ish. So Teresa from Boston Scientific, this is her birthday. And so we want to sing happy birthday to her, don't we? Okay.
Or
Yeah, absolutely. Does she want to say a few words?
Yeah.
Okay. All right, come on in. Happy birthday to you. Happy birthday to you. Happy birthday, dear Teresa. Happy birthday to you. Oh, thank you. Appreciate it very much.
No, she's been instrumental in getting our courses off the ground, and our pain fellowship, interventional pain fellows course in November, and this course as well. So thank you, Teresa.
No, Teresa and Boston Scientific have been absolutely instrumental in making this happen. So this is a sponsored course. Without the sponsors, there is no IGIS course. So for that, we really thank you very much. Thank you, Teresa.
Happy birthday.
Okay, let's take a break, visit the exhibits, and then we'll come back with optimizing surgical technique and the lecture here shortly. So we'll take a short break, and we'll be back in 15.
Great job, man.
Nerve-wracking. Because you're just waiting for it. Coach pitching. Oh no, so it's like, it's tough, yeah, they're not used to it.
How do you determine the location of the catheter?
Up to T4. So you get some cervical, and it tends to stay in space. You never have to worry about getting back. They're primarily
So I just saw a lady with esophageal cancer like 25 years ago. So
it's the only solution for so for, where's your, here? So I guess, I've gone to the cervical spine, C3, C4, because it tends to go, the action tends to go inferior. Yeah. It's not a good posture. No, it does, but the effect is better than good. But how would, so you would enter like T1, T2, and then go up to C4? No, you can tunnel it all the way from the bottom. I mean, it'll go all the way to the top. So you can start L3, 4, and get it all the way into the front of the back. Yeah, and it's a one, yeah, especially when you do that in your 6'2", whatever, so one especially. Yeah, she'll love you for it. I'll let you know how it goes. Yeah, man, appreciate it. Oh, yeah, Brunches. Yeah, he's a big local player.
Yeah. Okay, yeah, that's what I thought that was, right?
I talked to him. Wanted to do to get like.
Yeah. Yeah,
They swear to God.
yeah. Yeah. No, I like the. Yeah. I mean, I always thought like it would be interesting because there are a lot of patients that actually like fly to, let's say that they need like we're just getting like say sex medicine listening. But let's say I have a cardio stats, so if you kind of network somehow, but just like from an insurance perspective, I don't know. It's like I had the opposite issue. Special insurance, so I don't know but it will be interesting to kind of.
The things that are covered, they'll cover, they'll cover treatment.
Oh, yeah.
The things that are covered.
You need to justify.
I'm not sure, but I know, Medicare will cover some of that.
Wait.
I mean, it's.
We need to become the 50%.
It'd be good to see how much.
Well, based on the EBITDA, like yeah, let's say probably 50 Canadian.
It'll reach a stop.
All right, well, just with seeing how the practice change also with AI, like at some point it's gonna be like, it's not gonna work as much.
AI is gonna allow you to do more with less. So you have less people.
In this economy, no.
The value of a value.
It's gonna be just computers or whatever. So you're right, that's, I'll say probably more than 20 years.
That's what supervisors are. Keep my research. So I think this is where you may employ by somebody else. Using that to fill with all this research.
Yeah.
Research and make time. Use some common skills. Insurance is so expensive for me. Yeah. No, it is more. Let's do that. It does.
Because interestingly, in practice in Montreal, it's just like to sell. But sometimes I can't even find it. It's like when you see that, already when you are on site,
No, the problem is, if you manage, you don't have time to do it.
I know.
And you're trying to do your job, plus.
It's the babysitting.
If you get big enough. It seems like that's your.
It's just trying to get a business card person to help with the operation.
No, that's so true.
Always come back to me. So no, thanks for the introduction.
They think, well, no, it'll be okay. And they think, well, you know what, right?
It's good, like single payer system, like for the, I don't know what his number is. Yes, I read it on his profile. Yes.
Yeah.
So yeah, it's already like really big yearly you have numbers.
Oh, yeah.
It's already, yeah, it's interesting. It's surprising, like, to think like that. Public healthcare system is maybe some of the diagnostic condition.
I mean, even for a most of us, it doesn't really matter. It's easier to do it in a single payer system. What we have a single payer system.
Everywhere. That's my plan, but like it just requires like it's just like finding like the capital aspect is not too bad. If you have a baseline of basic problems that you can diagnose, you can have like take that out of events and then you have stuff.
you start with imaging, go.
So BC would be good.
Terrible. It is, they don't do anything. You pay the next one. I don't want to see that change. Until they. That may never. We may be clearly understaffed until you. And being understaffed. The same, but.
Yeah. Oh, yeah.
There's no cutting on the throat. I don't even know.
They cost things too, like, it'd be way too much for like, this. That's our. All those cases.
Career that's semi-useless.
Yeah, no, exactly.
I mean, you see what kind of impact.
We just started about 8 months ago and we're covering. So it's pretty busy. 2 weeks ago, I was like 6 weeks. And I'm like, okay, well, you know,
What do you do? You just gotta read.
well, we just started wrestling. We started as like versus the guys that have been running this for 15 years. You know, they're problems. Just like they were so yeah, that's why I'm like,
Yeah, I mean, just in terms of staff, in terms of personnel, it's going to be worse.
I know. The problem is that, like, when I finished my training, I was still doing 4-hour call shifts, and the after, so it's just now being moved to like so, you know, and you know, so if you just you have like a 4-day after that. So obviously, when we're covering, you know, two calls. Two overnights. You get sometimes 0 calls when they get call at like 2 a.m. You know, they need to read a chest X-ray. It's like it's a big deal. Like, dude, don't you have calls?
Oh, Yeah, so we'll do. We'll start this again. Start this one go. Yes. I think he's your coach. I knew he was there. I was like, he was familiar with this stuff. I just haven't in Chicago before. I basically, I think they just, he really gets super intelligent. You want to improve the solution that are running. Oh, I think if he's suspended, it's Friday.
And you're speaking with these kind of students at the radio and you're or have any reference in different use?
Start off with PRP tends to be more temporary.
Right.
So,
No, I
start off with PRP, then you
in stem cells, for example, like on the support cord in there.
Yeah, from the so the number of cells. 600 somewhere in there. Because he knows 18 so as long as you're getting stem cells. So it's getting in that
now we're using approximately 12 actually thinking about that. Also, I have read a paper about epilepsy stem cell therapy. The only thing that we have seen in our practice is that in the short term, let's say for example the first month or 3 months, the pain could be really high intensity.
That's true. I mean, this is long term. You can even get exacerbation.
Yeah, we actually, we're the first time, I think that in the country that we're putting into this called stem cell from we did 12 patients last year, and a bunch of them we had to do an MRI because they got like sanity sinus or herniatitis or something because the pain was very strong. Yeah, and then the next following 3 months it got better. Some people better than prior to the procedure. Some bunch of them didn't felt any more than before. We think that that's where we're going.
Just normal. You know, and then after like 6 months, usually pain will go up. 1 month,
and for management, it's steroids or
so after injecting pain pills, steroids, so I mean, just whatever it takes to get that pain down. If you can't get it,
and do you do any preventive discovery prior to the procedures?
So on this size is just, you come to me every 4 or 5 years, I'll inject usually 10 milligrams of this, 2 cc's. It's the same. So if I can take a pain, just walk like this. Same, extra low.
But you used to go by the MRI findings or the pain.
Young person, also actual back pain, actual column pain, one disc. But if you look at this, take the pain away.
Besides this guy, this is first because I actually find it with YouTube. So because there's like not like a fellowship or training program for interventional medicine. So besides this course, I have other recommendations for the doctors that come up here. And that's something possible without having like the medical degree, validated, do you have any place that you can go?
You know, depending on what you
Mainly my focus because pain management is in Costa Rica, our clinic specifies we specialize in spine problems, both cervical, thoracic, and lumbar spine problems. So that's what I'm doing. So that's why I'm doing these courses. So if there's a possibility, maybe I can get your contact if there's a chance that you can. Because everything that I have, I know is self-taught. I work with the nurse surgeons and hospital here in the US and courses. Erica will be 506. 85, 56, 52, 65.
Yeah.
speaker is that there's no it's just palliative medicine, and people tend to think that if I have to the pain doctor because there's nothing else to do and they're going to prescribe medication for the rest of my life. So that's what we're trying to is this kind of. You'll be very fine. Doing interventional medicine about a year now. No, I was a general practitioner and I started doing residency in cardiology, but then I got out and started working in
Yeah, so I train people anesthesia,
Stay away from the Well, at least like one people have basic should flare up fever. Now, so that's the theory of inflammation from your injections. Maybe you do something, or maybe from the injection. Maybe it's a response to the injection. Now, you don't see that, you don't see that. Like with those videos, you see better result with those patients. Yeah, I was, you know, that question about the
it is, like I said, it is a lot of like where I mean, Yep, I am the third of the 5 hires. One doctor has just hired 4 of them too, but then want to get the 2 so 3 cases. Yeah, I have been, I have done the one on. Yeah, you're coming as a little bit different. I want to say maybe more lateral getting into part. You want to make sure that you're really
Okay, you guys, we're going to resume the afternoon session. We're going to go until 2:30 when we will take a break, change into scrubs, and then go into the lab. Right now, we have in the lab Dr. Olivier Clerc, who is going to demonstrate the latest techniques in vertebral augmentation. Dr. Clerc.
We're ready to go. All right, thank you, Dr. Beal. So today we'll be talking about vertebral augmentation and some ways to improve the cement field and improve the outcome of vertebral augmentation. So we'll be reviewing 3 different medical devices, 2 that are classified as 2nd generation augmentation techniques and 1 of 3rd generation. So we'll be reviewing together the access for the Blazer, for the Kyphoflex, and the Spine Jack. So each of them have their advantages for different vertebral body. We'll be starting with the Kyphoflex, which is a articulated unipedicular balloon that you position within the vertebral body to obtain a better fill and create a more uniformous cavity. So we'll be starting with this one. So picture here. All right. And picture here. So we'll be starting probably at L4. Picture. Picture here. All right. Just a little skin nick here. All right. Picture again. All right. So all 3 techniques are transpedicular approaches. Picture again. And picture here, you can cone a little bit. Yeah. Little tap, tap here, picture. 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 Okay, so we can go lateral. We'll take a look if we have passed the posterior wall of the vertebral body. Obviously, what we're looking at right now, making sure that we're not breaching the medial wall for a classic transpedicular approach. So we should be in a good position here. For those type of techniques that, just like the kyphoflex, that we will be positioning a steerable articulated osteotome and then a balloon. We want to make sure that we're not too perfectly in the center of the vertebral body, so we want to be a little bit on the lateral side, so we have a very nice cavity creation with the balloon that will be inflated. So if we can just go toward the feet, just recenter a little bit the intro cannula here. So that looks like a very good approach. So what we'll do, we'll just make some minor correction here. So about midway within the vertebral body, you can go back AP just to show a little bit the positioning. During that time, we can, so we'll be working with the Medtronic X-Speed cement. So it's a very viscous bone cement that they are already preparing. During that time, I'll be taking the power curve that is a articulated osteotome that, if you can see here, by rotating the handle, you have a steerable tip that allows you to very aggressively have a direction within the vertebral body. So breaking down the trabecular bone and going exactly where you want to go. So this is what we'll be utilizing for this procedure to create first a channel where we're going to put also a articulated balloon. So if you can just raise a little bit the flat panel here. All right. And sometimes even in neutral position, you're gonna have a little bit of a curve within the tip of the articulated introducer. So sometimes you may want to straighten this introducer by going counterclockwise slightly. So this is what we just did. There is also a point to, well, two other additional points just to discuss. Your cannula will arrive flush with the first laser line. So you have 5 lines that indicates that incrementally you'll be able to advance with the mallet the power curve and while cranking further the osteotome. And you have here at the base of the blue handle, you have the direction of the osteotome. So we'll be introducing everything properly. If you can just raise a little bit more the flat panel here. Yeah, just raise it a little bit more. Yeah, or you can go lateral already if you want. Yep. So that should arrive flush at the first laser line. We have the direction arrow that goes exactly where we want to go. So picture here. Okay, and picture again. So you want to bring it out just slightly. Perfect. Picture again. Yeah, and now you can start to. So normally you want to do 90 degrees increments as just right before you tap. So a little tap, tap. until the next line. Picture again. And same thing here. Continue to advance. Picture again. Until the next line. Another 90-degree here. And as you can see on the lateral view, this is a very aggressive steerable curve. So it allows you really to almost be perpendicular to your site of entry. Picture again. Perfect. So now you should be completely articulated. So if you go back AP. During that time, we'll grab the balloon here. Perfect. So in that case, we could advance it even a little bit more. Okay, just raise up. So you can cross over the midline. Picture here. Perfect. And that looks pretty good. All right, so where you want to, so now we have this cavity that is created, that's this channel that is already created. What we'll do the opposite step, so 90 degrees, pull back a little bit, 90 degrees, pull back, 90 degrees, pull back, until we can completely get the osteotome out. And then there is normally a sheet that is covering the balloon that, in comparison to a lot of other medical device, we just throw out those sheets. This one we want to keep it because we can reuse this balloon for other levels, which is an important point. This is a balloon that has a low compliance and high pressure, so it can go up to 700 PSI. Due to the low compliance, we can reuse it at multiple levels, which is a great asset to have if we want to do kyphoplasty at multiple levels. So we'll just put it back. Again, we have a marker right in the mid portion of the balloon that will allow us to know when we'll be at the tip of the cannula. And we should be, if you go lateral here, perfect. All right, so just like the articulated osteotome, this is also a steerable balloon. So you advance it a little bit, and there's a butterfly handle also that will allow you to steer in the right direction. So you already see one of the markers that is out. So you can advance a little bit and then turn at the same time. Picture again. Picture. Okay, and picture here. I'll just retry, I think. Picture here. Picture. Picture. Ah, perfect. So you see right now we're within the channel that we created. So this is a, by the way, 20 millimeter balloon. So you have different type of balloon. We're treating a L3 vertebral body, so we could have used a larger balloon, but it goes in increments between 15 20 and 25, so probably 25 would have been great to use in that case. If we go back AP just to show where the balloon markers are located, and some of the viewers may or may not see, but this is actually, there was a memory on the C-arm here that, or there was. So while we position this, let me just talk a little bit about this C-arm. So it's a C-arm by Philips that was gracefully brought for the occasion today. These are Zenitium 90, great C-arm to use clinically. I've worked with those actually for the last couple of months. So they come only in flat panel, so great image quality. It significantly decreased the dose also of radiation. And the image quality is actually quite impressive. So they come in larger footprints, so either 21 centimeter flat panel or 30 centimeter. This is the largest one. And we are back where we want it to be. So perfect. All right. So well positioned here. Could be a little bit more midline where we could have used a larger balloon if we had it, but it's a great first location. And we can go back lateral. We'll start to inflate. Yeah, picture. Picture. So in the lateral, you want to make sure that the both markers are out, obviously, of the intro channel, the intro cannula, which it is a case. Picture again. Picture. 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 Perfect. So normally we can set a little bit the balloon here to create the cavity, and then we should be ready for the cement right now. So we'll get and picture again. Perfect. So and prior to bringing back the balloon, you de-articulate the balloon again. And picture. And it's slowly coming back. Perfect. There may still be a little bit. There we go. Perfect, and it should be ready to inject the cement. Thank you. So this is the Medtronic CDS cement delivery system. So we'll go take another shot here. Picture here. Can go up to the cavity. Perfect. So we'll start to inject slowly. So we're raising the pressure within the system. Picture. It should be filling very nicely the cavity that we're creating. Picture. So this is a very viscous bone cement, so high viscosity, so great for fracture cleft. Picture again. Picture. And we're able to fill completely the cavity. All right. Picture here. All right. Obviously, we would continue to inject and fill completely the bone cement, but for sake of time, we'll be stopping here and passing through the next medical device. Picture. Yeah, perfect. So there is also a release mechanism to decrease the pressure. So this is something also that you can use when you feel that there's too much of a buildup of pressure within the medical device. So what we can do. Perfect. And then if I have just a stylet, should be this one. And we'll give you just perfect. All right, so let's go back AP. So we'll go, next medical device that we want to take a look is spine jack. So spine jack has been on the US market since 2018. FDA approval, but we have actually multiple more years of experience with it. It started in the EU in the 2010, so we have now 15 years of data already. So great to restore vertebral body height, great to decrease the adjacent level fracture, and great to decrease the pain also related to fracture. But more importantly, by correcting the kyphosis by re-augmenting a little bit more the vertebral body and decreasing the kyphotic angle, we're able to decrease also some of the load that we have on the facet joint. So really, over time, it seems to be great to better improve the sagittal balance and decrease also the facetogenic pain that we see in patients, and it also prevent earlier and younger patients to develop facetogenic pain. So what we'll do, we'll just angulate just a little bit more toward you as our AP. Just a touch, yeah. Picture. That's probably too much. Just come back. Yeah. Perfect. So we'll go at L3, come back again. So just spinous process in the center here. It was just slightly off. Picture. Picture here. So for the spine jack, we want to be a little bit more flat than a typical balloon kyphoplasty or vertebroplasty. So we really want to arrive at this 3 o'clock, 3 o'clock and 9 o'clock position. So we really want to take advantage of the lift picture that we'll have from this medical device. Picture again. So I spent a little bit more time just making sure that we have a great entry point within the vertebral body, because it does save some time afterward. Picture. All right, so let's go lateral here. So a lot of the data that we have now for spine jack comes out of the SACOS clinical trial. Picture. And some of the points that I previously mentioned, picture, are indeed some of the findings of that study. So you can notice here that one pedicle will be slightly lower than the other one, is slightly lower than the other one because there's some scoliosis within this patient picture. That looks perfect. Okay, let's go back. Great. And picture here. And picture. 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 And does not need to be so perfect at the beginning. It does save some time. However, we'll show you the reamer with the reamer picture. You can just cone a little bit more. Picture. And this one, picture. Picture again. And picture. Picture here. Picture. 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 And picture here. Okay, picture. Super. Let's go lateral. Yeah. So still pretty frozen here. Picture. There you go. All right. Perfect. And then we can go back AP. So after that, there's a series of blunt K-wire that need to be positioned. I'll just move some of that stuff here. And that looks great. So again, we're not breaching the medial wall of the pedicle. This looks good. Normally, okay, and this one we're already perfect. Let's go lateral. Yeah. So at this point, we can do the exchange picture again. Oh, one that is not yet there. Do you have a bevel? Just a bevel tip, no. Picture. Yeah, perfect. Okay, and if you can just demonstrate a little bit more the ventral wall. So just go down a little bit with the C-arm. Yeah, perfect. Yeah, good. So again, normally I like to see them perfectly parallel, but there's a rotation within this, this patient due to the rotoscoliosis. So we can put the, and once you're well positioned, the rest is pretty straightforward. So you removed your intro picture here. Yep. You want to remove your introducer, and you make sure not to breach the ventral wall of the vertebral body. Normally, you can position them about 50%. This patient is very, the level of trabecular bone seems to be quite low. And portion of the vertebrae is still very frozen. Picture. Picture again. Okay. So when I do see that in cadaver course, we expect that it's going to be difficult with the reamer. I'm trying to get the cannula out without losing my track.
Whenever you do this, you have a tendency, real tendency to yank harder. And you do that, you'll pull your pen out. So pen and pull, windshield wiper, you see, he has perfect technique. It's just hard bone. Anytime you put in, instead of tap, tap, you hear a tick, tick, or you hear a squeak as you turn the jamsheedy, you know it's very hard bone. Actually, clerk many years ago was a fellow of mine. We encountered many such things as that, so we'll see. Sometimes you just have to pull it all out and you can reestablish the hole. But that's pen and pull, and always use the alternating rotation.
Just go back, hey,
Windshield wiper technique when you pull that out.
Yeah, maybe we'll just do that. All right, picture again. Just find back the picture here.
There it is.
Just lost that track there.
Looks like you're right back in the same track.
Oh yeah. And that does happen. However, normally we have a little bit less difficulty getting our the cannula out, and should be done there. Picture. And this one, this picture here. Picture here. Yeah, perfect.
There you go. It's not bending, you're just pretending.
So at this point, you want to expand a little bit the incision in which you will be using the reamer. So the reamer, that is a medical device that will allow you to create a larger channel to be able to put the jack. So this is a jack 5.0. So they develop about 700 Newton of force to lift the end plate.
The reason it's
And
called,
what we'll do, we'll just go lateral here.
the reason it's called a reamer and not a drill, although it looks like a drill, is it's fluted on the side and will cut, makes it directional. As long as you're advancing, you can change directions with the reamer.
Yeah. And now we'll advance as much as we can. Okay. I just need to see a bit more the ventral wall to just bring everything down. Yeah.
You do want to control the distal tip of your K wire.
Sure. Yeah, and that looks good. Picture here. Do the same thing on the other side. I just grab the other introducer. So same thing, need to expand a little bit the skin entry point. And then we'll see if we're able to
Okay, where it's bent a little bit. So
accommodate. This side is finicky a little bit. So what we can do, we will do, if you go back AP, just go back AP. Picture here. A little tap, tap. Okay, let's go back lateral. Okay, you can go back lateral. Okay, and picture here. And picture.
So that reamer is pretty aggressive. It'll go right through that hard bone.
Yeah, this side is pretty frozen.
Yeah, you can tell it's hard. I just want to try to prevent your K-wire from advancing.
Yeah.
And
picture here.
So what happens if you advance the K-wire into the IVC?
If we advance the K-wire to AVC,
no, I'm just
not
talking
a lot of
crew,
things.
Crew in here, Olivier. So
what we'll do, we'll go back AP, just make sure that we're well positioned on each side.
So what happens if you
before
advance
we
into the
advance
IVC?
a little bit more?
Nothing. Here's the difference. You ask, there are two categories of physicians, two specialties. One, a vascular surgeon that's doing an ALIF procedure for
let's go back
Dr.
to
Scheiner
lateral.
over here. And an IR is putting, let's say, a big, gigantic catheter in the IVC. So you poke a hole in the IVC, what happens? Vascular surgeon, go ahead, Livia.
Nice thing, we're just passing the posterior wall. So now we want to correct a little bit more laterally, and that's to be quite equidistant on both sides. So what we can do, picture. Yeah, I think this side is just too frozen.
That's hard.
For the purpose of time, we'll position the jack, and we'll show the rest. We prepare the cement.
Can you talk about when you would really be using this versus balloon type?
Picture here.
So spine jack the question is when we'd use this as compared with balloon kyphoplasty. And anytime you really want to reduce the vertebral body, this is what you reach for. It's not even close, the ability to reduce the fracture. So for years, I was a big balloon kyphoplasty user. Now I've gone to using just vertebroplasty or spine jack.
Just recenter a little bit more. Yep.
And whenever the fracture, I need to reduce it, I reach for the jack. And whenever it's non-compressed but fractured, as it happens, I'll just do a vertebroplasty.
Yeah, can you just go up? Can you just bring the arm a little bit more?
For in hard bone, for like if you ran your car into an embankment on I-35 or I-10.
Picture.
And you get a burst fracture, these are really good.
And then bring everything down.
You can use them with hardware, you can use them as standalone. In osteoporotic bursts, these can be used as standalone in Magarelli 3.3 fractures or AOA4 type fractures.
Picture.
And as Olivia mentioned, these things have 700, 750 newtons
Picture.
lifting force. I mean, if you put them under your shoe, it'd lift you off the ground.
And opening up the jack is as simple as this. Very classic also appearance of the skis that will create that lift force, that you have less trabecular density, more ventrally within the vertebral body. So very classically, you're gonna have this kind of inverse wedge shape, really demonstrating that this is a patient that has severe osteoporosis. So very classically, you'll be able to see this angulation within the jack. We'll be injecting the cement very shortly. Maybe we can go back AP and do the other access for the blazer.
The skis, the deformity there, you see that's plastic bowing deformity. The jack is made out of titanium alloy, so it's not firm. It's designed to do that. It's made out of titanium alloy, which is Ti6Al4V, so titanium, vanadium, and aluminum. So it's designed to do plastic bowing deformity. So it's kinder and gentler to the end plate that it pushes up against.
So we'll open up the other one, the one that would have went into the right side, because we'll be able to see the cranial lift here. And also where the cement does exit, which is in the total distal portion of the entry cannula right there. So this is where you'll be able to have a good feel while you inject the bone cement. So perfect. We'll go back lateral. Whenever it's time to start the injection of cement, so you turn back counterclockwise about 3-4 times, and then very easily you can retrieve everything here. And then inject the bone cement as needed. Yeah. And as you inject, often there is a buildup of pressure within the system. Picture here. Picture. Yeah. Picture again. Yeah.
So the kind he's using there has a collar attachment. It attaches onto the
picture here.
Channel. What you saw is it dislodged the working channel as the hydraulic pressure from the cement kicked back, and so he's pushing it back down. It's a collar fit onto the spine jack.
This is something you just need to be mindful of, and you would continue to augment this side and the other side afterward. Whenever it's time to get the system out, so very easily you can just have a rotation of the introductory cannula and pull back, and then you should have the final result right there. So we'll go with the next medical device, which is the blazer. We can go back to AP.
So remember, when you disconnect this, always twist it, because cement doesn't have any resistance to shear force.
Doug, you've done a lot of work on various balloons
Here, I'll just grab
through the years, right?
Yeah.
And
So the
why I think
third
that there was also
medical device that we want to showcase
Find that
here
This is better.
is
Better
a
device.
curved nitinol.
Yeah, the Sacro's trial was better in terms of pain reduction compared to balloon kyphoplasty, 1 in 6 months, which is saying something. So it doesn't matter to the size of the device. Maybe that has something else to do with pain.
So the next medical device is the blazer. This is also a cavity creating device that has a very thick nitinol channel that will allow us to create cavity in different direction of the vertebral body. So vertebral bodies that have heterogeneous bones, sclerosis, sometimes when you have difficulty to reach some of the fracture cleft, you can use the blazer to be able to access those different areas of the vertebral body. So it is, again, transpedicular approach. We use a 9-gauge introducer in that case. Picture here. Picture.
This is made by IZI. So this is previously a product from Benvenue. Benvenue was sold to IZI.
Picture here.
And IZI is now owned by Halma to make it more confusing for you, just to add to the level of confusion. But
picture here.
But this directional cement and cavity creation, cement delivery is very, very nice. By the way, if anybody here needs access to any of these products and you don't know who to contact, just let me know.
Picture. We'll just go lateral. Yep. So again, for this one, you may want to put the tip of the needle perfectly in the center or a little bit more lateral if you use a, now we can make some correction here. Picture. Yeah. Okay, let's go back. Let's go back AP. So by being perfectly in the center of the vertebral body, you can use the medical device both on the right lateral portion or the left. If you're a little bit more, let's go back lateral, yeah.
To finish what I was saying about the IVC, the difference is if you have an open case and you nick the IVC, the patient dies, or you have to have a heroic save. If it's a closed case and you make a big hole in the IVC, nothing happens. Pressure difference, the retro.
Perfect.
And if you put that into the, let's say you put the K-wire into the aorta, what would happen there? Nothing. Nothing. Remember, we used to do lumbar aortography with a 17-gauge serrated needle. And then after we'd squirt the contrast into the aorta, what would you do then? Just pull it out. Nothing. Tamponades itself. So don't have to get too excited about things.
So on the blazer also, there's one arrow that allows you to understand where the thick nitinol channel will be exiting. So again, want to make sure that, so right now, I'm a little bit more in the center of the vertebral body. So, okay, let's go lateral here. Yeah. Perfect. Perfect. Picture. Okay. Picture. Yeah. All right. So the arrow is located right here. So now if we are to open up the medical device, should see a nice picture. Cavity created there. All right, so let's go back AP just to showcase a little bit where this is going. And we should have this cement ready. This is the IZI cement, the VertiFix cement.
Through that same cable.
This cement has aggregate of barium sulfate. So it is a little bit different than other bone cements. which you'll be able to see when we are. So this is a good example to be able to cross easily the midline on the image here. And that bone cement is a medium viscosity cement, so about 350 Pascal seconds. So as you can see here.
Almost sounds like the perfect cement, Dr. Clark.
Yeah, it is. We'll go back lateral, and we'll be injecting a little bit just to show in live fluoroscopic evaluation what does that cement look like.
This kind of has a signature sign. You'll see the cement has barren particles in it, as he was saying. So this is designed to be able to see visually the flow. So you can see the barren particles like ants marching 2 by 2 down the cannula.
Picture here. Picture here. And picture. And picture. And picture. There you go. Picture here. Picture here.
This comes out of
so you can already see, for instance, this is a great example. So you see a little bit one of the lumbar vein that contains a little bit of cement. So some of those barium sulfate aggregates can very easily help you detect some of those leak. So for instance, in that condition, I could pull back, reposition more inferiorly the blazer, and inject in a different portion of the vertebral body. So whenever you have challenges like that in the classic vertebroplasty, either you use a contralateral perpendicular approach or transpedicular approach, or you can reposition, in that case, a blazer very easily. And just to note, this is coded as a cavity creation device, so a kyphoplasty. I think we will be stopping here. So to get the blazer out, you get rid of the nitinol, the curved nitinol portion, and there should be an introduction stylet somewhere. Perfect.
Well done, kind sir.
Perfect.
Questions, comments? So what is your choice of vertebral augmentation that you use, or is it done on a case-by-case basis?
It's really case-by-case basis. So we're moving away to, for the longest time, we treated compression fracture purely for pain. And now we have medical device that, yes, all will take care of the pain reduction, but also can improve significantly function and will decrease mortality. And part of that mortality data that we've seen recently was related to pulmonary infection, so pneumonia, decreased cardiac output also because patients could not breathe adequately. So height restoration is really something that we now focus more in some patients. So it depends on the patient. So if we have a thoracolumbar junction patient and a young patient after MVA, for instance, I would go with a third generation augmentation procedure, so a spine jack, for instance, to really try to restore the height as much as possible. Spine jack, I didn't mention it. It's indicated for type A fracture, so type A1, A2, A3. More and more data that comes out for the A4 compression fracture. So this is something that we'll see also in terms of utility in the future. At the end of the day, height restoration, correcting the sagittal balance, and also trying to fill as much as possible the vertebral body. So whatever, depending on your case, if you have a very heterogeneous bone, for instance, the blazer could be a good option, or using another type of kyphoplasty to be able to fill more the vertebral body. We know that pain relief decrease drastically with the amount of cement. It's the best modifier for pain relief, the variable that we have the most impact on that can decrease pain.
Fantastic. Great job. Yeoman's job with 3 devices and a C-arm to talk about. So next time, let's make this into 2 separate sections. Great job, Dr. Clark.
All right, thank you.
Okay, next up, I'm going to talk a little bit about minifying existing procedures and the impact it has with credentialing, coding, and billing. And so this is topic, here's my disclosure list. I'm a very conflicted individual, obviously. So we'll talk about credentials, malpractice coverage, talk about how to make a code, how to make an ICD-10. We'll talk about the billing and everything else that goes around this. You know, credentialing is local. It's your hospital, your ASC. It's all very local. And because I have 9 specialties listed here, and so, you know, we've got physiatry here, I'm in IR, we've got orthopedic surgery over here, and this is just in the front. Front couple of rows. So there's 9 different specialties. A lot of things that you're going to be credentialed for will be new. They'll be minimally invasive. A lot of these things haven't been done very much. So the credentialing is difficult. How do you make sure that a physician has his level of competence? How do you make sure that he does it safely when most of the people in the credentialing committee have never even heard of any of these things? Well, it has to do with the data that goes behind it. So data is very important. Letters of recommendation and proctorship will be very important. You have to collect data, the courses that are run by societies, courses that are run by industry, courses that are run by Seattle Science Foundation. All of these play a role into educating a credentialing committee in order to give somebody credentials. And so you can facilitate this from a number of different ways, and it's all done to determine a base level of competency. And I can tell you from personal experience, this is very difficult for new procedures, multitudes of different specialties. And as I mentioned, we are past the toe of the curve. We are now on the sharp upward tick of things like this, all the way from SI fusion to intradiscal hydrogel. And the pace of this will only continue. One of these things, if you're going to start doing things like I mentioned, including this interspinous decompression spacer, this was demonstrated earlier by Dr. Stevens, are you covered for this? Or do you have insurance coverage for this? This is coded as a 22612 and a 22840. Does your insurance, is that okay? And I can tell you, I've had probably 5 different insurance coverages over the course of my career. We changed due to various reasons, mainly cost of insurance. Sometimes they'll cover this, sometimes they won't. And if your insurance doesn't cover it, you need to get an insurance rider or an insurance endorsement to cover this. So you need to make sure, protect yourself. If you're thinking to yourself, I'm doing something, I don't know that this is covered or not, do something radical like read your policy. It's available to you. You pay insurance premiums for that policy. If there's any questions, you can reach out to the insurance company. If they don't cover it, make sure and get an endorsement or a rider or a different insurance. So category 3 codes are the way that this is new technology is introduced. This is basivertebral nerve ablation. I'm going to use this and Viadisc as ways to get a category 3 code. And a category 3 code, all you need is just some provisional data, society sponsorship, and you can get a category 3 code. And then when you're awarded a category 3 code, you collect data and sufficient data, provided you have that, plus enough usage of your temporary code. Category 3 is also called T code, stands for temporary code. You get awarded a category 1 code. And this is how it's done. So people say, you know, I've heard this as well, it's hard to get a new ICD-10 code. Well, it's hard to get a new CPT code. Well, maybe, but what about basivertebral nerve ablation? We've got 54.51 vertebrogenic code, and we've also got new discogenic codes, which I'll talk about in a second. We've got 6462829 and a 06217. All within the past 5 years. And that's not all. I mean, there's more of the coding. And so not only is this possible, it's very doable. And the better you understand that, to the higher level of granularity means you can get new codes for your procedures, meaning you can get good reimbursement assigned to those codes. And so this is an example. To get a category 1, it's no mystery. It's right here. So you need between 2 and 5 publications, really 5 in a de facto sense. You need to have no overlapping data and authors, and at least 2 of those. And the minimum level is Oxford level 2A. you don't even have to have a category 1 as a minimum level for new codes. So this is very doable. So how do you get paid for it? Well, here it is. You calculate RVUs. You calculate how difficult it is to do your device, and that's work. How much it costs, that's practice expense. How risky is it? That's malpractice RVUs. Come up with the total RVU, multiply that times a Medicare conversion factor, which is just a little bit over $33 currently. Should be a lot bit higher than that, but that's another topic, another discussion, to get the total payment rate. And this is how these are developed. The new category 3 or T codes are alphanumeric 0627T is a good example for Viadisc. And then we submit this and we calculate the RVUs, and this is how you get a new code, and this is how you assign payment for that code. So these are examples of new category 3 codes that were awarded to Viadisc for effective January 1st, 2021. And keep in mind that category 3 or temporary codes have no global period. They have no physician payment. These are assigned by each of the Medicare MACs, so just know that. And so if you're doing this in an ASC, know that you're not going to have a carve-out physician payment for this. You're just going to have a global. And so you need to have your physician payment, depending on how that was worked out, depending on whether you do it in an HOPD or an ASC environment at 22 or 24, hospital 22, ASC 24 in terms of Medicare speak. And there will be no global period assigned as well. Global periods are assigned after category 1 is awarded. And so you have the category assigned, the CPT, and the CPT we'll get to in a second. Well, it's listed here. To match that to an ICD-10 code, the discogenic code, we'll talk about in a second, it's assigned to an APC, an ambulatory payment classification category. You can see them listed up in the upper right-hand corner. 5115 is the one associated with this. It only goes to 6, level 6 codes. In the ambulatory payment classification, the code is on the left, the dollar payment is on the right. So the higher the level of code, the greater the degree of reimbursement. And they get this reimbursement by crosswalking to codes that are similar to the ones that were being looked at. So the Viadisc, the augmentation, the intradiscal augmentation using morselized allograft mixed with saline, the crosswalk for the intradiscal augmentation was vertebral augmentation. And the reason the reimbursement is so high is this is made out of donor disc. So there's a very finite amount of material for this. Therefore, the cost is higher because, we're not just manufacturing disc material in some lab in China. I mean, this is actually taking Viadisc, gets theirs from Dade County, Miami-Dade County. And there's only a population of 8 million people down there. But this is how the sausage is made. And then once a category 1 is assigned, then there'll be RVUs, there'll be a global period assigned to it, and the 51.36 for lumbar, 51.37 for lumbosacral discogenic back pain. This is new codes that are ICD-10 codes are assigned. And during our discussion with this committee to assign these codes, we were saying that we're talking about anterior column pain. Statistically, this is approaching 50. It's between 35 and 50% of all patients you see. And he said, well, why is this important? Why does this get a code? I said, well, again, this is the most common cause of back pain. And the most common cause of back pain currently does not have a diagnosis code. It doesn't have an ICD-10 code assigned to it. You hear a 3-beat pause. Oh, okay. Maybe that, and that's, you can see the light bulb go off. Maybe that's why we need a diagnostic code, because this is the most common cause of back pain. So again, CPT codes. I mentioned these codes for the Minuteman 22612, 22840. This stands for arthrodesis and posterior non-segmental instrumentation. It's associated with a reimbursement. This is also associated with a code description and the code description. So it's important to know the code, to apply the right CPT code to your right procedure that you're doing. And sometimes it won't be so clear, especially if you're one of the pioneers, and you guys, I'm sure, are the pioneers. That's why you're here. So just make sure and match the CPT code to what you're, the appropriate procedure that you're doing. And so it has a code descriptor, and you have to mind the code, meaning you have to pay attention to the code descriptor. You have to pay attention to what is in the code descriptor to make sure you're adequately performing the work as it should be performed for that CPT code. For example, 22612, that has with it that the area of fusion has to be directly visualized. Doesn't say how. You don't need to be doing it open, because this is capable of being done open, but we're just not doing it like that. So you have to make sure and directly visualize it using an endoscope or something else. And the 22840, and includes the details of spinal decompression, meaning if you're decompressing, you have to describe how and why. So this is mainly the how. And this is to mind the code to make sure what you're doing matches the description of the code. Shift gears, hospital, inpatient, DRG assignments, and this makes a difference as to what the hospital gets paid for DRG assignments. The main differentiation, and I didn't know this embarrassingly for years, I remember listening to a talk, Pierce Nunley, who works out of Louisiana Spine and Pain, says, you know, you should mention your comorbidities. I'm thinking, you know, I do, kind of, you know, I think I'd get most of them. But with comorbidities and without comorbidities, with comorbidities, without comorbidities, with comorbidities, without comorbidities. So it makes a huge difference on what you are reimbursed for through your DRG grouping, whether or not you mention comorbidities or not. In fact, it makes a bigger difference mentioning comorbidities as compared to the number of levels that you do. For example, a one-level fusion with major comorbidities listed can make a bigger difference in what your hospital gets paid as compared with the number of levels you do. That can be reimbursed more than a two-level fusion. So this is incredibly important. This is incredibly important to know. If you work in a hospital, the hospital will view you as these numbers down here, not necessarily as they view you as what you can bring to them. And what you can bring to them can be almost doubled by just knowing the fact that you have to mention some of the major comorbidities. So this is a good rule of thumb. Please do that. So fusion and non-fusion codes. Non-fusion codes are different. For fusions, you have to mention where it is. For non-fusions, you have to do the right code. For graft, 20930 if it's an allograft, and 936 if it's an autograft. Be sure to list, if people are reticent to list 28999 because it's an unlisted code, we're not going to get paid for it. Well, not really. You have to, some private insurances use this for hardware. So the hardware you put in, you'll put it in as an unlisted code, describe the hardware. This will be billed back to the commercial insurances. You will get reimbursed for it. So make sure and avoid the use of a non-listed code in certain circumstances, but realize that you'll have to use the unlisted code to be billed for hardware. So this is very important. Shifting gears again for endoscopic discectomy, the 62380 code, this was released in 2017. This is for decompression. And this is important that you use the code for decompression. It currently is undervalued, but to combat that undervaluation, we're doing a rash analysis. I won't go into the rash analysis, although it is very interesting. And this is done to revalue these codes. We are surveying different specialties. How much work does it time, using the RVU method here, multiply times the conversion factor. And we're going to try to increase in the value of this code, but this code is tremendously undervalued. The 62287 code, this is a discectomy code. This is not used very much in Medicare because, as I mentioned earlier, the people that are having disc herniations that get a 62287 are, you know, your age. They're not 65 and over. So this is used a lot in commercial insurance. This is a really good reimbursing code that was about ready to be sunset this year. And I won't go into that, but, you know, thankfully people were paying attention. They called us up and said, hey, what about 62287? I'm like, no, don't sunset that. I mean, do not, because that's a really good code. It's not listed very much on Medicare, but go into Blue Cross, go into United, take the utilization from there, because this is This is something that does not need to be sunset. Endoscopic discectomy. Coding for SI joint fusion is like a soap opera. This is never-ending battles, I mean, between surgeons and interventionalists, and people want to get this code, want to do that code. And what ended up happening in the most recent CPT committee is 27280, the open code, is the same. The 27279, the MIS code, is anything that transgresses the ilium and the sacral cortex, regardless of the direction, lateral, posterolateral, or posterior, as Dr. David demonstrated with the fins or the tines. There's another device called the TFX that has screws that go across. Those are all 7.9. 7.8 is anything intra-articular regardless of material. Cortical allograft, the N1 that he showed, not the N1, the Liberty that goes down into the joint but does not span it. There's no special tines, fins, or screws that go across. Patriot, sorry. So they have two of them. I got 50, 50, 80. So Patriot goes down into the joint. That will you be demonstrating this?
It's kind of in there for the hands-on session.
Gotcha, hands-on session. You'll be able to see that. And not only are the codes hopefully ensconced now, and they're at least with some degree of permanency, the minimally invasive procedures work better than the open procedures in terms of operative parameters and even outcomes. So these minimally invasive CPT codes and SI joint fusions are hopefully here to stay. And again, the criteria that we talked about this morning for the NAS criteria, I won't go over those again. Those have been adequately discussed. So in summary, credentialing is important. You will sometimes have to get additional support. A lot of times this is where turf wars happen because this is local. And so you have to battle it out with letters, proctorships, different courses, different letters of support, different mechanisms to support you to demonstrate your level of competence for that procedure. Remember malpractice insurance riders, insurance endorsements. This is important. Make sure you're adequately covered for this. Understanding how to code and how to diagnose and the appropriate diagnostic code associated with the procedure, the appropriate CPT associated with the procedure will help you stay clear of running afoul of anything in terms of inadequate or inaccurate coding or billing. Know what the requirements to convert a Category 3 to a Category 1. It will help you get reimbursed. It will help you contribute to other people's reimbursement. And pay attention for the DRG purposes for documenting comorbidities, major comorbidities. This is very important in terms of the hospital getting paid and in terms of you getting the adequate reimbursement. The endoscopic discectomy code is 62287. If you're doing that, use it. It almost died because of underreporting and underutilization. It's a great code. And then coding for SI joint fusion, hopefully that will be toward the final stages of being permanent. And what I mentioned to you in terms of transgressing the cortices, being intra-articular, this is a 7.9 and a 7.8 respectively. Hopefully that will be that way for quite some time. And as we minify everything, what we're doing now is we're in a phase of rapid development of new products. That's one. We're in a rapid phase of minifying existing surgical procedures. And so this creates a confusing amalgam of credentialing, coding, diagnostic codes. But as we move forward in this, the minification of existing surgical procedures, we've demonstrated over and over again with the data that we presented, not only can we do the procedure more safely, more effectively, better operative parameters, shorter time, but we also have better outcomes. Thank you very much. So are we going to?
I'm going in there, Doug.
Okay.
I was kind of running now, getting ready for the next one, but
sure.
Did you mention with the ICD-10s for spinal fusion that you cannot use spinal stenosis with neurogenic claudication as the primary coding longer as of March of 2024? Did you mention that?
No, I did not mention.
Do you think that's important to mention?
Yeah, go ahead. A little bit more on that, Chad.
So if you're doing any of the spinal devices that are meant to be minimally invasive fusion devices, back like in the years previous, case. We would sometimes use our primary code is an M48.062, which is the code for neurogenic claudication and spinal stenosis. In March of last year, the LCD was put out that said you can no longer use as a primary diagnosis, and oftentimes I use it as a secondary diagnosis. So you're going to want to learn, you're going to want to use codes like M43.16, which is the code for spondylolisthesis at a lumbar segment. And then there's another one that's called spinal instabilities. It's an M51 something, AA something. But one of the instability codes needs to be your primary code, and you can back that up with a degenerative disc disease or another secondary code. But that's something that kind of, unless your coder brought it up to your attention, or unless you do a lot of this, you might not have caught on to that. But it's a really big deal because they're concerned for any kind of clawbacks if you're using the wrong primary code for an ICD-10. So that's something I just wanted to make sure we highlight here.
Good.
You found that to be true?
Absolutely. So this is true across the board, not only for Medicare patients, but for especially commercials.
Yes.
And, the pre-authorization, the pre-approval, if you don't have an instability, then they will be telling you shouldn't be doing a fusion. And to my opinion, that's exactly right.
Instability marked by dynamic changes with a translation of 3 or greater millimeters.
Yeah,
Correct?
exactly.
Yeah, but that applies to the minute now, not necessarily to the verteflex.
That's correct. So vertiflex is strictly a stenosis spacer. Yeah, it's a different code. So all the other, right, yeah, you use spinal stenosis as primary code for that. All of the fusion spacers that we've demonstrated here, including the Minuteman, Zip, Inspan, just all the fusion spacers have to have an instability code listed. And you shouldn't be doing it unless you have a certain degree of instability. Set gapping, spondylolisthesis, dynamic translation, sagittal femoral translation, anterior disc widening. So that was one of the things that was brought up earlier that Dr. Stevens brought up. I find, and learned this from Dr. Clerk, is that anterior disc widening is probably a more reliable sign for spinal stenosis than virtually anything else that we have. And you only see it on dynamic imaging, and usually dynamic imaging that is done in a specific way with stabilization tools, AI stabilization tools. Yeah, I mean, it's very, very interesting stuff. And we're on the cusp of learning. I don't really think that this is known. What we know now is based on data from White and Punjabi back in the 80s. And believe me, that's good data, but we don't know the whole of the topic. So when we see somebody that doesn't really have dynamic instability, but yet, they have symptoms of spinal stenosis, and we wonder why, and all we have is an MRI of them taking supine. Oh, let me make you comfortable. Let's put something under your knees. Let's give you a little bit of flexion, get rid of all of that stenosis and the secondary signs so nobody trying to treat your stenosis can actually see it. And that's something that really you can only see with stabilization tools with flexion extension. I mean, I have this tool available to me now, and I was blind before, but now I see. It's really interesting. So Dr. Stevens is going to demonstrate minimally invasive tenotomy, and that is good stuff. So Dr. Stevens, just let us know when you're ready. As we wait for him to wire up, anybody else have any questions or comments? Snide remarks? Self-aggrandizing statements disguised as a question? Well, in my opinion. Seth, you have a question back there? Absolutely. Okay, I just wondered about this, checking with you. you're sitting next to Poser, he always has a bunch of questions he wants.
Just waiting for them, I'm ready.
He usually suppresses it.
Can you guys hear me?
Yes, loud and clear.
So a lot of things have happened today I didn't expect. One being hearing Doug Beal quote the Bible. Very impressive, Doug. I think that's awesome. But I'm also going to take one of your quotes and I'm going to add something to that right now. We talked about magic, and it was kyphoplasty and whatever the other thing was.
Magic, miracles, and kyphoplasty.
Miracles and kyphoplasty. So I'm going to add something to that, and that's TenJet. And the reason I'm going to add that to it is because what I'm about to show you, and by the way, I feel like I want to run through a brick wall and start doing pumps after your lecture, but I think after this lecture, if everybody in the room doesn't see that this is something they could start doing tomorrow, then I didn't, that I failed you and didn't present it well. But I started doing something called 10X multiple years ago. And 10X was a dissection of the soft tissue using ultrasound, and it was good. And some of you may be doing that now. And I had pretty good results with it, but there were a few things that I thought we needed to tweak, and so I started working a little bit along with the people from Hydrocision to make some adjustments to make what I thought would be a better device. And what you'll see today is what has been born through their previous spine jet that they were using for percutaneous discectomy is now being used for this. So the reason I say I add myself to those miracles and the kyphoplasties is because every time I do a TenJet, I'm amazed. And what I mean by that is that it's a very simple procedure that can be done very quickly and reproducibly. My part in the OR is about 5 minutes, and the patients get dramatically better fast, and the reimbursement is good, and everybody wins, because this is something that is done by very few people, and I don't know why that is. It really is a mystery of pain to me why people don't do this, because if you really want to differentiate yourself, like I said earlier today, from other pain doctors, do some of the extremity work, do some of the things other people aren't doing. And the number one things we're doing with this is a bunch of tendons that people come in with on a regular basis. I'm going to start with the shoulder. The shoulder is probably the newest addition to my practice, but I see rotator cuff pathology every day. And what you'll notice is that our colleagues in orthopedic surgery, if somebody has a partial supraspinatus tear, like an interstitial tear along the tendon, or if they have some tendinosis, they're not really prone to wanting to go take that to the OR, because the outcomes are not going to be favorable, or they may not change, and they may even worsen. So those are getting sent to me for a TenJet. And the TenJet, like I said, is about 5 or 7 minutes of work, and the patients are coming back very happy within a couple weeks. Another one that I do on a regular basis is a lateral epicondyle. If you want to do mine later, anybody who thinks they catch this lab and understands how to do it, both of mine need to be worked on. So lateral epicondyle is the second one. What about the gluteus minimus and medius tendons? If you have a person that's getting recurrent problems with their greater trochanteric bursa, and you just keep doing injections, they get about 3 weeks and then they're back again. Yeah, those people are tough patients. So what you do is you come in and you look with an MRI and you go, oh, there's the problem. They have some tendinosis or partial tearing of their minimus and medius tendons from their glutes. And that is what needs to be addressed. So if you go and do a percutaneous tenotomy of the gluteus tendons, they have tremendous results. What about hamstring tears? Who hasn't torn their hamstring in here, right? Hamstrings heal by scarring against the ischial tuberosity. And so that insertional hamstring pain is an ongoing pain that I've dealt with, and this is a great treatment for that. Got a patient I saw last week who's a young kid with a partial patellar tendon tear. Great treatment for that. Quadricep tendon, also same thing. We're going to show you the Achilles tendon here in just a second, and plantar fascia. So where there's a tendon, there's a TenJet. And where there's a TenJet user, there's happy patients. So I just want to show you a couple things. One of the things we were able to do by using this water jet technology is set this up to a certain station with our little console behind me to a place where we would break up the type 3 collagen, the unhealthy collagen, and leave type 1 collagen alone. So that makes it so that you can, with confidence, go in and out of your tendon and not worry about addressing the area you're working on, causing damage to pre-existing injuries. So, however, that said, whenever I come in, oh, by the way, if you don't know how to use an ultrasound, you should. ultrasounds are, I have one in my bag, I carry one with me everywhere, and it gives me a lot of diagnostic information for patients. I can show them their rotator cuff tears, their tears of their gluteus tendons right in the office, right when they're there in front of me, and it's very easy for them to see, oh, that area has a black hole and that area has white striations. The black hole is bad, white striations good. It's really that simple. So if you don't use ultrasound very much, essentially all you really need to know is that there's a little notch on the top that shows you the directionality. You place this onto the tissue, and I know this is small here, so I apologize. But if you can see here, this is the Achilles tendon coming down here, and it's a little bit bright up there for you, but it comes down here and then it attaches right here to the calcaneus. So all you do is you take this little water jet, which I've already put near the space, and you can see it causing that movement. So with this, it's a little bit hard to do the angle you need to if you come from the other length of the probe. And so a lot of times I'll just come out of plane just a little bit and get to the same destination. And you can easily see where the tip is there. You put your foot on the gas pedal and you water jet this for about 5 minutes. And what you'll notice is I'm using the calcaneus as my backdrop. You can see the tissue moving there. And we're just going to do that back and forth, pistoning back and forth, and working on that black area there, that hypoechoic area right up near the calcaneus. This person doesn't have a tremendous amount of hypoechoic area, but all you do is just work through that for about 5 minutes. And once you've done that, you'll see that that area that has that black hole will start to fill with striations again. And it will look much like the tendon that is more proximal here. If you haven't seen, it's a little bit hard and hazy still. This is the first time they've really projected with this, so it's a good learning experience. But you can see there's nice striations in that healthy Achilles tendon, and that's true of all tendons. And so what we want to do is get our tendons back to a status of healthiness. And you can see there's pretty healthy tendon all the way down until I get down to the area, even where I just did. You can see the bright area, which is just the water I've just filled in just now. And if I just keep going, you can see the little TenJet work in that area right there. And I just continually work up and down the hypoechoic area. And I don't think I'm the one moving that. If I am, I'm sorry. But you can see that's all it takes to work on that tendon. So what we've done is we have some good studies. All the studies I've done with this company have been through the lateral epicondyle. And what we were able to show with about 36 patients, not a big number, but we took myself and 3 other providers, another guy from Michigan and some others, and what we did is we took tears that were up to an 80 or so % tear of the common extensor tendon, and we showed after a TenJet with no other added device, no added PRP or BMAC or amnio or anything else, just the TenJet. We brought people back at 1 month, 3 months, 6 months, and 12 months. And what we found is that by the 3rd month, the tissue that we worked on, you can see how the water jet is filling in that void. So you get a pretty good idea when you're doing your procedure that you're filling in that void already. But what you would see at the 6-month mark, or maybe even the 3-month mark, is you'd start to see those striations return to the tendon. Why is all this working like magic or like just voodoo? And the reason is simple. It's an orthopedic principle that we've done for a long time. Whenever you have a osteochondral defect of your medial tibial plateau or your lateral femoral condyle, what do? You micro-traumatize, you micro-fracture around it. And orthopedic surgeons know this, Neil's in the room, he knows this. You go and you micro-traumatize all around that fracture to increase the blood flow back to that defect, and it will heal. This is the same concept. We're micro-traumatizing the tendon by using this water jet, and by doing that, we're increasing a hyperemic response to the tendon, and it's just, like I said, it's like voodoo and magic. It heals like very, very rapidly, very, very well. And I always wonder why people don't do this. I mean, it's this simple. If I'm looking at my own elbow, it's a little bit hard to get a good picture without enough gel. So what you'll notice is all you have to do is just put this down right where the lateral epicondyle is, and it's at the top of the screen. I don't know if you guys can lower it a little, not, but you can see the bright white is the lateral epicondyle, and you can see that the tissue that's in front of it is it had to be lowered on this screen. I'm not familiar with this ultrasound machine, but you can see that there's a a defect right in my common extensor tendon, right where it attaches to the lateral epicondyle. So you can very easily acquire the skills you need to be able to do this on an ongoing basis. And again, having your own ultrasound, I can show you mine if you want to. Mine is made by GE. It's called the V-Scan. And what it does is it's a Bluetooth that connects to my little iPad. And I don't have to worry with all these cords. I don't mind sharing with you guys. I'm getting to know you guys today. But during graduate school, before I went to medical school, I was a vascular technician in San Antonio. And I worked as a vascular tech, and they called me Doppler boy. And I think they were making fun of me probably, but what they didn't make fun of me at all when it was 11 o'clock on a Friday and they couldn't get access to a vena cava, a vein they wanted to get access to with their interventions, and they needed me to go back and show them right where that vein was. Or, we did a lot of graft work for people that were going to go on for carotid endarterectomy. I would show and draw the plaque in the external and internal carotid artery for the surgeon, and we'd go operate with him and actually help him with the surgery without having to do any kind of arteriography for that surgeon particularly. So vascular is in my past. We had a device called an Accuson, which was about 6 foot by 4 foot that I drove all around the hospital. And I'm sure I looked pretty nerdy, but the fact is I was pretty helpful. I got picked first on every team because all the surgery, residents loved me. But the fact is, it has come down to just being able to use that one the little wand that is Bluetooth and no cords. The cords do get a little bit cumbersome, but if you haven't really taken out an ultrasound and worked with it just a little bit, you just start and try these things. You'll see all you have to really do is put this right down where the bone interfaces with the tendon. And that's where as you understand, biomechanics, that's where the greatest amount of stress is. And so that's what we'll see. So we have a little orange here. I don't know if you guys can zoom in on the orange, but I'm going to hydrocision the orange just a little bit. And what you'll notice is as I hydrocision the orange, it starts to take in, you can kind of see, I don't know if you can show my tube, if you can show my tube. Come back a little further, come back a little further yet. Can you see all that action going on in the tube? This is taking all the pulp out of this, but what I can tell you is that even though I'm pushing right up against the other side of the orange, it's not affecting the tissue other than the pulp, because again, we selectively set this up so it will debride the tendon that we want to debride without having any other problems. If you think about somebody who has calcific tendinopathy of their rotator cuff, it seems like a really daunting looking picture, or myositis ossificans of a muscle after a football player or somebody who takes a big shot to the quad, and then they get this big old bruise that becomes a bony protuberance in the muscle and soft tissue. It becomes very painful. This can break that up. So same thing here. We've got some toothpaste at the bottom here, and you'll see that this just breaks right through the toothpaste. See it sucking that up? So I've done this on cadavers, and it's remarkable that those really obnoxious looking bony little lesions inside of the supraspinatus tendon will break up that easily. So a lot of the surgeons will send them to us for when they think that's the cause of their pain. Those are our tricks and trades. I don't know if you guys can see behind me. This is the console here. And Marcy, would you just take a little second? This is Marcy. She came to represent Hydrocision, which we appreciate. Would you just give us a little bit of the rundown of how this the console works?
This is the pump apparatus. It's ejecting 14,000 PSI through the bottom lumen into a top lumen with a window created of Venturi suction. So as we're up against that type 3 hypoechoic tissue, it will just suck it in and remove it from the body.
Do you guys hear all that? We're coming through. So when it comes to tendon issues in your practice, again, partial tears are okay. Obviously, full thickness tears. There's a guy that plays for the Celtics that tore his Achilles tendon the other night, and Tatum's really gonna hurt their chances of winning the championship. But a full rupture of the Achilles obviously is a surgical emergency, or a surgical urgency at least. But even a partial tendon injury to a distance runner, I get those patients sent to me, and all of them want to try this before they have any surgery. So we get a lot of podiatry referrals. Again, today we're talking about how do you build bridges with other specialties. If you want to find people that will be loyal to you, get a group of podiatrists that send to you, again, for things you can do with either the peripheral stem or on the tendons, and those people will be loyalty for life. And so I think that's really important. Could you guys hear Marcy talking about this? And so basically, you don't need many supplies. Most of this comes in their kit. The console you need and a bag of saline. Am I missing anything? Everything else comes in their kit, literally. And so it's a very easy, disposable. I've done these in my office. I've done them in my home. I've done them, that's not advisable, by the way. I've done them in the OR. And so again, if you leave here today and you didn't decide you want to run through walls and go start doing pumps and you want to start doing TenJet, then I don't think you listened to any of these lectures today. So that's all I really prepared because it is that simple. Don't be afraid of the ultrasound. Learn how to use it. It's very simple. Let's open up for questions.
So I find it really helpful for areas of tendons that have hypoxic tendinopathy, Achilles, patellar tendon, extensor tendon, and as you mentioned, Chad, the aspiration of the hydroxyapatite deposition disease in the hip and in the shoulder really helps. Question?
If it's a weight-bearing tendon like the Achilles, after you do it, do you have them on precautions for like a week or two, or what?
Absolutely, absolutely. I'm glad you mentioned that. So Achilles tendon, quadricep and patellar tendon, and hamstring tendon, we do want to give you precautions. And essentially, everything we do on the foot and ankle, we usually put them into a 3D boot for 2 to 4 weeks and have them walk in that, avoid running. If we do a quadricep or patellar tendon, I usually will put them in a knee brace and lock it short of extension so they never fire their quad completely, and they're just doing partial contracture as they walk. And I don't return people back to their running sport with any of those high tensile tendons for probably at least 6 weeks to 8 weeks. But compared to, I don't know if you've been listening to the news, but I mean, what happened to Tatum is going to put him out for the rest of this year and probably a good part of next year, right? We learned that from Aaron Rodgers. He came back after an Achilles rupture, but an Achilles rupture to an athlete, I mean, it happened to years ago. Michael, I'm blanking on Michael's name, that played for Texas Tech, and he went on and played in San Francisco. But when he tore his Achilles tendon, I went out to Santa Clara and did all of his pain management for the next 6 weeks. Every weekend I went out and helped him with his pain management. And the Achilles rupture to a wide receiver is a death sentence. To a jump shooter is a death sentence. And so if you're a person that has seen that over and over and over, and you have a partial tear of your Achilles, you're gonna always wanna give something a try. Again, what we're talking about today is not always the common pathway, but it may be that it's a procedure that doesn't burn any bridges, and if it works, then it's great. If it doesn't, you still haven't burned any bridges, you can still do the surgery. But I will tell you, in that study we did with about 36 elbows, one of mine went on to have an open procedure. And if you're a bag thrower at American Airlines and you can't throw a bag for 3 to 6 months, you're out of business. Right? But those patients can go back to throw in a bag or play I mean, there's a sport called pickleball that all my patients play, and I'm so thankful. I was talking to one of the reps last night from Medtronic about, I'm so thankful for CrossFit, and I'm so thankful for pickleball, because when business is getting a little slow, I just go put an advertisement on the wall at those places, and all of a sudden business isn't slow anymore. And so all kidding aside, those are patients that are going to have a lot of tennis elbow. And we have a lot of people that play a lot of tennis in my area, and we'll have them back playing tennis in about 3 weeks. And so if you can take people, get them back to what they love, and I know it sounds silly. I've got a 71-year-old guy who is playing pickleball 3 times a week, plays golf 4 times a week, and is on 3 softball teams. And he came into me for his tendonitis of his tricep tendon. I'm going to go do his tricep tendon. You know, I sent him to an elbow surgeon who's the TCU team doctor, and he sent him back to me. He goes, "Why didn't you do the TenJet?" And I was like, I thought about it, but I thought better of it because I thought maybe this guy would need, you know, a TCU team doc level guy. And he goes, "Do the TenJet. That's what he needs." And so I'm getting a lot of referrals for these from the sports and ortho and podiatry surgeons. And when it comes down to it, I mean, some of us that are more senior here, most of your faculty is pretty senior here. When it comes down to it, referral sources are fickle. If you can find something that people will send to you regularly, because if you can program then, oh, tendon problems, Stevens. Oh, peripheral nerve, Stevens. And then it's not like just putting it out to whoever, whatever pain partner in the community can help them. You really want to get those niches. I think TenJet is one of the best niches you can find. I don't know why everybody, remember Doug, when I came to Oklahoma City, we did one together?
Yes.
And you've done several since then?
Yeah.
Doug had me come to to Oklahoma City, and I don't think I said a word. I think I just watched him do it because he didn't need any help. But the point was, it's a application for a problem that we all see every day. Like Doug said earlier, you may have not seen it, but it's seen you. This is a prime example of a treatment you have that you can start tomorrow and safely perform. Are there any other questions?
Agreed. Question on the reimbursement, Chad. How does it work? What is it?
Doug, I can kind of hear you said reimbursement question.
So, question on the reimbursement. How does it work and what is it?
I'm glad you asked. So there's a different reimbursement for each code. The code that reimburses the least is, I think, 27006, and I use that for my gluteus tendon. And that is a reasonable, maybe about a $1,300 or $1,400 reimbursement. But when you do the shoulder, which is a 23405, it's more like a 2,300 to 2,500. And like I said, it's about, going back to that slide, can you afford not to do this? I mean, it's for 5 minutes of work for a happy patient and the good reimbursement that you almost can't afford not to do it. You have to, of course, take out the cost of goods, and that's not very variable because it's all disposable. But you look at that delta, and you look about how much time you use the OR and the supplies you use, and it's really not much. It's kind of a no-brainer.
Yeah.
And every one of the codes has a different answer to that, Doug. Plantar fasciitis, lateral condyle, they all make enough to give you a well amount over the cost of goods involved, but they vary in their reimbursement.
Very nice. Thanks, Chad, very much.
All right, you're welcome.
So next up, we'll have Neil Shonert. He's going to talk to us about collaboration and spine care principles from his perspective as an orthopedic spine surgeon. Neil.
So Ben, you got it up?
I got it. Oh, there it is.
There it is. Hallelujah. Let's see which one's going to work. Here we go. Okay. I'm going to speak to you from the experience of collaboration across subspecialties. The surgeons are a fair distance further down the road than you all are. But the opportunities that you all have to catch up in this game are really many. And some of them are really going to be very fruitful if you focus attention on doing it. So what the surgeons are now doing is in spine, they've had a series of successful registries here in Washington State. 3 of them were launched, and the national one, the American Spine Registry that has neurosurgery and orthopedic spine surgery in it, was a copy of our Washington State Registry. Washington State Registry now has somewhere in the area of 45 to 50,000 patients in 2-year surveillance. So, and it's across a series of diagnoses which you all participate in. Hence, it's something that's low-hanging fruit for you. So it's degenerative disc disease, spinal instability, spinal stenosis. The excluded categories, and you'd be wise to exclude yours as well, are trauma. It's highly variable. And tumor. So that also is highly variable. So if you're going to embark easy territory, lumbar spinal stenosis with or without instability, because you have separate ICD-10 codes for them, and you have separate CPT codes for how you will treat it. But if you were to do that, you would be able to compare your impact in the techniques that you've mastered to the surgical techniques, which are in two arenas. They're inpatient, and Doug showed you the reimbursement codes associated with inpatient procedures are substantial. And the ambulatory arena, where many of those surgeries are transitioning. The second arena that orthopedics has done well in is joint replacement. So the American Joint Registry, AJR, has now 4 million patients in surveillance, and the payers are partnering with the American Academy of Orthopedic Surgery to help guide the transition of inpatient procedures to ambulatory settings as a cost control measure, but understanding that the ambulatory arena has to be paid sufficiently for margin. But when you're looking at the cost savings associated with an inpatient procedure, they are so substantial that inappropriately selected patients, that's the way to go. And so the payers, and you are now going to practice in the era of the power of the payer. The payer is going to tell you what will be authorized, not be authorized, how much will be paid, what you won't be paid, what can be used, what cannot be used. And the only way you can take that away is if you have data. And that's a slide about generating collaborative data. And what you notice is the only one of the 5 that is in all capital letters is the most important thing you have to do. You have to own your data. Because if you are working for a health system and they own your data, you don't have control over it. Or if you're working within a closed model, that closed model, Kaiser Group Health, that closed model owns your data. So you want to own your data. The other small steps are starting small, making positive wins, staying on a diet. So if there are 10 metrics out there, start with 3. Make sure you get 100% data capture on those 3. So pain, function, and what was the widget that we were using in this vertebral compression fracture? And then whatever that widget is, how many companies make it? Okay, every one of them. And all you want to do is just check the box of which company you used. And what you'll notice is you'll have massive amounts of data very quickly, especially if all of you join in and do that. Or spinal cord stimulation, classic area. Make sure that you have the same metrics that other non-interventional clinicians use to measure. So, what do surgeons use to measure? We want pain, we want function, we want adverse events. We also pay attention to costs, so we put that down. So just to, went the wrong way. So here's an example of registry being used in general surgery. And they asked the simple question, does a leak test when you do right colon resection, do you do a leak test? Because if you test your anastomosis before you let the patient, all you do is just open the abdomen, do the anastomosis repair, place a rectal tube and blow air onto your anastomosis, fill the belly with water. If you see bubbles come up, just like when you were a kid and you were fixing the flat tire on your bike, that's why there's a bicycle in the background of that slide, is to remind you that you already know how to do this. If there are bubbles coming up from that inner tube, you still have a leak. Got to take the tube, fix it again. If you have bubbles coming up in the abdomen, you have a leak. You trace down to the bubbles, you put a stitch at the bubble, the bubbles stop, you've cured it. If you don't do that, that patient is going to come back to the emergency room, be readmitted to hospital, in sepsis, go to the ICU, and die. So you need 5 metrics in following whether you do or do not do leak testing. You will have similarly 3 or 5 metrics for each of your procedures. And what you'll see is that people who do leak testing, less than half in 2005, down around 40%. And by the time this registry had tracked all of the general surgeons in our state, 100% of them, 6 years later, 100% of them are doing leak testing. And the hundreds of millions of dollars of adverse event management disappeared. The governor gave these surgeons awards for this kind of work. And you can do that. And because it benefits your community, your practice, your subspecialty, and all of your patients, it's a really smart thing to do. So let me see if I can, here we go. Oh, this is it in spine. When you do it in spine, this is when the registry had 27,000 patients in it. We selected 1,536 of the 27,000 because we wanted complete data sets. So you got to have complete data sets. Small thing, but in medicine, a complete data set is much more powerful than a massive data set that has 40% missing data. A complete data set is important. What we were able to do is we were able to predict. So this is a JAMA article showing you, I can predict the outcome of your spine surgery or your spine surgery or your spine surgery before I operate on you. And in this particular instance, what you see is we developed a computer module that you can use in the office. As you can see here, this patient has a 13%, the histogram, the gray histogram on the side, on the right, has a 13% likelihood of success. And here on this are also listed the metrics you should use in any registry that you developed. And you'll see that they're very easy metrics to use. Mr. Pointer, there we go. Okay, first age, that's a pretty simple thing to do. Sex, that's a pretty simple thing to do. Always remember to know your insurance type, because what this predictive paper published was that the Medicaid population and the L&I population had a 17% predictive deterioration in potential outcomes, no matter which surgeon or what procedure was done. The head of labor and industry called me and asked, Neil, why are you, this is recorded, right? So he made a derogatory comment about the paper. And why are you, calling me out? And I said, well, you should look in the mirror in the morning because you're the responsible person who has caused this deterioration in outcome. It's associated with your payer system. That means it's your baby. That means it's your fault. It's not the fault of the surgeons. And I didn't go through the list of the surgeons who were on the paper, but they're all the cream of the crop in the state of Washington. Whether in university or whether in this facility, these guys right here, or community or other health systems, all of the best surgeons were on there. And what it showed is the surgeons don't have a difference in outcomes. The types of patients cause the difference in outcomes. So when you look at this, it does matter your age, it does matter your payer status, who are they? And then importantly, under these diagnoses are listed here, but I don't know why they're not showing up, are things like, is it a virgin or a revision procedure? That's important. Is the patient on narcotics or not? That is important. Does the patient smoke or not? If you're walking into the effusion arena, you need to pay attention to that. Is there a comorbidity associated with abnormal healing, diabetic? You need to know that because it impacts. And so what ended up happening is the reason that this patient has a 13% likelihood and everybody else has a 64% likelihood is because of success, is because their comorbidities, you heard Doug mention to you the importance of comorbidities. The comorbidity, we call them modifiable factors, but the comorbidities are important. So whenever you build your tools, you have to include these. And then how severe? If somebody's got a 5 out of 10 pain scale and they only get low back pain when they're carrying a case of beer out of the AMPM market, but they don't have sleep disruption, they don't have 8 or 9 out of 10. I didn't put the function scale ODI or NDI or Promise 10, whichever one you want to use. They all work. These are impactful for predicting. And if you know the predicted outcome of your patient before you treat it, and you have a whole series of colleagues who are collecting that similar data, so you, instead of waiting for the 400th patient in your practice, within 6 to 8 weeks, you have more than 400 patients across all of the practices that are involved in the registry, Very quickly, you get into thousands in your N number. You get up to the 5,000 level, you're now in trending. That's the territory where you can take your data to the insurance company and say, these are the trends, and when we take these numbers into the 20s, 30s, and 50,000 patients who have had these procedures, you're going to be able to predict their outcomes and the costs associated with it. It's huge. It's huge. And I'll go back to this one. This is the world's largest vertebral compression fracture registry. Some of the folks that are in this room here teaching you are co-authors on this paper. And what this shows is that you can have reliable safety. Kyphoplasty has an adverse events associated with the procedure, not associated with the age of the patient. You know, some of these elderly folks are going to have their own, but associated with the procedure, it's a very safe procedure. Very safe procedure. Combined adverse events, even though cement leakage is not a problem, you need to pay attention to it because it's giving you a clue about the personality of the fracture. If the personality of the fracture is cement wants to leak out to the right, to the left, to the front, it's also going to want to leak out to the back. And that is, alarm bells need to go off associated with that. But you have remarkable deltas in pain and function, meaning this is highly successful. And there's a vulnerable population of elderly women who benefit from this. The pain scores improvements, that's the upper scale. The function improvements, that's the lower scale, are dramatic, and most importantly, they're sustained. So when you go before a payer and you want to argue for the reimbursement of this or another similar procedure that you've enrolled in registry, this is powerful data. It changed when presented to Medicare Max in 2020, it changed national authorization policy. And authorization is access. If the patient gets authorization, they have access to you. If they don't get authorization, they don't go through your door. So it's important. And then this is, you can promote somebody's interest besides yourself. So this is the patient getting dramatic pain improvement. And what you're seeing here is that the quicker you get to the patient, the less expensive the procedure is. So if you get to see the patient, this is a patient of mine who came in the day she broke her bone, was fixed the day she broke her spine. And this is a patient who came into my practice 6 months later. Notice the tripling of costs. And you can relay that to the payer because they're the ones who are hemorrhaging that cost. They're paying 3 times as much. And you still have, pain, disability score goes damn near to 0, pain score goes almost to 0. And you notice here that the disability score is 3-fold higher in delayed treatment than it is in acute treatment. So from a payer, especially a national payer, those are higher disability costs. You're going to see that in narcotic use. You're going to see that in disability payments. So it's really impactful. Similar principles were used for a sacroplasty registry, and they showed the same thing. The augmentation is genuinely beneficial. You are going to be competing in your generation with the surgical subspecialists who are now engaged in registry. Then their registry is nationwide, and it has the same power as the statewide registry in Washington State that you saw published in the JAMA article, because they copied and ours is a copy of Peter Fritzell's Swedish spine registry. Peter came here and helped us get that done. And Swiss Spine's got in their 40th, 50th year now. But anyway, these surgical societies have written a consensus letter that basically says we don't think non-surgeons should be doing fusion procedures. And how many fusion devices did you look at this morning? So you are clearly looking at NIMBY, not in my backyard. Instead of collaboration around how do we develop a spectrum of care where we can have lower costs but genuine safe outcomes and catch these patients before they get to the only and inevitable knife as their options, you need to develop registry tools that exactly parallel with the surgeons. So your pain score should be the same. Your dysfunction score or your disability score should be the same. So whether you do NDI or ODI or Promise 10 or should be the same as that are in the publications. Your timelines for treatment, your diagnoses should be the same. So that what you're doing is apples to apples. And you should do the same thing that we did with Medicare, have the cost data. You're already advantaged. Where do you do your procedures? In a low cost, low capital environment. And so you're going to, in the apples to apples comparison over the next decade, the transition to interventional spine treatments are going to be dramatically large. And if you have these measurement tools with significant N numbers within them, you're going to be empowered, remarkably so. So food for thought. When you go into the surgeon's arenas, you have to have an understanding of biomechanics. As you can see, that plane ain't going to fly. And when you're doing heavy lifting, you got to know how to do it and to do it right. So using a registry tool to move graciously and collaboratively into an arena that is shared by many, many physicians with gifted minds and substantial egos, you want to be in a place where you're making your good work known and avoiding difficult circumstances. Those are the registries that I spoke of, the American Spine Registry, the Vertebral Compression Fracture Registry. That's what successful collaboration looks like. And then I'll close with this. In doing registry work, there are essentials. And the most important was the big red one that had all capital letters, own your data. Be in control of your destiny and transparently reporting. The best way to generate trust is to tell the truth frequently, publicly. That's transparent reporting. The Hawthorne effect is really the simplest methodology for demonstrating to humans the goodness of what you do. And Hawthorne is just analogous to taking a flashlight and turning it on in the center of a meth den or opium den. All the cockroaches run to the corners. So when you show your data transparently and just shine a light on it, the goodness of what you do will be evident, and the benefit of what you do will be evident, and the mistakes that are there will be evident, and you simply find the mistakes. So we did this in spine surgery, looking at diabetes management. What's the blood glucose coming in? What's the blood glucose going out of the hospital, not the operating room, of the hospital, so that you don't take a patient with a blood sugar of 800 or 600, 400 or 300 into the operating room. You fix that fixable, modifiable characteristic, you fix that before you go in. You get their temperature right. The antibiotics are given on time. These steps, which are particular to your practices, will be part that you will share and measure amongst all of you, and so that you're all on the same page, same sheet of music, doing the same thing, whether it's in Oklahoma or Arizona or Washington, it doesn't matter. It's the same caliber of care. You'll make sure of that. And then when you publish across subspecialties. So the JAMA paper, orthospine, general surgery, anesthesia, neurosurgery, whole bunch of gifted medical researchers, put them at the front, so that you have a broad collaboration in the author list, because it speaks of collaboration without that word being in the paper. So you've enhanced your relationship by by doing that. And the rest of it is just take the time to do it, because it's going to be, when you're in control of your destiny, you are so much happier than when someone else is telling you what you can and cannot do and why you can and cannot do, and they haven't got a fraction of your education or your dedication to your community. Any questions? I'm done, should be. Yep, I'm done. Thank you, Ben.
Let's go ahead and everybody can change and transition over.
Is it a break? Where's everybody going? Do we have a break? I think they forgot that we have one more live. Do you see what's happening?
We have a. Oh, there's one more. We have one more demo. We have a PS1.
Oh, I should introduce them. My bad.
I think they're in a hurry to get to the lab.
Yeah. My bad.
And no break, guys. We're going to roll it right into peripheral stim.
Yeah, here we go. So Chad Stevens is going to show us peripheral nerve stimulation. And Chad, are you hooked up back there?
I'm ready to go.
All right. All right, there he is. Thank you.
Yeah. I saw everybody trying to leave. I'm like, don't you guys leave so soon. We got more to do here. So, but I know you're getting excited to come back to the lab. I thought I was going to get a chance to do a live presentation of the Liberty Lateral SI system. So make sure you come by that cadaver. You're going to see that it is a very nice, smooth technique that we can easily get one screw into the place and have a good compression right in front of our eyes with 20 millimeters of compression on the wing side and about 15 on the threaded body side. So it's a pretty exciting procedure. I'll kind of break into the next thing here. We talked a little bit about peripheral stimulation earlier. We're going to do a little bit of a sprint presentation. Dr. Harstrom's going to do a little of NALU. And so I'm going to start with just showing you something really simple. I talked about earlier a lot of the indications for this. And remember, we talked about the cluneal nerve and how it's kind of one of those forgotten nerves, right? Like the SI joint, people always forget about the SI joint. This is just as easy to forget about it, but the cluneal nerve presentation is lateral hip and iliac crest pain, and it is very it's hard to distinguish it from other things, so you usually end up doing all the basics. You end up doing an SI joint injection, a greater trochanter, thinking about the glutes, thinking about all these things, but you come back to this. It's a real easy thing to test out by just doing, I just put a needle in here. This is just an easy little block to do. This needle wasn't quite long enough, but as you can see, you just start usually about the lateral border of the transverse process at the level of the iliac crest, use the L4, and just walk right onto the iliac crest and then advance it down just a little bit more laterally. And then I just kind of pull this device out as I go, and I'm giving some Marcaine or lidocaine, whatever I like, and just pull this out, and that's all there is to it. So we do a little trial, they come back, they say they like it. We switch to this one first, right? Yeah. All right. So this is Sprint, and Sprint is a option for, we talked about how there was short-term and long-term stem trials or stem treatments, and this is a 60-day treatment. This device is meant to go onto any nerve. The goal is to get about 1/2 to 1 centimeter from that nerve so that you don't necessarily want to be right on top of it. And again, when you're doing ultrasound, you can easily see, but you want to do a couple things. You want to make sure that these are centimeter marks. You want to make sure you're about 5 centimeters at least under the tissue, and you want to get it within 1/2 to 1 centimeter from the nerve. So I do some of these with fluoro. I do most of them with ultrasound, and you can do a combination of them if you like. But basically, when it comes down to placement, it's pretty easy. You just come in, and I usually start a little bit more medial, but I'm going to start about right here. Image, please. So I'm just going to try to go right down and touch the os right there, which I'm on bone, as you can see, image. And then I'm just going to walk up right over that iliac crest there. Image, please. and just going to try to stay pretty close with touching it by turning the bevel away and just kind of walking it out. Image one more time, please. That looks money. Right there, you're coming right across there. So that's about right where I want to be. Their system is pretty simple. All you have to do is then twist this out with a counterclockwise maneuver. Pull this part out, leave the introducer in, and then this is the introducer that has the lead here. The lead is coming out the end. There's a small little tine on the other side that catches on the soft tissue. And so it's a pretty simple placement when it comes down to it. You're just going to advance this in till you get to the level where it's all the way in, and then just twist it. This is going to be a clockwise twist. Picture, please. And it looks like it's pretty good placement, right? So then all you have to do is we want to kind of remove this whole thing as one device. So you just kind of hold down, give it just a little snug pull, kind of hold some pressure here, and grab this as it comes out. I think I got it. And take a picture. And that would be all you have to do. And you hook this up with a little device here, these little yellow things attached to it. It's a little bit, yeah, why don't you show that real quick here. Come on in and show that. You have a microphone, go for it.
All right, so this is the battery and pulse generator. This would be outside the sterile field. And if this were a real case, Dr. Stevens would string a test cable to me. I'd plug it in to the battery, and then with our handheld remote here, we would confirm sensation with the patient in their area of pain. So we have two settings. We have a 12 hertz motor setting and a 100 hertz sensory setting. Either way, the procedure is the same. Like Dr. Stevens said, 0.5 centimeter to 1 centimeter away, remote to the nerve with our monopolar electrode. Once we've confirmed paresthesia into the patient's area of pain, once that lead has been deployed, just a little drop of dermabond, and then the rep would hook everything up in the post-op area and get the bandage set up, all the cables set up, so all the implanted things are done, obviously under fluoro, and then the rep takes over afterwards to do all the exterior cabling.
So as doctors, all you have to do is what I did. And then what you have to remember is that this is something that's going to be into the patient for 60 days. And so they're going to talk about, maybe when you come to their station, a little bit about like weekly dressing changes and how to keep the skin puncture site from getting infected. But the idea here is it's a 60-day treatment, but after you remove the device, there's residual effect. And you're saying there's up to about 2 years data out there showing that there's residual benefit after you remove the device. Because that's always the question mark, is people say, okay, so do you do this? And we talked about this earlier, and then put, an alu or a Curonics in after that. What they're pretty much promoting here is that their data is showing a residual effect even after the device is removed. And so for our patients, again, that have maybe CRPS, and as we've all seen with just doing a sympathetic block, like a stellate or a sympathetic lumbar block, what happens a lot of times is if you can just interrupt that cycle for a short time, and then you can kind of start over, it's just like recharging your phone after it's been, dead for a while, and then that will give you that residual benefit. It's the same thing with this device, and that's what they're finding in their data. That was presented, I think, at Aspen, was it this past year. So I heard that and I thought that's pretty exciting upcoming work. And so as you can see, this is going to be pretty basic for placing anywhere. That it's not very surgical at all, and it's something that any of you can do starting tomorrow. So do we pull this up? Just give it a little pull out. Anything you want to add to that, Ian?
I would just say that any peripheral nerve that doesn't innervate the face or top of the head is on label, one that you could target. And like I said, that 12 hertz motor stim, that's more for multifidus atrophy or post-stroke subluxation in the axillary deltoid region. Most other nerves would be that 100 hertz sensory. Okay. And that's kind of a really broad indication, which is great.
So no, this is great. So it is one of those things we want our reps to be involved and present. And so it's really helpful to have them here. we're going to go ahead and take advantage of having a local all-star here. Dr. Harstrom is here. She's a local interventional pain specialist who does a lot of NALU. So we're going to share the stage a little bit. And so when it comes to question and answers, you're probably going to have to address it to she or I, or maybe there'll be questions we can both answer. But I want to give her a chance to show you what the placement for the medial branches would look like. So take the stage.
Yeah, thank you so much, Dr.
Sure,
Stevens.
of course.
Hi. So excited to be here. Thank you so much for including me. I want to take a quick opportunity to just talk about the more permanent solution to peripheral nerve stem. And with me today, I have the NALU product. I'm going to show the product here in details. We all get a chance to look at it. So this is the smallest implantable pulse generator on the market. So very, very small, about 1.5 cc in volume, that connects with an external therapy disc, the battery, with a bidirectional type of connection, which is the only one on the market that can actually confirm proper placement over the pulse generator, as well as connecting back to the disc. So patient is always getting the predicted and set outcome of the stimulation. So different than the Sprint system, we actually have a trial for this type of implantable device. So with a trial, we usually use a temporary 8-contact lead. I don't know if we can zoom in on that. And for the permanent placement, we have a timed 4-contact lead. So a little bit shorter. For different targets, usually, if I did like a cluneal nerve implant, like Dr. Stevens just demonstrated, I would use still my 8-contact lead because it has a little bit better range as we program around an area where we have nerves kind of running in a different course. And then for most implants, I would use this type of timed system. So to start off with, when we do medial branches targets, we're looking for that typical facetogenic pain patient. Same patient you would do your every 6-month or 12-month radiofrequency ablation procedure on. So many of these patients that would be good candidates for stimulation would also already be in your practice, and the patient you've been repeatedly doing RFAs on for a long period of time. So that's what I found in my own practice, that I have patients with diminished response, or they get fatigued from repeating the same procedure over and over again, and they come in for a more permanent solution, and that's what I can present today. So when we talk about facetogenic pain, again, we talk often about the lumbar branches. We usually target the L2 medial branch for this procedure, and we do so over the L3 vertebral area, and the target is the transverse process as it connects with the SAP, just as we would do in a radiofrequency ablation. So let's find that. And before I do any procedure, of course, patient selection is important. I look for that typical facetogenic posterior column patient pain pattern with positive KEMPs on exam, maybe some facetogenic facetoarthropathy on imaging as well. Let's find L3. So we can go up. We're going to square off those end plates as well, and we're going to target. Let's pick the left side here. We're actually going to come AP first. Yep, and just square off the end plates. So let's see where we are at. Can take a picture there. Okay, and then come a little bit towards me. Picture there.
If you think of anything I didn't say,
Okay.
have a second on the mic here.
And it looks like we already have a little bit of a caudal tilt. Can you just move the whole C-arm this way? Thank you.
We've all been kypher.
Yeah, I know.
Kyphoplasty.
Yeah, and I mean, that's what's so beautiful about peripheral nerve stimulation. You know, it kind of works for any type of pain. You know, patients that have anterior column pain will more or less always develop some posterior element to pain as well, whether that is from, you know, micro movements or trauma to the facet joints. So it works really well for all kinds of patients. Okay, can take a picture. 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 So come out of that oblique just a little bit. Picture again. All right, there we go. Picture. Picture. Okay. Picture. So what I'm doing here is I'm touching down on the transverse process, and then I just want to give it a little bit of a tilt and walk right off that process. Take a look there and take a lateral view now. Okay, picture there. Perfect. A little deeper. So as we can see, we have that needle resting nicely on top of the transverse process. Trying to advance the lead here. Can you give me another picture there? All right, so the target here is to be just about 50%. You don't want to be too close to the vertebral body, but just about transecting about 50%. So we'll take another picture, just about there. And of course, we're not going to go into the neuroforamen at this point. Can you go live here? So here I'm positioning my lead as I'm pulling back on the needle. Okay, picture again. Picture. Done. That's a trial. So now I connect with an external stimulator system that my rep has in place. You can do different kind of testings here if you want to check for multifidus activation, a low motor stim at 2 Hertz, or you can go a little bit higher and asking the patient where, if they feel the pain in that area that they normally have pain. The referred pain from facetogenic pain is often extending not only over the lumbar spine, but also over the buttocks and the thighs to some degree. So I usually look for that type of referred pain distribution before I'm satisfied with my placement. But this is pretty much what a trial would look like. So yeah. And then of course, the implant will be placed in the same location, but with 4 contacts instead, and the tined leads to prevent the lead from migrating forward.
So there is to it?
Yeah, pretty simple.
Okay.
That's so if you compare, I would say, spinal cord stimulation, for example, with something like peripheral nerve stimulation, it's much more forgiving. You can be further away from the target than what we see in this imaging here. Can we go back to an AP also, by the way, to get a full assessment? But you can definitely be further away from your target. There's so many types of variations in the stimulation and how they can disperse the current around the contacts, pairing with different type of stimulation bursts. There's all kinds of measures or pulse widths to add to the equation to get really good coverage over the peripheral nerve, which can be a little more challenging with spinal cord stimulation. So,
All right, good. Yeah.
Yeah.
So here at Seattle Science Foundation, when you come as an observer, be ready to lecture, is that right? In the
Yeah,
future?
apparently. You
Yeah.
can't just be participating here. You get
You know, I
dragons.
really do love this because some of us have had time to mentally prepare for this and to, last night before you go to bed, kind of visualize, what you're going to do when you get to the golf course and play the course. But being able to, on the fly, come in and present well is very impressive. But I think that's also something we all need to be ready to do. If we are real advocates for the procedures and the patients we protect and we treat, we need to be able to promote that and to teach other people why we think it's so grand and why we think it's so important. So I think it's great that you came in, and I appreciate your help very much.
Thank you so much.
Does anybody out there have any questions for she or I?
What is the length of the trial that you just placed?
The
So-
Nalu?
The time for the trial, duration of the
So I used 7 days, just like I would do with a spinal cord stimulator. I sometimes extend it a bit longer. What happens occasionally, especially with a nerve target like this, that you have actually some advancement of the leads, bring the patient back, we adjust the lead placement, give them a couple more days with new programs, new contact programs, et cetera, and usually find the correct target. You're not gonna see much lead migration with the timed leads, but the trial leads is a little bit more challenging to work with.
Okay, well done, you guys, very well done.
Hey, Doug,
Promptu, well
before we
done.
break from here, let me just say, I know we're going to get a chance to tell everybody thank you later, but
Questions, maybe?
the staff in here that has been supporting us has taken a bunch of clumsy physicians and made us all look great. And so I want to thank the radiology staff and the support staff and assistants here, because really and truly, we just literally walk in here and do our craft. And that's kind of what it's like in the OR. We walk in, everything's set up for us, and it's really nice to be here and not have to be, moving the cadavers ourselves and everything else. So when you come in here, make sure as participants, you thank them for spending here all day. And now we're about to start the part of the process where you guys are in here as well. But make sure you thank the people that have been working all day long. And I want to also thank Corey Kepler for putting on such a great course. If I don't get a chance to thank her lately, it's been a lot of fun.
Well said, Chad. Thanks to the staff. Thanks to Corey, and we will transition now into the lab.
You're welcome.